सारे टेबल एक हाँ यार दिखा ना तो अबे यार मेरे को नहीं दिखा उसने मेरे को वाइट वाला बॉक्स दिखा उसने हाँ ला ले अभी ला ले वही ला ले और वो आगे का स्क्रीन में डालना पड़ेगा आगे कार्ड कौन सा लगा कौन सा वाइट वाला पीछे लाल वो कौन सा वाइट वाला बड़ा वाला ना बड़ा वाला डब्बा नहीं है नहीं वो यस वो लगा एक्टिव ब्लैक वाला भी ला ले वाइट वाला भी ला ले हाँ ला ले यहाँ वाला वाइट बैठने में ला हाँ अरे मेरे को कनेक्ट हो गया तेरे हाँ हाँ अभी इसी बात करेंगे अरे वो माइक का भैया आवाज नहीं आता है करना आवाज आता है तो आवाज ऐसा गेट तो जस्ट बैठ के आवाज ना होता है फिर तो काम आएगा फिर तुमने पीछे तो रिटर्न करना पड़ेगा रिटर्न करने की तो भाई सब बंद करेंगे सीखे ना चीज में कैसा है वही तो प्रॉब्लम है नहीं तो उसमें क्या होता रिकॉर्डिंग में नहीं मिलेगी ना अपने रिकॉर्डिंग में नहीं है कैसा होता है आज मैं देखा से वो इसमें कुछ प्रॉब्लम है तो ना तो अगर थ्री थ्री दिखा वो तो दूसरा लेक्चर जब चलेगा वो आने वाला था तो आए ठीक है हो गया और क्या है क्यों हो रहा है ऐसा क्यों हो रहा है सेलेक्ट कर एक बार हुआ इस दिन की पर सेलेक्ट कर इस बार क्यों हो रहा है सेलेक्ट कर तो ये हमसे क्या आता है ठीक है तभी मारा तभी मारा ये तो जंगल की हुआ है ऐसा लग रहा है डायरेक्ट लगाना था कुछ नहीं लेना वो लगाना बड़ी होगी यहाँ से वहां तक इसमें वो और नशो का रिकॉर्डिंग में इसको छोड़ेंगे तो इसके लिए रिकॉर्डिंग में ठीक नहीं तो होना चाहिए अभी समय प्राइस एकच आहे ना लोकल एक डायरेक्ट ठीक आहे आपण इसको आउट मला कॅमेरा या बॅगचा कॅमेरा देखील मी बॅग दे ना मी जरा कॅमेरा काय दाखवणार मला कामाला काम बोलतो डायरेक्ट आपने क्या यार इधर आना ओके मतलब देख तो देखा नहीं स्क्रीन चेंज मत करो क्या हो ओके आउटपुट कशाने कमी माझं पहिल्या दिवशी माझं पण थोडं त्या दिवशी मुलं आहे ना घ्या ना सेंटर बघा बघतो मी तर मालूम नाही तुमचं ते पण उतारलं म्हणजे कोणाला दोनाला तो पण सर्विस आणि वो बजा वाला तो क्या नाम है दादा सर 2 मिनिट बोल दे अरे अरे हेलो 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 मेरी आवाज आ रही है ठीक है बराबर आ रही ना तेरे को आ रही कि नहीं क्या आ रही है आवाज ठीक है आ जा चालू करू. कुठे गेलो? कुठे गेलो? हे वळलं तुम्ही. याला लाईट वाल्याला सांगा मधून. काय आहे का मग काय? हा, शिव्या. हा, पॉईंट कर ना. काय राहायचं काय? ओके. सॉरी. कॅमेराला तर बघा ना. माझं पण आपण नातेवाईक गेलो तेव्हा आम्ही गेलो. माझं काम शॉर्ट झालं. पहिल्या काय केलं काय म्हणतात तुम्हाला त्याचा खूप बेकार होतं. तुम्हाला ज्याच्या मॅडमचा सांगायचं त्या उर्वशी मॅडम आहे ना त्यांना आडवाच येऊन बोलायचे. आपण नाही 4K इनपुट, आउटपुट भी 4K।
Hey, hello, hello, hello.
So, with this very brief invocation, let's declare the meeting open with the lighting of the lamp. I would request, all the colleagues seated in front row, Dr. Ashutosh Kothari, Dr. Rajan Badave, Professor Ganant, Dr. Sevanthi Limay, uh, Professor Philip Hawkins to come. To the lighting of the lamp. It was necessary that we revisit this and see whether micromanagement
To spread the light of knowledge. The way a team plays as a whole determines.
to the page. Partial mastectomy and would have been of no clinical consequence to the.
I don't think it's just because we can do it. Particularly, I also, John has mentioned that it's not for radiation therapy.
No, it's not that. They will come back. They will come back for radiation. But for us to make a general statement now and say that every patient who has a DCIS, I will stop doing sentinel node biopsy is not
Do your
appropriate.
patient get routine ultrasound?
For many from the audience. So can somebody does somebody have a question? I just wanted to know because it's a very large.
weekend Vidarthi. Throughout the day. Dr. Nitesh only. Finally, आप कल क्यों नहीं आए? थोड़ा प्रॉब्लम हो गया. Uncle, my person who covers he had to be somewhere. That's why. So, sorry. Oh, okay. But we must see just why honestly, last day, I think it was trying to put together on the last day. But it looked like a reverse. It came through. That's how I don't have, I haven't touched it. See, I was down. See, particularly, what I tell you. No, see, I don't know. Change, because she was coming early, so they have to change their way. I was surprised actually how did it turn out. So whenever the you've seen whenever the content is there, it's worked out right. Whenever content is done by the time it means it gets work. It's the whole it's the way still. At Sunday it's been local. Window last evening. Would be surprised. I'm seeing that we can go to an after or a relatively small room or something. I was running so high. Then I think so how is that maybe I did well, very well. She said that it was very sad. It's been better. I haven't still started medium one. I'm more than to start. Not even close to full up. I thought you also asked to give me that. No? Yeah, okay. So you tell me. Yeah, ma'am. Just want you to somebody. Yeah, he's online. He'll come later. Later, yeah. So we have to keep his last format. So after since for all these is here, Alistair Whitney is also there. And we will check that. No, we will want it. What that's the first. So I think
Good morning, welcome. That's all. From Delhi. Excellent. I've done an extra talk this morning. Oh, you've done it, super. So you've learned. How good. Good. I requested at the dinner. I'm late now last night. You requested this dinner. It won't be quite as polished as it should be. Absolutely. It doesn't have to be polished. I could just talk to you about a sick. It was not taught in that space. You know, I would stand up and ask a few questions and you will answer. But then there's a perfect is there. Oh, I'm like super. Yeah.
A very good morning, ladies and gentlemen. We are about to begin shortly. May I request you all to please be seated and organize ourselves. A very happy Sunday morning. After last night's grand feast and gala dinner, it's heartening to see you all leave the comfort of your bed on a Sunday morning and join us here. Today's theme is common stream, including all subspecialties. May I request you all to please put your mobile phones on silent mode before we begin our session? So, our first session is about advanced stage for breast cancer. And to chair this session, I would like to call upon Dr. Shona Nag, who's a consultant medical oncologist specializing in breast, cervical, and ovarian cancer. She's the director of oncology at Sahyadri Group of Hospitals in Pune. Let me remind the speakers we've got 4 lectures, 10 minutes each, and that will be followed by question and answers at the end for 5 minutes and pearls with chair. You can post your questions in the app and we'll take them up at the end of the session. Our first speaker is Dr. Shalaka Joshi, who's professor and consultant surgeon at Tata Memorial Center, Mumbai. And she will be talking about management of oligometastatic disease. Thank you.
Thank you, ma'am. Thank you, organizers, for having me here on a Sunday morning. Let's play the slides. Right. So we know we can see. Yeah, that's good. I'll try to finish before that. So we have breast cancer at metastatic at presentation is fortunately 5 to 10% and not a lot. But a lot of even early breast cancer patients relapse within 10 years, almost 20 to 30%. 10 to 20% of all these metastatic breast cancers are actually oligometastatic. And with increasing use of modern imaging like PET scans and CT scans and other MRIs, there's an increasing burden of identifying oligometastatic disease even when it is asymptomatic. So traditionally, we have treated metastatic breast cancer always with a palliative intent. Oligometastatic breast cancer is a new entity, not so new, maybe introduced almost 30, 35 years ago. I would quickly take you through the rational definition types. Is there a role of surgery? What systemic therapy? And how do we follow up these patients? And what is the duration of maintenance treatment, etc.? But my disclosure at the outset is that I have more questions than answers, and I'm happy if you can answer some of my questions too. And I don't have evidence which is very high level. So we are going to talk about level 3, at best level 2 kind of evidence. So the concept of oligometastatic disease started from lung and sarcomas and from colorectal cancers and liver, where one third patients developed disease either only in the liver or lungs, whether it was a colorectal cancer or sarcoma, depending on that, either in the upfront setting, recurrent setting, or re-recurrent setting. And when operated, they still did well. So 30% 5-year survival was seen even after metastatectomy in this subgroup of patients. And now, across all cancers, we have more effective systemic treatment, targeted treatment. So, metastatic breast cancer, particularly breast cancer patients, especially the HER2 positive ones, are doing quite well. And that leaves us with more oligometastatic or oligoresidual disease. So, do we have any guidelines, or are there any subsets of metastatic breast cancer patients we would optimistically like to tell them that they can be cured? Can we really cure limited metastatic breast cancer? So we also early in our hospital identified an entity of oligometastatic breast cancer where the survival was intermediate between locally advanced breast cancer and polymetastatic disease. So it's a spectrum of clinical behavior depending upon the site and extent of metastatic disease. Hellman and Wishelbaum in 1995 introduced the term oligometastatic disease, and they said that it's not just a stochastic oddity, but it may actually represent a subgroup of metastatic breast cancer which is indolent and which may do well in the long run. So ABC4 and now ABC5 and 6 have also said the same, that they identified oligometastatic disease as low volume metastatic disease with limited number and size of metastatic lesions. 3, 5, 10, we may or may not have a consensus, but up to 5 as per these guidelines, and not necessarily in the same organ, which are potentially amenable for local treatment. And this is the treatment is aimed at achieving a complete remission status, not just in the primary, but also at the metastatic site. So we see them synchronously presenting as upfront metastatic breast cancer or metachronous, that is after treatment, they come up with oligorecurrent disease, or oligoresidual, which is a more debatable but true realistic entity where metastatic breast cancer have very limited residual disease, which is persistent at a metastatic site, and they are called oligoresidual. So we look at the treatment components of OMBC as a systemic treatment, which is the mainstay. The loco-regional treatment, should we be doing or not? And ablation of metastatic site, is it really required? So looking at role of surgery in metastatic breast cancer per se, we earlier had data from a lot of retrospective studies and a meta-analysis of nearly 208 studies which favored surgery. And these studies were, of course, biased because women receiving surgery were younger, fitter, had smaller tumors, they had more ER positive disease, and a lower metastatic burden. There were biases that majority of them were actually just solitary metastatic or oligometastatic. And of course, these studies were retrospective. So the treatment biases and selection biases of patients would obviously play a role. And 75% were almost oligometastatic in the 2013's Harris meta-analysis. We after that had 4 trials of surgery versus not, or loco-regional treatment versus not, in metastatic breast cancer, including the one that we did at Tata Memorial. And most of these, rather 3 of these told us, including the ECOG Acrin, which was the latest to publish, and they said that there is no benefit of loco-regional treatment in metastatic breast cancer in uh, uh, in polymetastatic breast cancer, except for but there was a benefit in loco-regional treatment free survival, loco-regional progression free survival, but there was no overall survival benefit, except for one study, which is a Turkish trial, which actually showed a benefit in survival, in overall survival, and that is a Turkish trial for us, which is largely either solitary or oligometastatic and largely bone disease, which showed a benefit with surgery. So that may actually comprise a group of oligometastatic breast cancer predominantly. Now, there is a lot of literature how it is different at a genetic level, and of course, because of lack of time, I'm not going to go through all. But there have been attempts to characterize this intermediate metastatic phenotype with multiple genomic, transcriptomic, etc. ways, and there seems to be really some segregation on hierarchical clustering of these into the oligometastatic are flocking together versus the polymetastatic. So this may be true even at a genetic level, that we can't put all our eggs in the same basket when it comes to metastatic breast cancer, and there could be really a heterogeneous spectrum of disease. That led us to believe that a selected subset of patients with metastatic breast cancer should be, or I would rather say could be, approached with a curative and not palliative intent. This paper from Japan, which is almost a 30-year experience of oligometastatic breast cancer treatment, they said we treat less than 2 organs, 5 per organ, and less than 5 centimeter in size, each one of them. At a median follow-up of 103 months, they showed a good 10-year overall survival and even estimated a 35% 20-year overall survival. So with that, we have multiple ABC guidelines, these ESMO guidelines, which say that a small but important subset of patients with advanced breast cancer, which is low volume metastatic, also called as oligometastatic, could be treated with a curative intent. And if you heard Dr. Badway's lecture yesterday, I don't have that slide, but the surgery or loco-regional treatment seems to be having an effect on the distant metastasis. Hence, the concept that we should also be ablating the oligometastatic site came into role. So, looking at a few clinical scenarios, this is a very common situation all of us see in the practice where you have lung mets and you have lesions like this. Sometimes they're too small to really even aim them for a guided FNSC or biopsy procedure. So, if something like this, you would likely treat this as a metastatic lung cancer. And then you have certain analysis like retrospective. I said at the outset that I don't have high level evidence. So whatever retrospective prospective data we have, the solitary or the limited lung metastatic disease seems to be having a good DFS and OS 5 year, and the 5 year survival was almost 54%. They also identified a few factors which could be better prognostic, like a disease free interval of more than 36 months. If you are able to do a complete metastatectomy, these were older trials when we did not have the radiation oncologist chipping in for the pulmonary metastasis. And if they were, of course, unilateral or one sided lung mets, and the operative mortality morbidity was not too bad. This is another clinical common scenario that we see is contralateral axillary node or contralateral supraclavicular node. You have your PET CT telling you that there is nothing else anywhere. And again, I don't have high level of evidence. 7 cases in this, 28 cases in this, and an excellent effort of meta-analysis or systematic review in this setting of 24 articles, but still only 48 patients, saying that you could have a reasonable overall and disease-free survival if you operate on the contralateral axilla, and the outcome seems to be better than overtly metastatic disease. And of course, all of us see this very common situation of bone mets, where most common metastatic site in breast cancer is bone, usually in ERPR positive disease. So we know that oligometastatic bone disease or solitary metastatic bone disease has a good outcome. The median progression-free survival is 23 months, and overall 5 year survival could be as high as 50%. And then we have this fancy technique of radiation where we are able to do stereotactic body radiotherapy and blade these completely. So we have the Saber Comet study, which said 1 to 5 metastasis could be treated with stereotactic body radiation, and the survival was better. It was better by almost 26%. And however, they also warned us that there is a significant risk of side effects, so one needs to be careful. And there were 3 deaths in this study in the SBRT group compared with none in the control group. And you could have a worse metastatic situation like the one in the liver. Again, we don't have much data, but we do treat solitary or single or maybe up to 2 or 3 liver metastases with interstitial brachy, radiofrequency ablation, microwave ablation, and multiple other techniques. And we have some retrospective data that may actually help. And this slide from my colleague Reema Pathak, where we are treating even solitary brain mets with fancy radiation. I won't get into the details of radiation. So, what do we do with oligometastatic breast cancer? Do we treat it like metastatic, just do systemic treatment? Do we do locally advanced? Do we treat them like locally advanced breast cancer, or do we go all the way and ablate all the oligometastatic sites? We just were coming to this conclusion that this seems like a good idea until the ASCO 22 told us that the NRG BR002 study told us that there is no benefit in survival, overall survival. In this study of 125 patients, randomized 80% metachronous, less than 4 extracranial sites with control primary, and there was no benefit when metastatic directed treatment was compared to standard of care only systemic treatment. So that leaves us back to what do we do? And then we only have expert consensus guideline. This is the latest I found from 2023, a Canadian guideline where we seem to be having some consensus. Should we give first systemic therapy? Yes, 100% of them agree. This is last slide almost. Should we consider systemic therapy before and after R0 resection? 100% agreed. Should we allow the patients to stop the systemic treatment or continue systemic treatment, most likely, which is anti-HER2 or endocrine treatment? Yes, the most of them did not agree to stop, so we would continue it longer, considering it is metastatic. And how do you follow up these patients? Lung metastasis, 3 monthly CT, PET CT for bone mets, MRI, whatever that the institutional policy is. But we follow them up stringently. Do we have ctDNA or any other marker to kind of guide our treatment? 100% said no. So I think this is 2023 consensus. Most of us may agree with it. And we have a hammer, but although SBRT seems to have given us a bigger hammer, we still have something to learn about how and when to strike the nail. So is oligometastatic all disease the same? We would probably consider all these things to really decide a treatment at a personalized patient level. So my take-home message is you confirm it is OMBC with MRIs, with PET-CT, and whatever fancy imaging that we have. You start with systemic therapy first, which is almost always the norm. Response assessment imaging, of course, and pick up the responders, discuss fight in the MDT, pick up the patients with good ECOG. Obviously, you can't do offer this treatment to very elderly and unfit patients. Discuss with the patient, and if you happen to decide that the intent is going to be curative, then offer local regional treatment in the form of surgery, azure resection, radiation, and ablation of the metastatic site, and keep your fingers crossed. I have more questions and answers, like I said in the beginning, so happy to take some questions if you want.
Excuse me, Dr.
No
Shalaka. We'll
questions.
have the questions at the end of the session, provided we have time. Thank you so much, Dr. Shalaka. Uh, our next topic is management of brain mets systemic perspective. Unfortunately, Dr. Vashisht Maniar, who was supposed to take it, could not make it. So we are highly and extremely grateful to Dr. Alistair Ring, who has agreed at such short notice to prepare this talk. And for those of you who have joined us today, Dr. Alistair Ring is a consultant medical oncologist at the Royal Marsden, and he has special interest in the management of metastatic and early breast cancer and management of cancer in older patients. Over to you, Dr. Ring.
Thank you. Just a disclaimer, my conflict of interest is I wrote this last night after the gala dinner. So when I was asked at midnight to fill in. So it may not be quite as polished as it should be, this presentation. So thank you very much for this invitation. So look, I've actually changed the title. That's my prerogative because I was asked rather late to give this talk. So I've actually changed the title to HER2 positive breast cancer because we all know that patients with HER2 positive breast cancer are at higher risk of brain metastases. These are some data that I was meant to be writing up on the flight over and failed to do so. Essentially, this is a study of 300 patients, just a cohort of patients with HER2 positive metastatic breast cancer at the time of diagnosis. Around 7 or 8% have a diagnosis of brain metastases as a metastatic site. But over the course of 5 years or 5 or 6 years that we followed them up, 20 or 30, well, 30 or 40% of patients subsequently developed brain metastases. And I think that's a lot of what a lot of us recognize. Better systemic therapies controlling extra CNS disease leads to the sort of evolution and becoming apparent brain metastases. Of course, a lot of this depends on how hard you look, whether you do routine MRI scans in patients with advanced HER2 positive disease, or whether you wait for symptoms and then do scans. Irrespective, the number of patients with HER2 positive breast cancer with brain metastases is large. Now, when we're talking about systemic therapy, of course, the challenge is this, the blood-brain barrier, and just in some terms of sort of general principles, we know that when a breast cancer spreads hematogenously to the brain parenchyma, the first step is extravasation, as shown on the top of the slide, extravasation through the capillary wall, and you get perivascular growth. And the point about perivascular growth is the blood-brain barrier remains intact because the tumor, when it's microscopic, doesn't need to really generate its own blood supply to the same extent. So the blood-brain barrier is intact, and to an extent, that's a barrier for systemic therapy access, to an extent. But as the tumor grows, it needs to develop its own vasculature, and we get a sort of breaking down to an extent of the blood-brain barrier, and what's referred to as a blood-tumor barrier, which may be more or less permeable to systemic therapies. So what do we know about what kind of drugs might we use to treat brain metastases in patients with breast cancer, including HER2 positive breast cancer? Well, I guess as general principle, there are 3 groups of drugs we might use. One is chemotherapy, which obviously works intracellularly and may or may not be able to penetrate the blood-brain barrier. We've got the antibody drugs, particularly anti-HER2 therapies, such as pertuzumab and trastuzumab, which are generally, because they are large molecules, historically we have thought do not penetrate the blood-brain barrier. And we've got the small molecule inhibitors of HER2, so drugs like lapatinib, neratinib, tucatinib more recently, which, because they are smaller molecules, we think intuitively might penetrate the blood-brain barrier. So what do we know so far? I haven't referenced all this in the interest of time, but essentially, I think it's fair to say the response rates of HER2 positive breast cancer to standard IV chemo are low. We know that response rates to monoclonal antibodies, trastuzumab and pertuzumab, are low. If you read the published literature, they're said to be up to 10%. So there's a study called Patricia where patients had pertuzumab and very high dose trastuzumab, which reported a response rate of 10%. Personally, I don't think it's 10%. But anyway, some studies in the published literature suggest that. We all have patients who have HER2 positive disease, well-controlled extra CNS disease, and when they relapse with brain metastases, because in general, we regard it as a bit of a sanctuary site and is not preventing, and these drugs do not particularly prevent recurrence. So I think the response rates to monoclonal antibodies are a bit lower than that. And similarly, I think the response rates to what I'm going to call first generation antibody drug conjugates, so drugs like trastuzumab emtansine, are pretty low as well. Again, published literature 10 to 20%. My personal experience is a bit lower than that, but maybe a bit more likely to get responses in patients who've had radiotherapy, which might cause a bit more disruption of the blood-brain barrier as well. But really, I think until about 3 or 4 years ago, we thought responses to chemo, responses to antibody therapy were pretty low. And really what we were using was oral chemo in the form of capecitabine with or without drugs such as lapatinib, a HER2 tyrosine kinase inhibitor. And you can certainly see responses to capecitabine and lapatinib. To be honest, it depends how you define response. There are different ways of defining response. Do you use RECIST criteria, or do you use a Banno criteria, or do you use other criteria that might be, shall we say, more sensitive to pick up a response? So volume change rather than the sort of dimensional changes we use in clinical trials. But the point about all of these responses is, unfortunately, they tend to be pretty short-lived. So, but this is where we were 3 or 4 years ago, even 2 or 3 years ago, I guess. Capecitabine lapatinib or capecitabine neratinib, another oral tyrosine kinase inhibitor. So you could get responses, but unfortunately, for most patients, they didn't last terribly long. And then 2 new developments I'd like to draw your attention to. So HER2 CLIMB was a study in patients with HER2 positive advanced breast cancer, randomized to capecitabine tucatinib, an oral tyrosine kinase inhibitor, and trastuzumab, or capecitabine, trastuzumab, and placebo. The trial was positive. I won't show you that detail, but it did enable patients with brain metastases to enter. And a subsequent publication in the Journal of Clinical Oncology summarized the data in those 291 patients who had brain metastases. And essentially, even in those patients, this is CNS progression-free survival, we can see that clearly capecitabine, tucatinib, and trastuzumab is better than capecitabine and trastuzumab. So clearly there is some activity or additional activity with the addition of drugs like tucatinib. So that's one new option. So some degree for positivity. And then the other thing I'd like to mention is this drug. We spent a lot of time talking about this in the medical oncology session. So Enhertu, or trastuzumab deruxtecan, is an antibody drug conjugate. Essentially, it's an antibody with the same amino acid sequence as trastuzumab. It's got a cleavable linker, and bolted on basically to the antibody is a chemo drug, a topoisomerase inhibitor. I guess what's slightly different about this drug and relevant to this discussion is that the chemo drug, which is an exatecan derivative, is pretty membrane soluble, which has 2 implications. One is it may leak out the cells after it has been released and affect HER2 negative cells. But the other implication, just you might imagine, is that its membrane solubility might enhance penetration of the blood-brain or blood-tumor barrier. So this drug has undergone clinical development. Registration is now licensed on the basis of the Destiny-03 trial. Patients randomized to TDXD or TDM1, Kadcyla. The overall trial was positive, huge benefit in progression-free survival, really impressive results. I'm not going to talk about toxicity today, but of relevance to the talk I'm giving now is that in those patients within that study, Destiny-03, but also some other previous Destiny studies, you could clearly see activity of TDXD over comparator drugs. And in fact, when you look at response rates to TDXD in this waterfall plot, lots of patients on TDXD with brain metastases, these are brain responses, get a response. And that is superior. Shouldn't be making a direct comparison, but these are patients who have a capecitabine, lapatinib, those drugs I mentioned where you can get a response. So these are really impressive responses. And in a couple of dedicated studies, looking at TDXD in patients with brain metastases, you can get really quite impressive intracranial responses. So no longer, I think, can we regard the brain as a complete sanctuary site from systemic therapy. Clearly, there are other local regional therapies and radiotherapy, which we can talk about in a minute, but systemic therapy may have a role to play, particularly in HER2-positive breast cancer. So in summary, patients with HER2-positive breast cancer are high risk of CNS metastases. Response rates to standard IV chemo and, in fact, monoclonal antibodies in general are pretty low in clinical experience, I'd suggest. I think until recently, capecitabine and oral TKIs have been used, and that's certainly what I've been using in clinic. But unfortunately, relatively few patients get a response, and if they do, they're not prolonged. But these combinations, either capecitabine, tucatinib, trastuzumab, or TDXD and HER2, do offer some hope that systemic therapy in HER2-positive breast cancer brain metastases may be something that we can treat. Thank you very much.
Thank you very much, Dr. Alistair, for saving us at the last minute. And it didn't seem like an unpolished talk at all. Thank you very much. Ladies and gentlemen, it's my pleasure to invite our next speaker, Dr. Anushil Munshi, who's a radiation oncologist whose work experiences at Associate Professor, Tata Memorial Hospital, and Director, Fortis Memorial Research Institute, Gurgaon, have transformed him into a prominent radiation oncologist in India. And he's presently the head of the department and consultant radiation oncology sciences with Manipal Hospitals, New Delhi. He will be elaborating on management of brain mets, the radiation oncologist perspective. Over
Good
to you,
morning.
Doctor.
Thank you so much for the kind words. It's going to be a bit of a rapid fire in 10 minutes. So, we already have seen this, the cellular journey from breast to brain. The risk factor for brain metastasis, younger age, poorly differentiated tumor, HER2 positive, more than 4 metastatic nodes. And as we have already heard, HER2 positive is a high risk population for developing brain metastasis, followed by TNBCs and followed by the luminal subtypes. And of course, there are some genetic variations as well that kind of discriminate and tell you to some extent as to who are the subgroup of patients who are likely to develop this, but it's still in evolution. So once a patient has developed brain metastasis, what are the prognostic factors? These include KPS, extracranial metastasis, primary tumor control, age interval between primary diagnosis and breast metastasis, number, size of brain metastasis. And as a subsite, breast may actually be a more favorable subsite in the overall scenario. And different groups and different authors have given disease-specific prognostic index, especially in the case of breast cancer, as you can see, more or less juggling with these items which I've already enumerated, and some have added lymphopenia as well. Now, if I start going into the chronology of the evidence that has evolved for brain metastasis, it's going to take half a day. But in a snapshot, it started from whole brain radiation therapy versus steroid, then whole brain RT versus whole brain RT plus surgery, then surgery versus surgery plus whole brain radiation therapy, whole brain radiation therapy versus whole brain radiation therapy plus radiosurgery versus radiosurgery plus whole brain radiotherapy, surgery versus surgery plus RS, and so on and so forth. It's a very long story how we have reached where we have reached now. Now, for a patient with a solitary lesion and controlled primary, no extracranial disease, things are a bit straightforward. Radiosurgery alone if the lesion is of a reasonable measure. Otherwise, surgery in patients who have especially symptoms of compression, followed by focal SRS or SRT. The other options for these patients include surgery plus whole brain radiation therapy, or radiosurgery plus whole brain RT focal radiosurgery followed by surgery, and so on and so forth. For patients with 2 or more lesions, these are multiple lesions, still surgery could play a role, especially if you have one of these lesions, just one of these lesions, not more, one of these lesions, which is kind of causing compressive symptoms. So you kind of decompress and then take up the radiation part of it, whether by whole brain radiation or focal radiosurgery to these lesions. And of course, the other options for these patients are whole brain plus SRS or whole brain RT alone. Is there any number cutoff? And this keeps on coming off and on. And this Japanese study tells us that, and they took actually patients with up to 10 brain metastasis. And when they compared 2 to 4 tumor versus 5 to 10 tumors, they actually did not find too much difference between the two. So they actually proposed that even up to 10 could be tackled by focal radiosurgeries to these 10 lesions. Is there a volume cutoff? And then you had this study from, this is one of the studies which I'm quoting from California, which actually proposed that, okay, even if you are treating more than one, but the volume, the cumulative volume should be less than 10 cc to have better outcomes. And so you have these, the SRS criteria where the suitable patients for SRS include patients with the number of lesions 1 to 15. So please don't get carried away by the figure of 15, because it's rarely that you have 15 lesions and you still have volume less than 10 cc. So be very careful about that. So mostly you treat around 3, 4, 5 lesions with radiosurgery, and if the number goes beyond that, then probably whole brain radiation comes into play. Then of course you have the cautionary and you have the unsuitable types. So IBMV is a newer concept in SRS for brain metastasis, where you see the brain metastasis number at the first stereotactic radiosurgery divided by the time in years since the initial primary diagnosis. And the newer, and this gives you a kind of a criteria which tells you how the survival would be in the upcoming time. And then of course radiomics, genomics, and immuno SRS is also coming up in a big way. The big debate that keeps on coming off and on is whole brain RT versus SRS. What is better? What is worse? And I'm just presenting this snapshot evidence of three of a meta-analysis which had pulled 3 studies, 3 prominent randomized trials, and told us that less than 50-year-old, there was a tendency for better overall survival with stereotactic radiosurgery, and more than 50-year-old, there was more distant brain failure, but no overall survival difference. So overall, this is a summary of evidence when you compare the two. With focal radiosurgery, it's cognitive sparing relatively, but there is slightly worse neurological progression-free survival. When you give whole brain radiation, it's slightly tending towards worse neurocognition, but you have better neurological progression-free survival. The overall survival probably remains the same. Whole brain radiation has also developed some bit of advancements. So when whole brain RT is offered, memantine should be combined with it, oral memantine. And when we are taking patients for whole brain radiation, the present norm is to do hippocampal sparing. In our hospital, we are also offering scalp sparing whole brain radiation to patients to spare their hair. Do operated patients of brain metastasis need adjuvant RT or SRS? The answer is yes. And you have a randomized trial. You're not one, probably 2 or 3 randomized trials that tell you that there is definite statistically significant benefit in terms of local tumor recurrence free rate once you combine radiation after surgery for brain metastasis. And the newer thing that is coming up is pre-operative stereotactic radiosurgery. And the reason it is coming up is because you have a better target. The target is smaller. You can delineate it in a better fashion. You have lesser chance of radionecrosis in such a scenario. There is lesser risk of leptomeningeal spread, which is supposed to happen once you do surgery followed by SRS. So preoperative SRS kind of protects you against that. Can we totally avoid radiation or whole brain radiation or SRS in patients with brain metastasis? Upfront scenario answer is no. Recurrent scenario maybe in a select group of patients. We have already heard the talk regarding HER2 climb, destiny, to Tuxedo. and so on and so forth. But the nutshell of evidence is that candidates for targeted systemic therapy would be those who have been treated prior with radiation, and those who have asymptomatic disease, and those who have actionable mutations, and those who have sub-centimeter lesion in the non-critical sites, because that is the group of patients that was taken into the trials. If you see HER2 80% of patients were treated beforehand in some way with radiation, and only 20% were kind of not treated. And this is what is reflected in the ASCO SNO ASTRO guidelines as well. So this is a snapshot of what I have already told. The title says triple negative, but I feel this can hold true for all classes of patients of breast cancer with brain metastasis. So you have limited lesion, especially one lesion, or maybe around 2 to 10 lesion. Also in a select group of patients, you could consider them for radiosurgery. But if you have more than that, or if the volume increases more than 10 to 12 cc, then probably with multiple lesion, you need to give whole brain radiation to these patients. And the other question for radiation oncologists is that with continuous coming up of new drugs, perhaps on a monthly basis or a weekly basis, what are the drugs that could possibly interact with radiation when we are giving either SRS or whole brain radiation? So these are the ISTRO endorsed recommendations, which was published in Lancet Oncology this year only. And fortunately, most of the drugs don't interact too much with radiosurgery or whole brain radiation, except they have put a red flag for TDM1 and some bit of a caution for CDK4/6 inhibitors. We began doing radiosurgery with invasive frames, as you all know, moved on to non-invasive frames, and then to frameless SRS, SRT, as is the practice in most centers these days. The other question that keeps on coming up is, my machine is better or your machine is better, and you have n number of machines these days, and everyone likes to flaunt his machine as the best. But in my opinion, all the modern day machines are doing a reasonably good job. What is important is good quality assurance. What is important is a good SOP at your hospital, and what is important is a good radiation oncologist that does a good job. So, summarize, radiation therapy is the treatment cornerstone for brain metastasis. It has a prominent role as a sole modality, post-op modality, and in progressive lesions as well. SRS control rates are impressive with preservation of cognition. Whole brain radiation too has evolved with pharmacological and anatomical cognition sparing, and robust evidence for withholding RT in patients with molecular targets, I would say, is still awaited. Thank you.
Munshi, may I have my mic, please? Yeah. Our last speaker for this session is Dr. Anton Snegovoy, who is going to talk about management of skeletal mets and bone health. Dr. Snegovoy is one of the top-notch medical oncologists from Russia. He's the chairman of Russian Society of Supportive Care in Oncology. He's the head of the Department of Outpatient Chemotherapy, NN Blokin Research, Russian Cancer Research Center, Ministry of Health, Russia. He's been and is a part of several research projects contributing to the field of oncology and bridging Moscow to Mumbai with sharing his knowledge. Over to you, Dr. Anton.
Thank you very much. And good morning, dear colleagues. Thank you, organizing committee, for inviting me to create a presentation about management of skeletal metastasis and bone health. We make a presentation together with my colleagues Inessa Kononenko, who is the chair of the outpatient department chemotherapy. And of course, this problem is very highly important for the patient with bone metastasis, because it's a huge number of the metastatic breast cancer will develop of the bone metastasis. And of course, the bone metastasis play a crucial role in the advancement of the cancer and indicated to shift or to more aggressive and sometimes untreatable phases of the illness. And now that bone metastases have two specific lesions of the osteoblastic and osteolytic lesion, and of course, the clinical developments of the bone metastasis, it is a skeletal related events, which is more famous skeletal related events is hypocalcemia, the pain, is a pathological fracture and needed to radiotherapy or surgery procedures, and of course, as a treatment induce bone loss. If you don't cure this situation for the patient with breast cancer, unfortunately, many of them, more than 60% of the patients, which cure skeletal related events, and unfortunately was dramatically dropped a 5-year survival. And now we have excellent algorithm of the management of the skeletal metastasis. Of course, it is a backbone of the principle of the multidisciplinary management. And the some key aspects include to prevent disease and symptom palliation, early detection bone metastasis, choose of the systemic treatment according to the primary tumors or metastatic lesion, of course, reducing the risk of skeletal related event in this patient before symptomatic events is a very crucial points for the management of the skeletal metastasis, palliative radiotherapy, radionuclide therapy, orthopedic surgery for the indication, and of course, as a supplement of the calcium and the vitamin D. The algorithm of administration bone modified agent is presented on these slides. According to the oligometastatic or multiple metastasis, we can to use its bone modified aging according to the clinical situation. Very interesting debate about dose interval bone target agents according to bisphosphonates, zoledronic acids, or rank ligand inhibitor denosumab. We know that bisphosphonate after 3-6 months could be for a long time interval administration in 12 weeks, but it will be, in my opinion, it's very careful because the Zoom and optimized trials were underpowered for reliable results. According to denosumab, should be administered in now every 4 weeks because we cannot currently be recommended. Many trials try to answer this question about opportunity to prolong administration of denosumab, but now the trials of the REACT BTA study not answered adequately this question, and the Swiss reduced study not still data in present time, and of course many crucial aspects that denosumab does not incorporate in the bone matrix, and bone turnover is not suppressed after canceling these drugs. We are moving forward as a new opportunity to the treatment of the skeletal metastasis, and of course, in the conjunction with novel systemic therapies, immune therapy, and target therapy. The role of local therapy in the metastatic disease is also rapidly evolving. In this case, very interesting data was published in last year in the GCO. It's a prophylactic radiation therapy versus standard of care patient with high risk asymptomatic bone metastasis. High risk lesion was defined as a bulky site. Disease involving the hip, shoulder, and the sacroiliac joints, disease in long bones, disease in vertebral and the joint spine, or disease of the vestibular element involvement. This data shows that Syria is a cure in the less in the radiotherapy arm than standard of care arm is less than 20%, and significant fewer patients hospitalized for the skeletal related events in the radiotherapy arm, and also very interesting and very important also overall survival was significantly longer in the radiotherapy arm than the standard of care arm. The author's conclusion that radiotherapy delivered prophylactically to asymptomatic high-risk bone metastasis reduce a cure on the skeletal related event and hospitalization. It is very important for the practical management of the skeletal metastasis. Also, we develop a new opportunity, new drugs. Of course, it is a different tyrosine kinase, sarcatinib and dasatinib. Very interesting and promising data. Curcuminoids, which combined with together with docetaxel for the patient with bone metastasis, curcuminoids can prevent tumor growth factor beta B, induction of parathyroid hormone-related protein, and reduce osteolytic bone resorption. And very interesting, a new strategy in the combination of the cytotoxic agent docetaxel with antigen-specific nanoparticles as vectors. These nanoparticles recognize integrin in the breast cancer cell in the bone and carry out the chemotherapy drug with the bone metastasis with less systemic toxicity. Next chapter of the bone health, of course, is the metastasis prevention. Very early studies to confirm this strategy. And the clodronate with Professor Inga Deal and Professor Powers was publishing the excellent results of the use of clodronate. Also very important data about ABCG12 and the ABCG18 and data of Azure 10, which shows that adjuvant treatment of the zoledronic acids in stage 2 and 3 breast cancer can to reduce breast cancer death. This data was published in big meta-analysis ABCG, which published in the Lancet in 2015, that also shows that yes, that zoledronic acids in the postmenopausal patient to reduce recurrence, bone recurrence, and breast cancer mortality, and this affects irrespective of the type of the bisphosphonate. We go to the era of the precision oncology, and of course, very interesting data about opportunity to use the MAF genes as a precision selection patient who have benefit in the zoledronic acids. We know that MAF gene can to be control one remodulating if the patient have a high level of the MAF, the zoledronic acids is not work. For the patient with negative of the MAF, the zoledronic acids have benefits for the using in the adjuvant setting. And now we have an algorithm of the use of bone target elements, which divided to patient in the post and premenopausal patient settings, and also according to the chemotherapy, we can to use its zoledronic acids at different times. Unfortunately, we have no optimum duration of the treatment of the metastasis prevention, but according to the ESMO guidelines, we could use this strategy between 2 and 5 years. In last my next slides, couple of slides, I want to discuss about STIBL. It's prevention of treatment-reduced bone loss. We know that many patients who underwent of the endocrine therapy according to the aromatase inhibitor or ovarian function suppression, or a man who underwent androgen deprivation therapy have a risk of the fracture because the decrease of the bone mineral density during this endocrine therapy. And all of these patients, of course, have excellent, have advised to consume calcium enriched diet, exert moderately, and take vitamin D in every day. And of course, this patient should evaluate it of the bone mineral density. And according to these guidelines, we can use of the bisphosphonates for the prevents of the loss of the bone mineral density, and of course to decrease of the percent of the fracture during this therapy. In my final conclusion, that the cancer and its treatment can have a profound effect of the bone health. Clinically treated cancer patients need to be aware of the multidisciplinary treatment available to reduce skeletal morbidity from metastatic disease and minimize cancer treatment induced during to the normal skeleton. Also, I have thank you very much for your attention, and I will be very happy to inviting you in the breast cancer forum in the August this year. It is an exciting meeting because you have a unique opportunity to bring together with colleagues from different specialties and to look World Heritage Historic and Architectural Complex of the Kazan Kremlin. And also, it's a very interesting forum because it's includes different the new chapter of the way of the breast cancer feeling. And also, don't remember that you have to use a pre-registration now to take advantage of the special offers. Thank you very much.
Thank you very much, Dr. Anton Snegovoy. The session is now open for questions. I request Dr. Shonanag, you've got 5 minutes for questions and 5 minutes for imparting your pearls of wisdom. Thank you.
So, thank you. That was an amazing session. I think we covered some very important topics like brain metastasis, oligometastatic disease, and bone health. which is crucial to the management of our metastatic patients. Are there any questions from? Yes, yes.
Good morning. From the surgical perspective, as a breast surgeon, have we reached the stage where we can ascertain whether local regional treatment in oligometastatic disease is beneficial or harmful?
So I think we're going to address that in the panel where they are going to talk about primary surgery in metastatic disease. So that's one of the topics. Shalaka, would you like to make a comment? Short one.
So that's why we don't have high level evidence, but we seem to be believing that if you are able to ablate all the oligometastatic sites distally, and if the systemic therapy response is good, then we may consider loco-regional treatment after the initial 3 to 6 months of systemic
Systemic therapy.
chemotherapy and looking at response. So, and we are even able to offer breast conservation surgery, to be honest, to these patients, because the choice of surgery may be as good as what you choose in locally advanced breast cancer, again, as per response assessment.
I think this would be an excellent debate topic because a lot of these studies were done before effective targeted therapies, effective ADCs, effective dual anti-HER2. Dr. Alistair, do you think that you actually need to treat oligometastatic disease if you have such effective agents available in the clinic?
Thanks. It was an excellent talk on the topic. I mean, I think patients should have systemic therapy first,
Yeah.
absolutely, and that was clearly outlined in the sort of penultimate slide. And then the question is whether you're consolidating or not with aggressive treatment of low volume disease. I think where possible we do tend to. So I'm talking about distant metastatic disease. I think
Yes.
discussion is slightly different around the primary tumor, but I think we do tend to try and consolidate. I acknowledge the NRG study. There's so much heterogeneity here, though, isn't there? These are patients with I mean, there are 127 patients in that study. The richness of metastatic breast cancer, the different receptor status, the difference in disease-free interval, there's so much has to be more personalized than that. I think the debate around local regional treatment is whether you do an operation once you are convinced you have control of metastatic disease and it's not more distant, or whether you just monitor the primary site and only do an operation if
When it
you see
progresses.
progression. And I think we don't know the answer to that question.
My question was focused on whether biologically you are actual fact by removing the primary are leading to more harm. Apart from local control is a different issue. We don't have a choice. But if we're talking about whether local control is not an issue, but whether removing the primary, from what we heard yesterday, will actually lead to more progression of this disease or not.
Can I?
Well, yeah, you can address that. I think is there evidence for that? Yeah. So I think that's the short answer. We don't have evidence. We have a hypothesis. So let's see what happens. My limited question here, because I'm hearing, and yes, that is clearly our policy and protocol in our center also, that when there is systemic disease, we go for systemic therapy first, always. However, there are those few patients where you have a completely treatable, curable local regional disease, and you have one solitary bony metastasis. There was a real life situation. A 60-year-old lady with a completely treatable primary and a solitary intramedullary metastasis in the shaft of the femur, which was completely asymptomatic. And we actually discussed her in our tumor board, and we finally decided that no, we should not deny her the full treatment. So we went ahead and and we brought in the radiotherapist to give radiotherapy to that metastasis, and and treated her local regionally and then with endocrine therapy because she was strongly receptor positive. So this is the combination: strongly receptor positive, solitary treatable metastasis, and local regional disease. Yeah.
I don't disagree with that, but I would still give a systemic therapy first. And the specific reason I'd offer a systemic therapy first in that instance is we quite often, not infrequently, see in a patient who has 3 or 6 months of an endocrine therapy, CDK4/6 inhibitor, maybe some bone targeted therapy as well, that new sites of healing arise. We get sclerotic areas appearing. And in fact, it wasn't oligometastatic disease, it was more extensive disease. And you only find that out after you've given 3 or 6 months of systemic therapy. Now, you may still think she needs aggressive treatment or oligomets at that point, but I still think it's worth finding out. So I wouldn't deny her that aggressive treatment, but I'd still want to give a systemic therapy first.
Shona ma'am, one last question and then your pearls of wisdom, please.
Uh,
Can
Anybody else?
I just ask?
Three questions.
No.
I'm sorry, I cannot allow that.
Mani? Okay.
Thank you. No, I just wanted to add this that see, as far as the evidence is concerned, you'll never be able to generate it because the oligometastatic disease is a very low volume disease. One. Secondly, even if you look at the operable breast cancer and the incidence of oligometastatic, because we don't do routinely metastatic workup in these, it's 8%. But these are all treated as curable disease. Thirdly, they are indolent disease. And indolent disease, you will not be able to get the answer. And no randomized trial, even our own trials, have excluded oligometastatic. The only evidence is retrospective, which has been seen that whenever there is oligometastatic disease, you've been able to cure, which is a large body of evidence in retrospective data. So I think we'll still continue to treat it with curative intent. Yes, systemic therapy first, but I think intent of treatment here would be an intent to cure, knowing fully well and counseling the patient that the risk of progression will be higher as compared to an early breast cancer.
Can I have one quick question for Dr. Munshi? As chair, I have a little prerogative.
Quick.
So,
Make it quick,
so,
ma'am.
so Anushil, I can't leave you alone. I have to ask you a question. You said that all brain metastases need to be treated. Now, you get a HER2 positive patient with an asymptomatic MET. You have access to drugs like TDXT, you have access to drugs like tucatinib. Would you still radiate the patient?
So first of all, this statement is based on what evidence?
There is very little evidence for anything we're
So
talking
no.
about.
So radiation, there are tons of evidence of the control that radiation can have on brain metastasis. So somehow the narrative seems to be, but sorry to say this, but the narrative seems to be building up that systemic therapy can take care of brain metastasis in breast cancer,
I'm not saying
even in a HER2 positive population. But what is not being emphasized is that these are heavily pre-treated patients. In most of the trials that you have, almost 80% were heavily pre-treated with radiation as well. So now suddenly, if you are to make it a norm that suddenly you don't want to treat them with radiation because you feel that
selecting them out
no,
for
I know,
performance
but
sake.
then let us build an evidence for that. So let us either not treat them at all or treat them in a randomized trial, compare them with.
Dinesh, what do you say? Have you seen what happens to the patient after brain radiotherapy and SRS?
I don't think this meeting will solve this question. Sure. Yeah. So it's always comes down to that patient, that situation, because there is not only the biology of the tumor. There's some reason why luminal A is multimetastatic, and some reason why triple negative has remained confined. Right. So this is really about watching the patient extremely carefully.
So a case by
Looking
case selection is
extremely.
what you
I
got to
don't
do.
think you will generate evidence, and
So
I don't
thank
think.
you, everyone. We'll take your question in the panel, sir. And that was a really nice session. And thank you, Dr. Alistair, for stepping up at the last minute. I hand over to.
Thank you, Dr. Shonana, for chairing the session. Our next, may we have a group photo with all the speakers and chairperson, please? May I request the speakers to please step forward onto the stage while I announce the beginning of the next session? Let's announce. Our next session is about precision in advanced breast cancer. And to chair the session, I would like to call upon Dr. B.K. Smriti, who's a senior consultant medical oncologist at Leelavati and Bombay Hospital. Dr. Ramesh Hariharan, who's a co-founder. He's not there. Dr. Okay. 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 I invite Dr. Sevanti Lime, who is the Director of Medical and Precision Oncology at Sir H.N. Reliance Hospital. Over to you, Dr. Sevanti.
Thank you. Dr. Shona, ma'am, may I please also? Please. You're going to be in this hot seat till the session ends.
today. That's how it's going to be. We are privileged to have them both. So I take the opportunity. So, um, as you know, we ran parallel sessions in precision oncology and medical oncology over the last 2 days. And now we are going to just give you some highlights of what we discussed. So, where I'm coming from and why I say precision oncology application, the future is now. I'll just build a story very, very quickly. So, this is who I am, and these are my disclosures. My journey starts way back almost 20 years and more at Sloan Kettering, where I was assigned to do a data analysis on 2,000 HER2 positive breast cancer patients. And when I went into work as a faculty, my first project was a salary duct project where we were looking at HER2 positive disease that had been treated with trastuzumab. And NCI led study where an advanced head and neck patient had a magical response to trastuzumab. And then the NCI match trial, where I was the national chair for the HER2 arm, the arm B. And so a lot of HER2 story that brought to fore the fact that the HER2 pathway could have nuances and applications way beyond the HER2 amplification that we practiced. But why is precision still difficult to apply in mainstream? Mainly because only 14% of Merongs, according to a survey, or less than 20%, utilize genomics as a clinical tool, and only 40% match targeted therapies to genomic alterations. We just organized our pathways into disease systems, and now we have an entire pool. We don't even know when we find these pathways. It's like a sock in a pile of clothes, and you don't know where to wear the sock, on your foot or on your head. And then there are always tumor agnostic approvals. And just the day before, we had approval of Enhertu trastuzumab deruxtecan in all HER2 positive IHC3 tumors, tumor agnostic approval through FDA. We have the immunotherapy biomarkers really falling short in patients where we are unable to predict which are the patients that are going to have real benefit. You have the ones with high PDL1s not responding, and you have the low PDL1s, complete immune desert by prediction, having a complete response. There is severe dearth of data. We are not pooling our information. And then the testing is very challenged. We are only testing the tip of the iceberg. We have different methods that are completely unexplored and are experimental. We have trials that are not that are designed differently. NCI Match, even as we were launching NCI Match at 4,000 different centers in the US, even while launching, we knew it was already outdated. The HER2 arm that I wrote alongside two other co chairs nationally had a response rate of 3%. So obviously, our selection was incorrect. And then finally, as we deal with advanced disease, we also know that cancer is a 9-headed hydra. It has multiple pathways, it's a transforming disease, and it is how you interpret the tumor and how you apply various methods of treatment is how you get about the therapy. Before I bring on my rock stars of the morning, I just want to take a mention here of our Precision Oncology Center that is based on multiple different phases wherein we work with our collaborators to take in all genomic data. Now we are actually foraying beyond routine genomics. we have transcriptomics, we have multi-pathway analysis, we have people coming in together to run molecular tumor boards. With our collaborations are actually outside of our institutions. We are very well supported with our collaborators, molecular collaborators. We have not-for-profit Impact India International. These are molecular tumor boards that are run by fellow colleagues, founded by three of us, but participated by many. And we have ILON Precision Oncology for international handholding and collaboration. We have a large clinical trial presence. We have precision database collection. We have rare tumor clinic. We have young adult clinic. And we have a comprehensive approach to precision and trying very hard to make a contribution from this part of the world. Moving on to breast cancer, it is a heterogeneous disease. And as we understand the very different molecular subtypes, and with the entourage of the new kid on the block, the ADCs, understanding of other pathways, evolving pathways that will help make our targeting even further enhanced. This is an overwhelming field, an understanding which is totally understated, and a huge amount of homework yet to be done. I open this part of the session with Dr. Nitesh Rohadgi, my dear colleague and head of oncology at Fortis Memorial Institute in Gurgaon, New Delhi. He's speaking on HER2 low disease in breast cancer, advanced breast cancer, and N-HER2 focus, which is the major conversation as of today. So Nitesh, welcoming you to the dais, and just a word here regarding Nitesh. Nitesh is a leader in precision medicine. He's also a leader in breast cancer. Nitesh, we're really honored to have you today. Thank you so much for coming all the way. Thank you.
Need to make this fast.
Nitesh has 15 minutes for his talk.
That's after I start.
Yeah, of course, after you start. I'll tell you, your
Thank you.
time starts now. Can we have the IT guys from the preview room to disconnect the laptop?
Thank you very much for inviting me, Sevanti, Dr. Hari Bhakti, and the team here. It's actually an honor to be
Disconnect.
lecturing or talking in front of such an esteemed chairs as Dr. Smriti and Shona herself. Thank you. So this is very interesting. I think we are seeing breast cancer life change because of not only a new molecule, uh, but a whole new way of looking at it. So I was very excited to come and speak about this topic today. Hmm? I don't. This is not my laptop. No. I don't think my password will work. So this is very classical of HER2 pathway. It gets stuck. You certainly know it's going to work. You're confident, and then at the last moment, it gets stuck and something happens. Password नहीं काम कर रहा इसका. Yeah, there we are. There we are. Yeah, Nitish. Yeah.
15 minutes, huh? Not 10 minutes. Okay, 15.
Excellent. Are we good to go? Excellent. Thank you. So, antibody drug conjugate is clearly a new concept. We did not grow with it. We, in fact, did not even start practice with it. And the whole concept, while developed earlier, the classification of HER2 is at the base of it. So, it's very important to remember. It's disappeared again. Yash, we need a password here. So it's very important to remember that we have for long said HER2 positive 3 plus, fish positive, and we forgot the entire other cohort of patients. And suddenly, in last 2 years, we are now remembering that this whole group is important. Why is it
So why it is important is actually coming an answer from a very interesting Indian publication itself. I'll just show that. Start with this slide, yeah. Thank you. Yeah, good, perfect. So why it's important? So we got roughly 200,000 patients in India, and there was a very interesting publication from All India Institute after the development of HER2 low. They looked at the data and they saw while there were only 30% patients, and we've known this in our practices long enough, which were HER2 3 plus, in fact, 60% were HER2 low. So we are in fact talking about almost 100,000, maybe a little less, maybe a little more patients in India who will be HER2 low. That's a huge population of patients to treat. And do remember, breast cancer, unlike head and neck and lung cancer, is not a population of the poor only. I mean, it is of the poor, but not a population. So this is an affordable population. So we do need to solve this. Um, this is the brief history of HER2. It's extremely long. Starts in 1998. I think they're still developing. But look, proud in the extreme left where Sivanti is sitting towards precision medicine. It's all there. And what that shows us that we will see an true escalation of solving this problem as we go ahead. The crux of the matter today is antibody drug conjugate. It essentially means, and I think Alistair put it quite well, where you have a antibody which will bind the tumor on its surface. You have a linker which will have the chemotherapy sitting behind, join it and inject in into the cancer cell. And the best therapy would be where a lot of chemotherapy at a very high dose can be delivered only to the cancer cell and nowhere else. Now, of course, we haven't reached there yet, but this is essentially what was tried to be done. Now, the TDM1 story is the first one because that's where it all started. Emilia, we all aware of. We saw a good increase from almost 6.4 to 9.6% in PFS and a survival advantage with the first antibody drug conjugate. So there was a lot of excitement in the air till we realized that actually, while this was an excellent drug, maybe it's not all that excellent either. It was very good for then, but we realized that science could do better. And we started exploring that in the HER2 not so high group, this didn't work, which essentially meant that until the drug really got down to the HER2 receptor, it didn't work. And this was another example where if you received prior pertuzumab, your HER2 expression goes down to such levels that actually TDM1, in fact, there have been studies claiming that may do even harm. I don't think so, but I do think that it is less good than when pertuzumab is not used. That does not mean you don't use pertuzumab, but it means we need better drugs that set in the stage for TDXD. The I'm sure I wasn't there yesterday and day before, but this drug is being spoken about in every medical oncology conference, not only breast, in fact, but across all solid tumors. This is the crux of, in fact, the HER2 pathway. And it's very important to understand that while we've been trying to play with the surface, which is the trastuzumab, pertuzumab, and to some extent the inside. Again, Alistair spoke about the lapatinib, the neratinib, and tucatinib, the small molecules that go in. It is on the left, the interaction between the surface receptor and delivery of the chemotherapy right to the base where things work. But the benefit of TDXD was slightly different. I'll come back to this in a second, but the benefit of TDXD was that not only the payload came straight to the tumor, but in fact, because permeable, it went to the neighboring cell. And I think this is where we saw the biggest benefit. The bystander effect was an add on, and it was working not only in the tumor cell, but you see some very drastic responses in patient. And I think it's when you give it and you experience it, it's really a revelation. Recently, a patient with pericardial effusion, pleural effusion, I think she had weeks to live in ICU. We gave DXD in ICU because I was telling the family to please go down to palliative route. The son said, no, I have to give last try because she was well a couple of weeks ago. It is
heartwarming when you see a patient walk out and come to your OPD 6 weeks later. And that is the effect, I think, of the bystander effect, because it melts tumors down. What I've done here is shown a compilation of all the antibody drug conjugates we are using today, the TDXD, the TDM1, but also sacituzumab govitecan. Don't forget that, because it's extremely relevant. And what is important is not only the target, but also the DAR, which is basically the ratio of the drug to the antibody drug conjugates. The higher that ratio, my guess is this will only go higher with time. TDM1 is 3.5 to 1. The present two ones are 8 is to 1. The more the chemotherapy will be delivered in the more specific the cell. So I think this will be extremely important thing to see in the future. And also what payload or the what chemo is being used with the anti-tubulin, but do remember that's outside the DNA. So you wonder how does that work? Or a topoisomerase, which is the DNA working on the DNA, or in fact, in the future, my guess is we're going to go down right to the amino acid level and cause straight away damage, just like we do with PARP inhibitors. And Destiny Breast 01 was the TDXD poster child's first trial, which clearly showed that in patients who had almost every treatment on earth, there was still an advantage both in PFS and OS. And this was, remember, Emilia was 9.6 months, and this actually was an improvement on one level above that. And that led to Destiny Breast 03, HER2 3 plus, very the population which had again all the HER2 receptor treatment and had failed, was randomized to TDXD versus TDM1, the then standard. And these kind of separation of curves starting right at the beginning at the first 2 months is something we do not see enough in medical oncology or in oncology. And you could see that the PFS difference was 6.8 versus 28 months. So clearly, while TDM1 set the stage, we had changed the game by giving a drug which was penetrating better, reaching the right target, and the bystander effect. We saw an overall survival advantage. Thankfully, they were both not reached. I do need to see what the update of this is, but there was clearly a separation of curves, which you can see that even at 36 months is still quite wide, so it's likely to show benefit. But that raised this whole talk was actually about HER2 low. And this was the redefining our 60% population, which we were missing out on. So in HER2 low, a population which was either considered as triple negative or as ER positive HER2 negative, which is 60%, there is a new treatment on the block or a new concept on the block for sure. And there were clinical trials done in HER2 low. It's not like this was a completely new entity. It's got flouted now, but there were trials done and they failed to show an effect. Till Destiny Best 4.0 came in and they randomized TDXD to treatment of physician choice, which was capecitabine, eribulin, gemcitabine, paclitaxel, nab-paclitaxel, the kind of drugs we would all use. And this the median number of drugs or chemotherapy lines patient had were 3. So a lot of chemotherapy already delivered. The median number in metastatic setting was also either 1 or 2, and the median number of lines same. And the patient who were ER positive, in fact, 70% had CDK. So you can't really say any of this group was not standard of care already used and finished. And it saw very significant PFS benefit of almost 5 months. This was a difficult to treat group. These were the group which was actually doing bad, as seen by the curves below. And we saw overall survival advantage of almost 7 months. The interesting bit was HER2 negative, HER2 low group cohort exploratory, but there was a big debate whether this group it works. It did. And in fact, we saw a good response whether it was HER2 positive or HER2 negative. So the whole discussion whether this drive was by HER2 receptors or by HR receptors became a bit defunct because we saw responses in both groups and almost equally. And you can see the forest plot is entirely towards the left, clearly suggesting that the drug worked in the entire group. There was toxicity, and I think it's important to note that I will come to the main toxicity of ILD in the second, but there was more nausea, there was a little bit more diarrhea, there was little less neutropenia as compared to TDM1, but not insignificant, and of course there was alopecia. But the main problem was nausea, fatigue, and pneumonitis, which we'll speak about in a second, because this is an adverse effect which is of special interest. And for the first time, we saw a protocol which dictated all the steps that had to be done for the ILD. So this ILD was a significant change. You saw grade 5 toxicity of zero point 0.8 versus 0, and overall it was 12 versus 0.6. There was more issues with LVEF also, but that's something I think we had got used to. So in summary, TDXD did reclassify HER2 as HER2 3 plus and HER2 low, the new category with a new treatment option. It demonstrated improved efficacy in this group. DB04 established that this is a new standard and potential improvement of almost 50%, as I said, in India, maybe 60% patients in that setting. The ILD is important. I think we must all read the main protocol supplement with very clearly and elaborately given there. There is a graded of toxicity, there's a point of scan, there's a point of stopping, and the point of recontinuing and permanently stopping. So please, my request is do not give this drug without understanding. I picked up one ILD only because my registrar who monitors patient had read this thoroughly and had made sure he had read it. So he picked up the ILD out of sheer somebody saying breathlessness, slight cough, HRCT showed changes. We restarted because the patient we picked up early, gave steroid, was fine, but it is something to be looked into. What is interesting, the rechallenged patient gave some examples, and look at the patient in the second last row. Actually, this patient is continued beyond 1,000 days. So it's not that you can't rechallenge, but you have to follow the protocol. So that's my request. It is now approved by both NCCN has included it, and FDA approval is there. It is in HER2 low, so new category formed. But that does lead, in very little time I have, about sacituzumab govitecan, which again in the phase 3 accent trial showed a clear advantage. But when we look at the HER2 group also, we see that there was uh, okay, so when we look at the HER2 group also, we clearly see there was an advantage in both HER2 low and HER2 zero IHCs. So it's a HER2 low that we are most interested in. And in Tropics 2, which is the ER positive group and HER2 low, again we saw an advantage suggesting that actually this drug works across the group, whether it's ER positive, the old triple negative with HER2 low, or ER positive with HER2 low. Questions remain. Fish amplification is my first question. I'm not entirely sure whether the main driver is actually the fish amplification. It makes sense. And I think some more study needs to go into looking at fish amplification as a continuum rather than actually to say it's positive or negative. I debated this in YIR this time. There was a moderation. We discussed that. And I think it's a very interesting concept. Timing of test, which is the HER2 low? Is it the first HER2? Is it the second HER2? Is the last HER2? There is a discussion on this that HER2 2 plus at any point, HER2 1 plus at any point in patients. If somebody in metastatic setting has had 3 biopsies, you can use any of them. I'm not entirely sure of that. So I do think the timing is not entirely clear, especially with data saying that it changes in metastatic patients. Brain mets, I think Alistair did cover that, but we do know that in HER2 low, the brain mets is more than in HER2 0 and less than in HER2 3 plus. But does the drug work equally? I'm not entirely sure. I think we need more data on HER2 low group and brain metastasis, which is lacking at the moment. And most importantly, sequence. What do I do with the triple negative? Do I use SG first or do I use NR2? And what do I do in the ER positive? Do I use SG first or do I use NR2? Again, I think there was a very interesting discussion on that. And it seemed that while there may be some consensus that in triple negative use SG first and in hormone positive use NHER2 first and then switch over, I don't think is that clear either. I think I have very little time. I would have liked to go to the next steps of what do we do there in terms of the new drugs that are forming, but I don't have time. I'm going to be told off. But I would like to thank the entire audience for listening. But a special thanks to Shanu Modi, not only for doing DBO4, but actually sharing her slides. And so I will give her credit for that. Thank you.
Thank you, Dr. Nitesh. Dr. Sivan?
We'll take questions in the end later.
Yeah.
Okay.
In the end.
Thank you, Nitesh. So I think quite a bit beyond N-HER2. Fantastic. When we talk about precision in breast cancer, right now, this is the conversation that is the leading conversation. And HER2, IHC3, HER2 amplification, HER2 low, and across the board, and how even HER2 zero could have a meaningful benefit from application of ADCs. And then more ADCs and lots of evolving biomarkers. But one modality that has already stayed and proven its advantage in locally advanced as well as advanced breast cancer is immunotherapy. And so I welcome Dr. Alistair Ring to speak on role of immunotherapy in locally advanced breast cancer with a focus on pembrolizumab and K522. Thank you, Alistair, for doing this talk and many others that you've done through the meeting entirely. Thank you.
You've got 15 minutes timer, please.
Thank you. I'm just waiting for my slides to actually appear. Brilliant. Okay, well, I promise you this is the last talk I'm doing, so you won't have to put up with me much longer. So thank you for the invitation. Come and talk a little bit about immunotherapy and early breast cancer. So this is treatment in the neoadjuvant setting. So let's just remind ourselves, why do we give treatment in the neoadjuvant setting? To make surgeons' jobs easier, to limit the size of surgery, limit size of auxiliary surgery. Let's not talk more about the axilla after yesterday afternoon, but limit auxiliary surgery, to expedite treatment of micrometastatic disease, so getting our adjuvant treatment earlier, to shrink the cancer, to delay time for genetic, to buy a bit of time for genetic testing to be done, but really also to predict outcomes in longer term trials, and perhaps to tailor treatment in those who don't get as good a response as we want. Because we know from all of the data over the years that patients who get a good response, who get ideally a pathological complete response, those patients have a lower risk of recurrence in the future. And that's what a lot of the research and a lot of the developments in neoadjuvant treatment are based upon. So these pathological complete responses up until now, about the rates of 30 to 35%, patients get a PathCR with anthracycline taxane-based chemotherapy have evolved. So over the years, last 10 years ago, we were using anthracycline taxanes alone. Now, increasingly, we use platinum compounds as well. And that's based on a series of trials that I've summarized here, and essentially adding in a platinum to an anthracycline taxane chemotherapy increased pathological complete response rates. And we started to see PathCR rates of around about 50%. And we also saw that adding in a platinum, and this is just data from one of those studies, the brightness study, we found that adding in a platinum increased the PathCR rate, but it also translated to an improvement in event-free survival. And really, come about 3 years ago, that cemented for us the use of a anthracycline, taxane, platinum combination, chemotherapy backbone in patients having neoadjuvant treatment for triple negative breast cancer. And that was the situation 2 or 3 years ago. But in parallel, we were seeing studies of immunotherapy in advanced breast cancer. So 2 drugs, we were quite a long way behind other tumor sites who were really realizing the benefits of immunotherapy in other settings. The 2 drugs, atezolizumab, shown in the Impassion 130 study, improvements in progression-free and overall survival if you add on immunotherapy to nab-paclitaxel chemotherapy. Okay, so improvement in progression-free and overall survival. Only in those patients who had a PD-L1 positive tumor, probably around about 40% of patients. And pembrolizumab, when added again onto a chemotherapy backbone, also led to an improvement in overall survival, again, only in patients who were PD-L1 positive by a different assay in this setting. So essentially, the question arose, can we translate the benefits of immunotherapy in the metastatic setting to our patients who are having neoadjuvant treatment for early breast cancer? And I've been asked to focus on one trial, and that's the Keynote 522 trial, which is really the one that has changed practice. But I just want to recognize there are a number of other studies as well, some of which have demonstrated improvement in PathCR, and some of which actually have shown improvements in event-free survival as well, particularly this GEPAR Nuevo study using durvalumab. But I'm going to focus on pembrolizumab and the Keynote 522 study. So Keynote 522 is a study in triple negative breast cancer. You had to have either a node positive tumor or a node negative tumor of T2 or above. Triple negative patients, other entry criteria for the trial, any PD-L1 status. It didn't have to be known at time of entry for the study. And the randomization was either to a backbone of chemotherapy with carboplatin, Taxol, and an anthracycline chemo. So the backbone I was referring to earlier, or the same backbone with pembrolizumab. So it's pembrolizumab or placebo. You had treatment in a neoadjuvant phase prior to surgery, and then you carried on pembrolizumab or placebo essentially until you completed a year of treatment in total. The study primary endpoint was a PathCR rate, or the co-primary endpoints, I should say, there's PathCR rate, because we know that should translate into event-free survival, and event-free survival with a number of secondary endpoints as listed on the slide. Big neoadjuvant study, nearly 1,100 patients randomized, 2 to 1, I should say, to pembrolizumab and chemotherapy compared with placebo and chemotherapy. The population recruited looked like this. So by and large, a relatively young population, but triple negative patients, but some older patients enrolled as well. They were largely fit. Most of the patients, retrospectively, I should say, I mean, they were, you provided tissue at the time of entry, but were PD-L1 positive, as it turned out. They had carboplatin. You could either have it 3 weekly or weekly. And 50% of the patients had nodal involvement at the time of entry. So the next slide is the primary endpoint, which is the pathological complete response rate. So essentially, the PathCR rate with the control arm, which is in sort of a kind of, I don't know what color you call that, sort of dark red color, was about 50%, which fits with, I think, what we would expect with an anthracycline taxane carboplatin combination. And that increased to 65% with the addition of pembrolizumab. So an increase, 13-14% increase in PathCR rates. But what was important was even at some of the first early analyses, we were beginning to see an improvement in event-free survival. Because the question with all neoadjuvant studies, when they show an improvement in PathCR rate, is will that actually translate into an improvement in long-term outcome for patients? So those are the early analyses, and this has most recently been updated at ESMO last autumn. And these are 5-year follow-up data. There have been multiple iterations of the outcome of this study. And essentially what we're now seeing is an improvement in event-free survival of 9%. And importantly, the difference in distant relapse-free survival is 7.6%. So the addition of pembrolizumab is leading to an improvement in reduction in distant recurrences, essentially. So what about response according to pathological complete response? So outcomes according to pathological complete response. So essentially, patients achieving a pathological complete response have a very good outcome. And as we know, patients who don't achieve a pathological complete response have a less good outcome. So we knew that anyway. The green lines here are patients receiving pembrolizumab. So these patients have pembro who got a PathCR. These patients who didn't have pembro got a PathCR, who actually did pretty well anyway. And these are patients who had pembrolizumab and didn't. So we bear in mind, pembrolizumab was continued whether or not you had a pathological complete response, as was, of course, the placebo. So the question that arises is to what extent these patients needed to carry on their pembrolizumab after they'd achieved a PathCR. What do we do about these patients who do not achieve a PathCR? Well, in clinical practice, we carry on with the pembrolizumab because they still seem to do better. But quite often we try and enroll them into clinical trials now. So there are at least two, I'm sure there are many more clinical trials trying to enroll patients who do not achieve a pathological complete response, including after immunotherapy. The one we're recruiting to is this one, Tropion-03, and essentially looking at a new antibody drug conjugate that we haven't really talked about, Dato-DXd, which uses the same chemo molecule as T-DXd that I was talking about earlier, but a different antibody, either Dato-DXd with another immunotherapy durvalumab alone or with capecitabine. So a real need here, patients who do not achieve a PathCR, so about 40% of patients, what do we do with them even if they not achieve PathCR having immunotherapy? So improvements in PathCR rates, improvements in event-free survival, that's the good news. What's the catch? So essentially, what are the adverse events? So this is the adverse events during the combined phase. In other words, when you're having pembrolizumab and placebo with chemo. I'm not going to dwell on this because really the side effects that we're seeing are really dominated by the chemotherapy more than the pembrolizumab. That's the focus when you're on that phase. But what I did want to draw your attention to is the immunotherapy related side effects, because certainly for surgical colleagues who may be slightly less familiar with immunotherapy related toxicity, make no mistake, immunotherapy is a gift that keeps on giving. It can affect most organs in the body and can lead to some very challenging toxicities to deal with. So these patients continued, as I said, immunotherapy after their surgery, and the toxicities and specifically immune-related toxicities that we see are shown on this slide. And the couple I'd like to draw your attention to, one of them is hypothyroidism. So about 15% of patients develop some degree of hypothyroidism. So usually what happens here in my experience is patients become hyperthyroid and become tachycardic and symptomatically hyperthyroid. Obviously, they're being monitored routinely in their routine blood tests at thyroid function. They become hyperthyroid. They may or may not need a beta blocker to control symptoms due to that. And then their thyroid burns out. They become hypothyroid and need thyroid replacement. There are very standard protocols to deal with that. Some patients do get severe skin reactions. The other one I just wanted to draw your attention to particularly, although rare, is adrenal insufficiency. And the reason I'm drawing your attention to that is these patients by definition are having surgery. So our protocol is to measure an early morning cortisol in all these patients who are coming up to the point of their surgery, just because there have been reported reports of anesthetic deaths in patients undergoing surgery on immunotherapy because they've got undiagnosed adrenal insufficiency. So either have a protocol to measure an early morning cortisol or make sure your anaesthetist is well aware of that risk. Because when things do go wrong, unfortunately it is rare, but it does happen, things can go badly wrong. So immuno-related colitis, immuno-related pneumonitis. Now, quite aside from being life-threatening problems in their own right and very unpleasant for the patient, what they also do is inevitably delay surgery, a key part of the curative treatment pathway for these patients. So, in conclusion, the addition of pembrolizumab to a backbone chemotherapy of anthracycline, taxane, and platinum increases PathCR rates and event-free survival rates. and reduces the rate of recurrent metastatic disease. We do need to be careful with toxicity, although those immunotherapy related, the chemotherapy related toxicities are as standard. The immunotherapy related toxicities are something slightly new to be dealing with in a curative population who are heading towards surgery. So we need to have clear protocols to deal with that. What are the unanswered questions? Well, will this have an overall survival benefit? One would imagine so, because of the impact on distant recurrence, but remains to be seen. Do we really need to continue the Pembro in patients achieving PathCR? What about the management of patients not achieving PathCR? And I think the answer there is clinical trials. And the toxicity is not just about day-to-day things and risks for the patients. There's a significant financial toxicity approach associated with this treatment that requires a honest discussion. Thank you very much.
Thank you, Alistair. So the real provocative part of the last presentation is what is the biomarker for application of immunotherapy in these settings? And in a resource-limited nation, we constantly struggle to understand which is the patient that we should be offering. Because if you tell a middle-class family that this should be done and this may add to their lives, they are unable to afford. It is such a huge challenge and limitation to all our patients, and it's a constant struggle for us in the clinics. So I think we need to really enhance the methods of testing, enhance the methods of analysis, and pool the information that each one of these initiatives is bringing together. In one such effort to bring in some discussion into the role of artificial intelligence in pooling the data and bringing to the fore the application of precision medicine to the clinic and helping it translate into patient benefit. I would welcome our team from Tempus here, Mr. Andrew Paramore, the CEO of Tempus UK. Andrew, we are here waiting to hear the role of artificial intelligence in processing the avalanche of precision-led data that is coming through and helping the application of precision medicine in our clinics, in our day-to-day lives. Thank you for making it here. The stage is yours.
Thank you very much for that introduction. As you've introduced me, I'll just quickly flick through my disclosure slide just to make sure there's no confusion about my allegiances. So I think over the weekend, I think we've learned that the landscape of breast cancer and the number of biomarkers that are being generated is actually evolving rapidly. And breast cancer used to be a little bit behind non-small cell, which led the way in biomarker-driven treatment. Breast cancer is really catching up. These are the biomarkers that have approved targeted therapies, and these are the ones that are waiting in the wings. So we can see that breast cancer is going to become more and more complicated to manage as we generate more and more data. And we find ourselves in this situation where through each diagnostic step, we generate a little bit more informative information that could guide the patient's treatment. But what we're finding, it's dissipated across the hospital network based on the profession that's provided that insight. So as healthcare professionals, we also have to be great at finding these nuggets of information that are buried across the diagnostic journey. I think mostly the multidisciplinary meetings can help as each profession then contributes, but it still takes time to draw the information together. And this really is the foundation of why Tempus was set up in the first place. So the CEO of Tempus, Eric, his wife was diagnosed with breast cancer about 15 years ago in the US. And he was actually shocked at how difficult it was for the treating clinician to find all that diagnostic information that was being generated about his wife. So he wanted to make a difference by making that information and data accessible to the clinician, putting it at their fingertips so they didn't have to search. And Tempus is quite a young company. I mean, it's only about 8 years old. But in that period of time, in collaboration with academic institutions and collaborative research groups, we've generated a database that contains 7 million de-identified patient records in oncology. And that sounds interesting and great, but data's only useful if you can get at it and see trends and make decisions based on it. And the evolution here was to actually develop a browser-based way of searching the database. And we call this Lens. So I'm not a data scientist, but I can use this because there are really deep filters that you can just drag and drop and do really interesting research into the retrospective data. And with those same academic collaborations, we're leading to publications that could potentially inform treatment of breast cancer patients in the advanced stage setting. So these are just a couple of screen grabs from some of the research that's been presented at conferences over the past couple of years that actually show the molecular landscape following the use of, for example, CD46K inhibitors as first-line settings. So if you understand how the tumor has evolved, then perhaps you can better select the appropriate therapy to get the responses that we're all looking for. Now, obviously, data is great to develop insights, but obviously, one of the things that's really evolving at a pace is the use of the comprehensive genomic profiling, or NGS. And most tools are offered as individual modalities. You either do a DNA test, an RNA test, or you then do germline. I think what Tempus did was we want to make sure that we realize that every tissue sample you have from a patient is precious. They can be exhausted very quickly by the number of tests that we need to perform to make that diagnosis. So we offer a test called XT, which is both DNA, whole transcriptome, and tumor normal match. And I just want to show you with the data that we've generated why that's important. So this first bar chart on your left is showing what happens when you use that multimodality approach. So you actually increase the number of potential actionable mutations that you can find if you use both RNA and DNA, because each contributes something new. And obviously, those that are involved, the medical oncologists among you that are involved in treating advanced breast cancer, will know that fusions are becoming more and more important when we've got NTRAP and RET targeted therapies. If we look at the pie chart on the right of the slide, we can see the actual fusions that were detected, which are actually now targetable. So this was actually a very large study of 84,000 patients, the largest fusion analysis that's been done to date. And again, I repeat, that's the power of large data sets. So I've mentioned tumor normal match, but kind of what does that mean? I mean, we do that for a very specific reason. We do it to improve the fidelity of the somatic calls when you're thinking about using that information to target treatment selection. What that basically means is we subtract potential germline findings from somatic findings, so there's no confusion there. But that also then provides some more interesting insight. So we know that breast cancer is one of the cancers which we tend to seek out germline mutations because it has implications in the management of the disease. But what we've discovered here, even though that's a recommendation, we still use characteristics from the patient to decide whether or not we should send them for germline testing. But using this methodology of tumor normal match, you pick it up in a higher proportion of patients than you would expect. So it's 10.8%. And what this can be used for is it can be used to conserve resources and time, because obviously there's no point in doing a germline test if you find nothing. But if there's a signal of a potential germline finding, then it will increase that chance of finding that in that patient and perhaps triage them for germline testing and genetic counseling. And more recently, what we found, and this was presented at San Antonio just gone, this is an exploration of what happens to the somatic landscape in certain germline mutations. And we can see in the bar chart that you get a very different distribution from the somatic-driven cancers versus the germline cancers. So again, this insight may have important implications on how these patients with germline driven breast cancer would be selected for targeted therapies. And finally, immunotherapy is becoming more important, and tumor mutational burden is sometimes used as a measure of this activity. But obviously, the calculation that's used to estimate tumor mutational burden is mutations per megabase. And if you're including potential germline findings in that estimation, then you tend to push up that estimation, and you may be wrongly assuming that this patient is TMB positive, so greater than 10. But interestingly, what we've seen in the data, the boxed red charts are specifically breast cancer. We can see that there is a difference in the estimation from matched tumor normal versus just somatic estimations. But also we can see there's a difference across racial groups. So it's important, to control for that impact of including potential germline findings in your calculation for those estimations, because we don't want to give therapies to patients if they're not likely to respond because we've overestimated the TMB. And obviously, there's so much data now being generated by clinical research and these new biomarkers that are coming to the fore. I'm not going to go through the detail of the studies because I'm sure over this weekend you've been through these key data. But just a couple of things I want to pull out from this. This is the PADA-1 study. And obviously, it's important now because we can, this study showed that the ESR1 mutations emerge under the selection pressure of therapy of CD46K inhibitors. And what that's actually done is now the guideline groups like ASCO and NCCN recommend that we should be monitoring these patients for this emergence of resistant mutations in the ESR1 gene and then switch therapies, which is what the PADA-1 study showed, that you get a better response. Now, what the data shows us, actually, if we look historically backwards, if we look on the bar chart on the left-hand side, first of all, but also let's focus on the fact of the ESR1 mutation that we're monitoring. We've noticed that ctDNA, so liquid biopsy, is actually much better than tissue picking up these ESR1 mutations, especially as you get clonal evolution of the tumor under the selection pressure of treatment. Now let's go back to that bar chart on the left-hand side. What this is showing us is the time difference between the tissue biopsy and the liquid biopsy. So we start on the left with less than 7 days between the two sample types. And what we're looking for here is concordance. So the darker the blue, the more concordant the two methodologies of sampling are in terms of the variants that are detected. But I think it's logical, and you won't be surprised to see that as you get further out, so as the time increases from that baseline tissue sample to the liquid biopsy, so the results become more discordant. So this suggests, again, some tumor evolution. And it's important, it's underlining that importance that the tumor is going to evolve under the selection pressure of therapy. So the data is now emerging. It's important to pick that up and modify that treatment interventions. If we look on the right-hand side at the larger bar chart, I can tell this is breast cancer that's been sampled by the very, very long tail of variants that have been detected. And I think that's why historically breast cancer has been kind of shied away from these targeted biomarkers because it seems such a complex jumble of driver mutations. But again, we can see there are commonalities which we should be able to target. And then on to the SOLAR-1 study, which again, I think just reinforces that point that we should really expect evolution of the variants that are driving the tumor under the selection pressure of treatment. And what this is doing, what these data are showing us, is that if we switch therapies, we're able to sustain a response to treatment and prolong the survival of the patients. But we must gather the information about what's going on with the patient's tumor over time. So we rely on the tests and the data that we see to draw those conclusions. So I think just to summarize, and the more information that we can collect, the better we are at making informed treatment decisions. So the better we can then improve the therapeutic responses to our patients and also get better at selecting appropriate therapies. So the data seems to be suggesting that if you combine ctDNA with tissue biopsy, depending on the time scale and the availability of resources, you're more likely to pick up actionable mutations. But let's go back to where we started, the data problem. All this information that we're generating, let's put it at everyone's fingertips so we can then use and make more informed treatment decisions. So you can see that picture of those data silos is now very different. It's simplified. And this was the driver of what Tempus is all about. It's using AI and machine learning to develop tools to put this information at your fingertips. So Tempus Hub is a way of accessing all of your genomic information and clinical information in one place. Easily searchable. There's an app you can put on your mobile phone, and launched last year is a virtual assistant called Tempus One. Tempus One uses machine learning and large language models to link your questions to data within the secure environment of the Tempus database, but also clinicaltrials.gov and NCCN. So you can ask any question you like about what's the therapy recommendation for ESR1 mutations in the second line, and it will query the database for you and serve up that information. We're also working in collaboration to improve the information that we generate from H&E slides and radiographic images. You can teach machine readable slides. Digitization enables you to look at the phenotype and predict the genotype. And as I said before, you know, that tissue sample is precious for every patient. So if we can actually detect a rare mutation or protein that could be targeted without consuming the tissue to do the IHC test, just by looking at the slide, we can then enrich for those people that we actually send that confirmatory IHC test to get their diagnosis. And basically, I just want to echo a mantra that's coming from NHS England, which is data saves lives. And that's behind some of the drivers in the big projects of the 100,000 Genome Project and the much more inspirational 5 million healthy volunteers analysis for our future health. So I really would reinforce that point. Thank you very much.
I think I would like to thank all the speakers for
Ma'am,
three
there is
great talks.
one more.
Yeah. Okay, sure.
Timothy.
Three. Okay. Okay.
Thank you. Thank you. Thank you, Andrew, for very eloquently presenting how data could be meaningful in the application of precision medicine in our clinical practices. And that's the horizon that gives us hope that we will be able to piece this together in a much better way. When we were in sessions yesterday, Dr. Michael Grant presented his plenary, and in his plenary, he presented a case. And he said, I don't like case reports. I want data. But I think in precision, we are dealing with such nuances that it is extremely tough to build large database. That's where I feel bigger efforts to bring all the data together would be so much more important, and it will contribute to world literature and also world strategy of treating our patients for better outcomes and enhance the approach of precision and personalizing therapy. With this, some more on diagnostics in breast cancer, precision diagnostics being presented in tissue by Dr. Stefan Schuster, who's going to focus on comprehensive profiling and multipathway analysis for precision based therapy in breast cancer. Thank you, Stefan, for doing this for us. Dr. Stefan Schuster is the CEO of Datar Genetics Germany, and he's here today to talk to us about the tissue based genomic application for advanced breast cancer. Thank you for doing this.
Ten minutes for this timer. The preview room, 10 minutes. Huh?
Hello, good morning. Thank you, Dr. Savanti, for the kind introduction. Actually, I just learned today in the morning that Tim couldn't come because of visa issues, and this is why we are presenting now, my colleague and I. Actually, I thought visa issues, obviously it becomes more difficult for Europeans to travel now, meanwhile, to India. So I'm talking today a little bit about multiomics and setting the scene basically also for my colleague afterwards. Why are multiomics so important? When we look back in 2015, 2016, when the Shiva trial, for example, was published, everybody thought, well, precision oncology, it's maybe not the way to go forward. The issue, basically, with the Shiva trial was that it was looking only for a very selected set of genes and was not really applying multiomics at all. And so the benefit in the end for the patients were very limited. We tried then to learn from this journey with my pathway, the Moscato trial, NCI match, and we landed with a Resilient trial where we tried to implement not just mutational analysis, but also chemosensitivity analysis. We were applying gene expression analysis. And this is what we were basically doing in the Resilient trial. And we finally saw a benefit for more than 40% of the patients that were enrolled in this clinical trial. The challenge that we have with cancer, it's multidimensional. We have on one side the tumor heterogeneity. On the other side, we have interpersonal, intrapersonal challenges. There are differences in between. Today we heard a lot about HER2 already. I will show you just in the next slide some case report. N equals 1 trial. We have to look at each patient separately. And it's not that the tumors are different, but the tumors are evolving over the time. We know it very well. There is a German study out there from the Edinger Institute about brain cancers. With each therapy, the mutations multiply. And in the end, you have so many changes in the genome of the tumor of the brain cancer that it doesn't equal anymore to a human cell. And this is also why therapies fail in the end, because if you try to apply drugs that kill human cells in the end, even if they have aberrant mechanisms, you won't kill them anymore when they're kind of alien. So I showed this slide already on Friday, but today I want to emphasize on something else. This patient was a breast cancer patient. She was hormone receptor positive, and she was initially HER2 negative. After 12 months, she had already the first liver metastasis. Those liver metastases were HER2 positive. And this is where we have seen that finally, when a HER2-based therapy was applied, the patient has a certain benefit. But there were other issues reappearing and other challenges in this patient. So she also suffered from later on from ascites. And here we had to focus, or the doctor, the oncologist had to focus at which compartment has the biggest clinical pressure. And on one side, she had liver metastasis. On the other side, she has ascites, and ascites was more pressurizing. And this is why we did analysis on the ascites, and there we found reappearing and disappearing ERBB2 mutations, where in the end, the drug trastuzumab deruxtecan, we are always speaking about hitting cancer from multiple sides, but in this case, it was maybe the magic bullet that really helped in month 70 the patient a lot. Nevertheless, or unfortunately, the patient died because of sepsis in month 78. So here you can see that also over time, the possibility to apply multiomics, not just genetics, but to have the ability to analyze different compartments is very, very important. I will skip this because I think my colleague will emphasize a little bit more on the CTCs and how we find them. Because with multiomics, it's also the advantage that when we focus on genetics alone, we might not find in all patients finally targetable targets that we can apply, either because it's because of guidelines, etc. But when applying a very comprehensive marker like CTCs, which we find in almost all cancer patients, dependent on our method, we are able to apply chemotherapy treatment. And we already did here some clinical trials. Also very important to note here, especially when we are in the later stages in the metastatic setting. Chemosensitivity alone, and I think this is what we learned about all the clinical trials that even we have seen also today. Chemotherapy alone in later stages is not sufficient. We have to add targetable drugs. We have to add immunotherapy, etc. And this is what we have to do in an intelligent way. And this is why we are also looking at mRNA quantification when it comes to our methods. What we are doing at Data Cancer Genetics is that we not just focus on the tissue on one side, but also look always what is happening in the blood to get an overall picture from all metastatic sites. I think what is also always a little bit left alone is the topic of pharmacogenomics. We do this always. We are analyzing multiple other things, but just a small story about pharmacogenomics. When I studied pharmacy 18 years back, the whole class did a pharmacogenomic analysis. Well, males were a little bit underrepresented in this class. Nevertheless, more than 70% had germline mutations in their enzymes, and this really shows that it's necessary also to look all over at the pharmacogenomics. Nevertheless, of course, there is the tumor mutational burden. There is, for the immune checkpoint inhibitors, there's MSI, MMR. We have to look at the microsatellite, the RNA fusions, again, the mRNA expression, and also the immune histochemistry, because it can change over time. We did there some clinical studies, namely the Resilient and the Liquid Impact trial. And where we applied this exact test and what were the survival metrics in the end. We have seen that if we can combine multiple therapies with each other, the patient has the biggest benefit. I think all of you remember the slides of that were shown multiple times on the Congress of from Hanahan. He basically also says you have to tackle the cancer from different sides. You have to tackle basically different pathways. And this is what is basically shown here. The biggest benefit have those patients where we can apply most therapies. And also Timothy Crook participated in some of our clinical trials. And when you look at angiogenesis inhibitors, but also at mTOR inhibitors, they're pretty old, or some of them are pretty old drugs, and especially 20 years later, 20 years before rivastigmab, for example, or everolimus, they are targeting central cancer pathways. Nevertheless, when applied alone, the benefit is pretty limited. We have to find or to combine them with other intelligent, or in an intelligent way with other treatments. And this is what you can do with multiomics, to add another targetable drug, to add another chemotherapy. This is where the advantage in the end comes from, and where you can see in the end a disease control rate initially for more than 90% in the end. And these are all very advanced cancer patients. Now, we did also some data in Germany. I showed this slide already on Friday. It's just, again, that you see a benefit when you compare the patient with itself. So that the PFS2, just one slide left, the PFS2 can be enhanced when you apply multiomics in the end. Now, I was setting the scene. Nevertheless, precision oncology is not based on empirical data. We have to look at the individual patient. We need to have in the future also maybe flexible guidelines that allow in the end multiomics to be implemented in the daily use, because at the moment it's available mainly for wealthy patients. One open question is also what biomarkers are important in addition, and of course the pharmacoeconomics. Thank you very much for your attention.
And sorry for having to get you through this. And now welcoming Dr. Darshana Patil, the medical director of Datar Genetics, to speak on liquid biopsies in breast cancer. And this would be followed by liquid biopsy in breast cancer screening by Dr. Timothy Crook. Darshana, floor is yours.
So good morning, everybody. We have heard a lot about precision oncology in breast as well as liquid biopsies in past 2 days. Still, I will give a brief overview on liquid biopsy utilization in breast cancer. So as we mentioned that we saw in 2 days that lung cancer has always been the poster child of precision oncology, but with new approvals coming in, I think breast has become one of the topmost actionable precision oncology diseases that we have currently. Almost 40 to 60% of the breast cancer will have some targetable alteration. It's not just limited to PIK3C or HER2 anymore. We have AKT1, PTEN, we have the somatic or germline HRR mutations, which come to our rescue when we are dealing with a particularly difficult situation. So with broadening of the targets in breast cancer, we also have seen the efficiency of liquid biopsy to give us that information from a simple blood draw. So this is a data in more than 4,000 individuals where the spectrum of mutations which are targetable have been detected with equivalent sensitivity in a blood sample as well. PIK3CA, ESR1, of course, top the chart. And however, when we see the data, the concordance is seen, varied concordance is seen across multiple genes. I think the slide has some issue. So there was a slide where I was trying to say that TP53 mutation, PIK3CA, ESR1, and HER2 is but detected with equivalent sensitivity, with the discordance rate is seen in ESR1 more than others. The reason is not the limited sensitivity of the circulating tumor DNA in profiling ESR1. It is more because it is more sensitive, especially when done in acquired resistance setting. And that is why liquid is being proven as one of the equivalent sample for profiling of advanced breast cancer. And the data is already there, whether what would happen. So detection is fine. Whether if we target based on our liquid biopsy profiling, what is the data? We already have data from alpelisib or capivasertib, where we see that the targeting of a particular patient based on a liquid profile gives you a good result, where we can see PFS advantage or ORR advantage with these targets. So, what is the additional advantage that liquid is offering us? Yes, fine, it is able to detect the predictive biomarkers with good efficiency, but can it be better in certain situations? Definitely yes. As I mentioned, in acquired resistance setting, ESR is being captured more sensitively from a blood sample than a tissue. And not only that, we have seen heterogeneity in cancer is a heterogeneous disease. So when you are profiling tissue and liquid, you can see that concordance is fine, but there are certain PIK3CA mutation or certain ESR mutations which are detected additionally in blood. And especially with PI3K pathway, we have seen that if you have dual mutations or more than 2 mutations in this pathway, targeting that pathway has yielded better result than a patient who has a single PIK3CA mutation. So, supplementing of tissue to liquid is going to be obviously the best ideal choice. But when in a resource constrained situation, in a in an advanced breast cancer patient who has taken multiple therapies, I think breast, in particular situation, liquid might be a better option. So it's we know that PI3K is playing important role even in resistance setting of endocrine therapies. It is not only a target for selection of PI3K inhibitors, but even in endocrine resistance along with ESR mutation, PI3K, FGFR mutations, FGFR amplifications, or AKT1 mutations also play significant role. And such broad insight with help of a liquid biopsy in these situations is definitely helpful for better management of patients. So, I'll just go to the next slide. So PI3K mutation is one story that we have already discussed. What beyond PIK3C and what beyond ESR1? So this is a particular trial which we discussed already on Friday, but still just to give you brief again insight on it, that HER2 mutation cohort in HER2 IHC negative patient also showed significant benefit when HER2 was targeted with neratinib, maybe in combination of fulvestrant showed better result than single agent neratinib. Similar result was also obtained in the cohort of AKT1 mutation. So these trials are just highlighting that utilizing liquid is going to give us more targets. At the same time, it is going to translate into clinical benefit. So as we can see, again highlighting the same result, that utilization of AKT1 inhibitors or utilization of HER2 inhibitors based on a liquid data has given you significant benefit in terms of responses. Just few cases again. So in acquired resistance setting, we know that many a times we do not have access to tissue. In that particular time point, this case is also showing you the relevance that not only in a prior hormone receptor positive patient that ESR1 mutation was detected, it also showed emergence of HER2 amplification. So of course, that is the reason, especially for example, in lung cancer, we always want to look at the small cell transformation. We need access to tissue. In breast cancer also, we have seen switch in the profile of hormone receptors or HER2 receptors at recurrence, and liquid biopsy is equipped to give you insights into that profile as well. Another case where the rare alteration, we always talk, when it is breast cancer, we just always focus on the mTOR pathway, AKT1 mutations, ESR, and HER2. But even the rare alteration like enteric fusions, of course, they are very rare, but when we have these liquid biopsy panels which cover almost all relevant targets for solid tumors, you may see such results while reading reports of your patient. And when you are trying to utilize this information, the benefit will be observed in the clinic. In this particular case, there was an enteric fusion which was detected, and she did response. She did achieve a response when the pathway was targeted with lerotectinib. So this is about the predictive role of the liquid biopsy. What more can liquid biopsy help us with? So when we are discussing predictive biomarkers, whether it is on tissue or blood, it is most commonly in advanced breast cancer diseases. Whereas liquid biopsy has a role even in early stages of breast cancer, especially for prediction of the recurrence risk or detection of the recurrence earlier. So this is a data where detection of ctDNA during a follow-up was associated with increased risk of relapse. And this ctDNA profiling did detect the recurrence risk quite earlier. So the lead time that ctDNA offered was almost 10.7 months in this particular case study. So uh, we always speculate whether ctDNA is going to be beneficial when there is only brain involvement, especially patients who have been HER2 positive, have taken HER2 inhibitors, they relapse intracranially. So, is ctDNA going to be sufficiently sensitive in that particular situation? This particular study did address that question as well, where 20 out of 23 patients with intracranial response were metastatic were detected with a ctDNA. So this ctDNA has been proved in detection of relapse in multiple situations, whether it is detection when you are profiling a patient post-surgery, whether after neoadjuvant surgery. If you see ctDNA positivity at any of this particular time point, the recurrence risk of whether it is hormone receptor positive, whether it is HER2 positive, or whether it is a triple negative disease is going to be higher. And as we have already seen, there have been multiple interventional trials also now underway, whether based on this observation of ctDNA in these particular situations, if you act on that information and introduce intervention, whether that is going to give you benefit. And we have seen multiple studies where such interventions are being proven beneficial. Just at particular, so there are multiple approaches of MRD. There are certain tumor informed assay which have seen benefit. There are certain tumor agnostic assays which have shown some benefit, but every approach may have some limitation. And hence, at our center, the MRD detection approach that we adopt is a combination of tumor informed as well as tumor agnostic strategy, and with a LOD achieved to be 0.01%. So there are certain, of course, important factors. Liquid biopsy report, when we are reading, there are multiple factors which we have to be aware about, whether the sufficient depth has been utilized, whether a negative report, as you are all aware now, is not always conclusive. So we have to ensure what liquid biopsy assay we are utilizing and what are its limitation, or even the limitation of the clinical situation we have to factor in before concluding the further management based on the liquid biopsy. However, it has proven its benefit, not only being useful for detecting predictive biomarkers. It is also useful to detect the acquired resistance biomarkers, and it is of course helping us to detect the recurrence or minimal residual molecular disease. Thank you, everybody.
Thank you, Darshana, for that very rapid fire. And I know that, so we have to now connect. Now we're going to bring Dr. Tim Crook online to discuss the role of liquid biopsies in early diagnosis of breast cancer. There's Dr. Tim Crook is the first author on the paper in cancer. Tim, we're really missing you here. And thank you for doing this early in the morning. We actually shuffled a little bit to be able to give you a waking time. So we are here eagerly waiting to hear you talk about role of liquid biopsy in early detection of breast cancer. There's an FDA breakthrough, and there is this publication that won the best paper award for cancer for this year. Tim, we are going to set the stage for this discussion. Please take it forward from here. Thank you. Thank you for joining us.
Thank you. Thank you for having me. Thank you for asking me to contribute. I'm sorry that the visa situation prevented me from joining in person, but I'm pleased to present a précis of the work we've done on using CTC, so early breast cancer detection. We all know the challenges of conventional breast screening with mammography, summarised here. So we've been interested in pursuing alternatives, of which circulating tumour cells or CTCs are an attractive possibility. Here's a little cartoon showing mechanistic pathway of metastasis by CTCs, process well recognised now, but escape from the primary tumour can involve either single cells floating around or more biologically efficiently clusters which contain multiple cancer cells with immune cells, platelets, stroma. These are microemboli, of course, a very well recognised phenomenon in solid tumours. Cells that survive in the bloodstream will, by definition, if they've become viable metastatic foci, have the capacity to evade immune surveillance and other challenges, growth factor availability, etc. Ultimately, if they're still alive and kicking, they can exit the bloodstream and start to grow in distant tissues. This provides a diagnostic opportunity, and we've developed that to seek to identify a meaningful screening test using CTCs. How would we define CTCs? Viable malignant cells, either single or in clusters, as I've mentioned, shed by the tumour into the bloodstream. Detection of those CTCs might give an indication that there's a cancer on board. CTCs are ubiquitous in cancer. They're very rare in asymptomatic individuals or in individuals with non-malignant conditions. Finding the CTCs and being able to subject them to laboratory analysis is, as I'll show you in a moment, the equivalent of actually sampling the tumour from peripheral blood. So essentially comparable to HPV tumour tissue.
Dr. Tim, may I request you to please switch your presentation on the slideshow mode?
Right, let me recover in that. How do I do that?
At the bottom down, you have a cup like, or you can go on the top slideshow, on the left slideshow. Okay, 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 okay. Yeah, fine. Go ahead, sir. Go ahead.
Is that any better? You don't really see me. I'll continue. Sorry, I hope that's okay. Go ahead.
Sir, please go ahead.
Yeah, so in 4 years ago now, we published a paper, which I think was a very important paper in retrospect, circulating on SOM's tumour-associated cells of a doubtful neoplastic hallmark of cancer, using a different methodology from previously deployed approaches to isolating CTCs. This was more gentle, more permissive of CTC isolation. And in that study, we showed that at least 90% of all solid tumours will shed and have detectable circulating tumour cells. Those same CTCs were very rare in asymptomatic individuals and very rare in non-malignant benign conditions. Importantly, the CTCs retain the molecular imprint of cancer. In other words, they're a microcosm of the primary tumour from which they're evolved and can be used as such diagnostically. Specific information. So this study looked at over 5,000 patients with a range of solid tumours and detected, using this proprietary technology, CTCs and CTC clusters in approximately 90% of blood samples from that patient population. Frequently, these CTCs were detected in individuals who had no radiological or symptomatic evidence of having a neoplasm on board. In contrast, they were undetectable in the vast majority of blood from patients who'd never had cancer. And this excited us because it raised the possibility that detection of CTCs using this technology might have diagnostic and screening potential. In a follow-up study, we looked at 6,025 cases and found that CTCs and single cells or clusters were detected in 92.6 and undetectable in 95% of a control group of 700 individuals with benign conditions. Further analysis showed that immunocytochemical profiling of the CTCs using antibody markers specific to tissue or organ was concordant with the formal histopathological diagnosis in over 90% of those cancer diagnoses. The take-home, therefore, was that immunocytochemical profiling of circulating tumour cells could identify diagnostically relevant and useful information in suspected cancer cases. That was the precursor to this bigger study in specifically looking for evidence of CTCs in early stage breast cancer. And you can see the sort of workflow on the left and how antibody staining with breast-specific markers can pick up circulating tumour cells in the peripheral blood of patients with breast cancer. So this study was run on CLSI guidelines. There were two parts of it: case control, looking at patients with known cancer versus asymptomatic controls, and a prospective study looking at breast cancer versus patients with benign breast conditions. You take whole blood, you lyse the red cells, and you put the cells then into an epigenetically enriched medium, and then you grow up clusters, CTACs and CTCs. The case control study for this approach, 548 patients with no diagnosis of breast cancer, a control population of nearly 10,000 healthy women, and the prospective clinical study, smaller numbers of course, but comparable sensitivity and specificity, which I'll show you on this slide. So in the case control study, sensitivity even for stage 1 and 2 breast cancer was around the 90% mark. The detection of CTCs using this unique platform, very high, 100% for stage 3 and stage 4. In the prospective study, we obtained similar, much smaller patient numbers, of course, but nonetheless, the sensitivity and specificity implied in the case control study was maintained. And this test is now called Trinita. It's been commercially developed, and it's got FDA breakthrough device status for early stage breast cancer detection. Thank you.
Dr. Seventy, we have exactly 3 to 4 minutes to conclude this session, because then we are, as it is doing away with the coffee break, we have
No
gone into
worries.
the
We'll
coffee break.
save our questions for the two panel discussions that are coming up. So essentially, thank you everyone for listening through this, and thank you, Tim, for the great work that you've done, for your congratulations for your manuscript that has won the Best Paper Award for this year, and for the seminal work that has been done by Datar Genetics in this area. We'll come back to you with questions. I don't know if we can have Tim on panel later. he was on the panel. We'll see.
Yeah,
We'll communicate with you separately. So Tim, thank you so much. I just want to thank you, and we really missed having you in the room. And the bottom line here with your presentation is that what we are seeing right now in liquid biopsies for early cancer detection is just a tip of the iceberg. There are many more efforts coming through. There is Datar, there is Grail, and of course, there are newer companies coming through with early diagnostics with liquid biopsy. Breast cancer is one of the malignancies. We have pan cancer efforts. We have colorectal cancer that just got published in New England Journal. This is a field that is ever evolving. And I feel in a resource limited nation, this is the space to really, really watch out for, because screening is totally deficient in India. And when we screen and we are able to get people together in a room, we're only screening one organ at a time. On the horizon is liquid biopsy screening for pan cancers. And that is what one is really waiting for. Congratulations, Tim, and congratulations, Datar, for this seminal effort. But we have and we will wait for many additional efforts, such efforts to come through. So that concludes the precision focus of advanced breast cancer and locally advanced breast cancer. Because we ran late, we don't have time for questions in this session right now. I hope I brought a different flavor to the surgical hall A and some food for thought for you to build on as we go through our panel discussions. Thank you all for being here and listening very, very patiently to topics that don't necessarily belong in the room. Thank you.
Thank you very much, Dr. B.K. Smriti, Dr. Shona Nag for sharing this session, and Dr. Sevanti for moderating the session. May we have a group photo with all the... Sorry?
Can I just ask comments from ma'am?
Okay. Ma'am, would you like to just conclude?
Well,
the comments?
that was a great session, and as I said, it's mainly to see what is there in future. Though we did begin with, really seminal work done in the clinic, especially the HER2 low, the immunotherapy. Of course, there are a lot of questions which I would have liked to ask, but given the shortage of time, I do congratulate all the speakers for making this a very interesting session and look forward to some panel discussion we could have on these various topics. Thank you.
Thank you, ma'am. Thank you for chairing. And also, one of the main messages that came through, some of these things are in the future. But like we said, the future is now. So let's watch out for this space. Thank you. Thank you for chairing.
May I request all the faculty to please come together for a group picture while I announce the next session? Ma'am, please come. And Dr. Sevanti, please invite all the speakers. And while they are posing for the picture, I have a bad news and a good news. The bad news is that the coffee break is cancelled. As we go ahead with the sessions, in the interest of time, because we have the consensus meeting later on, so we do not want to delay, and there are people who have to catch their flights.
Can someone look for me? Someone look for the page?
Yes, sir.
Our next session is about large operable breast cancer and surgical de-escalation. To chair this session, I would like to call upon Dr. Amish Dalal, who's a consultant surgical oncologist at Sir H.N. Reliance Foundation Hospital and Research Center, Dr. Rajiv Bhatt, who's a skilled and experienced surgical oncologist who specializes in all major cancer resections, Dr. Ritu Jain, who's a medical oncologist at Jaslok Hospital, Mumbai. I request them all to please be seated here. And as moderator, I would like to call upon Dr. Neeta Nair, who's a consultant breast oncosurgeon at Apollo Hospital in Mumbai. I would like to invite our esteemed panelist, Dr. Sudeep Gupta, Professor and Head of Medical Oncology and Director of Tata Memorial Hospital and ACTREC, Dr. Nikhilesh Borkar, who is a consultant surgeon with the Division of Surgical Oncology at Sir H. N. Reliance Hospital, Dr. Kopikar, Dr. Advani, Dr. Anushil Munshi, Dr. John Benson, Dr. Ali Sever, Dr. Gaurav Agrawal, Dr. Amol Kakre, who's a consultant radiation oncologist at Sir H. N. Reliance Foundation Hospital. Dr. Rosina Ahmed, who is a breast cancer surgeon in Tata Medical Center, Kolkata. Dr. Karuna Luthra, who's the Director, Department of Nuclear Medicine at Sir H. N. Reliance Foundation Hospital. Dr. Preetham Kataria, who's a Deputy Consultant with the Medical Oncology Department at Sir H. N. Reliance Foundation Hospital. Dr. Saloni Desai, Consultant Radiologist at Sir H. N. Reliance Foundation Hospital, Dr. Antonella Grasso. And now comes the good news. The good news is that the coffee is still available outside. Those who wish to grab your cup can grab it and come and be a part of the panel discussion as Dr. Neeta Nair now takes it on forward. Dr. Neeta, I can get you your cup of coffee
No,
here if
I'm
you
good.
want.
Thank you so
Thank
much.
you. Please go ahead.
So I think Dr. Gupta is choosing to step out and finish his panel for the next session, if I know so. But what I'm going to do is I'm going to reach out to both of y'all for questions. Shona, you're not allowed to run away. So while we talk about large operable breast cancer, we're going to shift focus back to a little bit of surgery. We've heard a lot of liquid biopsy, a lot of where the future is now, as Shivanti said. But we're going to talk about what our reality actually is. Welcome to my esteemed panelists and chairpersons. And how we're going to approach this is just look at it as real world considerations for where we are today. When you talk of large operable breast cancer, and this is for the students in the room, you're talking about anything which is a 2B to a 3A staged cancer. Anything that's greater than 5 centimeters, N0 or N1, and M0. I'd like to bring to your attention when it says something which is anything greater than 5.1, that can range from up to 5.1 to 25 centimeters. This is data that we had published from the Tata Memorial Hospital, where we looked at the kind of large operable or locally advanced tumors that we were seeing. The median tumor size for that group was about 6 centimeters, and it ranged to about 25 centimeters. So we need to understand that this group is very varied, and you cannot treat it the same for every patient. And this is where you look at personalized medicine in surgery, I would say. This is a group that I don't think we have a debate where we're talking about a metastatic workup. And what I've put up for you is the NCG, or the National Cancer Grid Guidelines, which said that it was essential to do a metastatic workup. The choices given were fairly varied. And I'm going to ask the group that we have with us is how many of us are currently comfortable not offering either a CT scan, bone scan, and a PET scan, and going ahead with an X-ray and a USG abdomen pelvis in a group of locally large operable breast tumors. So we'll start with you. Can we get the panelists a mic, please?
Yeah. Yeah, it's working. Well, the question is whether you can omit the standard of care imaging in terms of
Get suboptimal imaging, but do some imaging.
well, in absence of symptoms or clinical findings, and wherever the patient and the system doesn't have the resources to carry out the standard of care, well, yes, we have to do it, but then it's like compromise. It's not the standard of care.
So, Rosina, your take. And how we're going to look at this is India is a fairly varied country. Most of us are from towns and cities and larger cities and have access to care. That's not something that we see for all our patients across the country. Rosina, you come from a fairly large center in Calcutta.
Yes, but if in a situation where you would accept that sort of imaging, you also have to accept that the treatment will not be, all these other things that we're talking
Correct.
about. These two things don't go together. If you're going to go for modern breast cancer treatment, then you need to do the whole thing in that way.
So you start with optimum workups to get
Yeah,
optimum care
absolutely.
for your patient. So, Nikhilesh, I'm going to ask you this, and you currently work at one of the biggest hospitals in Bombay. We're standing in it. Is would you be comfortable to say PET scan for every patient, Or is it now your go-to investigation for a workup, or do you still ask for a CT and bone scan in most patients?
Most patients, I would ask for a PET scan.
So we have a nuclear medicine specialist with us, and I'm going to ask you, one of our bigger concerns has always been when you're talking about a PET scan, is you talk of possible concerns that get raised in terms of mediastinal nodes coming up, additional biopsies. Has technology given us enough to remove this ambiguity, or are we still there?
Um, See, the things which we have to understand is today what we call a PET scan includes a whole body PET scan and a diagnostic CT along with it. So a lot of previous papers and guidelines were based on the fact that a PET scan may not be able to interpret lung nodules, but now a HRCT is part of a routine whole body PET CT. So the lung part is clearly sorted. As far as bone scan is concerned, we know that on a bone scan, whether it's a healing metastasis or whether it is actually a true active disease cannot be differentiated. And therefore, a PET scan definitely scores over it. And overall, when we're talking about sensitivities, a whole body FDG PET scan in a high grade breast malignancy has a sensitivity of at least more than 95% as compared to about 81% for a bone scan. So you see, and these ambiguities, yes, in the Indian setting, we do have situations where mediastinal nodes may be positive, but when we are looking at a breast cancer, looking at the pattern of nodes, if I don't see axillary nodes, if I don't see internal mammary nodes, and if I see mediastinal nodes, I'll know, what's happening. So we kind of play on the pattern. We try to interpret it accordingly.
So I think that's where we've come to today is there's a lot more information that we have available to us. It's a clinical radiological discussion and a consensus that one would come to. Choosing to opt for the PET scan, from what I understand from our experts, is that it is going to be the optimum choice we can offer to our patients, but it's going to be some investigations versus nothing at all. And where we are technology and clinical radiologically today, we're more or less fairly accurate in being able to use it for diagnostics. I'm going to pull Shalaka into this just because you see a lot of patients who you will not have the resource availability to possibly get a PET scan in all your patients. Um, do you think it's suboptimal to not do a PET scan? Are you happy to have a CT and a bone scan with that? We were doing X-rays and ultrasounds then.
We were happy for the general OPD to do chest X-ray, ultrasound, bone scan. And unfortunately, we had that kind of a division that, okay, when you're posted in the general OPD, you ask for chest X-ray. Nakilesh would remember the same. And if you're in the private OPD, you ask for a CT and bone scan. Today, I think we've also stopped doing chest X-ray, ultrasound, bone scan because if you mean to get a metastatic workup, you mean to get a good metastatic workup, unless the patient really can't afford. But we have a lot of centers, even in Tata general category, NC, government funds, we can get investigations done. So it's either a CT bone scan or a PET CT. To be honest, it's as per the next available date, a lot of times for me. Happy with both of them.
So we're looking at some functional imaging, Dr. Munshi.
Shweta, you would also be aware of the recent randomized trial that
Right.
had came up and that told that around 10 to 15% cases it lead to change of plan compared to a CT-based
Bone scan.
plan that had been
So
done.
that's what I'm saying. Functional imaging does give us that advantage, and we're going to try and do that as our optimum. But of course, there are going to be situations across the country where that's not going to be the answer. Changing the track a little is that, okay, we've worked up this patient, we've got no distant disease anywhere else, we've got a biopsy, we've got receptor status, and I'm going to pull our medical oncologist into this conversation. When you talk of a T3 tumor, she could be a 5.1 centimeter tumor. Your surgeon tells you she's amenable to some sort of extreme oncoplasty. You could operate upfront. This is something that you could potentially also operate first versus give neoadjuvant chemotherapy. If she's low grade, would you be happier to have us operate first so that we're able to stage the axilla more accurately? Or would you still want to give neoadjuvant just for sheer stage and size?
So, as we all know that the ERPR positive tumors may not respond that well as compared to triple negative or HER2 positive tumors to a new adjuvant chemotherapy. So, wherever possible in the upfront setting, if the skin is not involved, if it's a T3N0 disease in an positive, PR positive tumor, I would like to you to go ahead with the surgery first and then consider for the
So, do you
adjuvant
think
treatment.
that addition of adjuvant and endocrine plus abemaciclib has also changed that for you, or is it just purely based on the receptor status?
So definitely it's based on the receptor status because the role of the abemaciclib with endocrine therapy would be more in an adjuvant setting. Definitely we'll like to look at the other characteristics. What is the Ki67? What is the grade of the tumor? Not just the size. So that would really give us an age in deciding the abemaciclib in adjuvant setting. But as we all know that in a new adjuvant setting, still the chemotherapy doesn't have that PCR rates as we have in triple negative or a HER2 positive disease.
So, I think what we can take away from that is that you can always opt for upfront surgery in a T3N0, which is ERPR positive, as long as it's amenable to it. And Dr.
Neeta,
Munshi.
I've been reading recently about attempts to increase PCR rates for ERPR positive
Right.
population as well, using CDK and other things. So, would it benefit the surgeons as well, for example, this kind of a scenario?
So I'm going to tell you that with ERPR, you're going to possibly see a little scattered response. You're never going to really see good concentric response. So that sometimes can make the situation more complicated than simpler.
Can I add
Dr. Kopikar.
can I add something that might be very controversial, but I want
Extreme
to add.
oncoplasty.
No. What I'm trying to say is, what is the age of this patient?
So assume she's a postmenopausal lady.
Yeah. So why don't you give upfront hormone therapy?
Hmm.
Don't don't bother about your abemaciclib, etc. But we know that even just primary endocrine therapy has a good response.
Absolutely.
So you can actually measure the response of the endocrine therapy on this patient if she's postmenopausal, and then probably that would help you plan adjuvant therapy later. Basically, if she is N0 to begin with, and then you find that she is N0 at the end of your and you have a very good partial response, or you may have in about 10 to 11% of patients a complete response, then you could probably choose this patient for only endocrine therapy going forward by adding your abemaciclib or whatever else, and you could probably avoid chemotherapy completely. So this is a thought that has always been in my mind for postmenopausal patients.
That's very important point, and I think from the surgical point of view, and certainly what surgery are going to offer. I mean, we seem to forget right from the beginning that the neoadjuvant, for example, systemic treatment was not necessarily to achieve complete pathological response. It's
Just to
actually
do
to reduce the disease.
BCS.
And we seem now to keep talking that if we are not expecting complete pathological response, forget about neoadjuvant chemotherapy. I don't think it's getting
No,
confusing
absolutely.
message.
Yes, absolutely.
We have a simple, or I personally have a very simple formula in terms of the neoadjuvant chemotherapy in particular. If the patient is going to have chemotherapy, in other words, from all the multidisciplinary team decided that they're going to have chemotherapy, I always prefer to give it upfront. One, we are again assessing the response. Two, we may improve, in actual fact, the local disease, which we may convert patients to breast conserving surgery. But also, most importantly, now we have the different modalities of systemic treatment in patients who did not have complete pathological response. So there is a great benefit. The only snag is that when the indication for chemotherapy is borderline, and
That's when you'd operate
that is where it
upfront.
becomes
I think that's a point very well taken. Yes, Nikhilesh.
This patient, we might do a oncotype DX, and if
So
the score
that's what
comes
my
low, we
next
might avoid the
question
chemo.
is that are we comfortable with Oncotype DX in a T3 N0 today, since it was developed for early breast cancers only? But we have started moving it. So I'm going to bring the medical oncologist into this.
So I think a controversial point, but still, if you look at the Oncotype DX guidelines to be sent for T3, so more than 5 centimeter tumor, we would be not still comfortable sending Oncotype DX. So the tumor which are less than 5 centimeter, or
Yeah, so we're discussing T3s.
yes. So for T3, we would not be comfortable sending Oncotype DX until unless the patient. I mean,
Yes,
definitely.
I'm going to tell you that I actually looked this up because I decided to look up whether there were patients that had been asked this. And there are multiple patient forums on which patients have put up, having been asked to do the Oncotype DX despite being T3N0, have a low risk disease, and then were asking for opinions from
oncologists across the world. So it is something that we have brought into clinic, and I'm not sure where the evidence for that is. So if you look at the TAILOR-X study, I think T3 was 0 patients in the representation. If you look at RX Ponda, it's about 5% of the patients. Shalaka, you wanted to say something.
So, just one point, Nita, that even for planning neoadjuvant, we do look at grade and even the ALRED expression of how ERPR positive it is. And some of those with ALRED 3 by 8 rather act like
No, so
triple
there's the argument isn't about whether you're going to give chemotherapy or not, and you're going to discuss in your MDT exactly like he said, is whether this patient is eligible or requires to have chemotherapy. If she is not being planned for chemotherapy, are you happy to operate upfront in a T3N0 versus would you want to give hormone therapy, etc.? So, would you want to give neoadjuvant hormone and reduce and downsize it versus would you operate upfront? So that's where we are, and I think some of us would go ahead and operate upfront.
There could be a easier way out rather than waiting for response. You do a Ki-67 after 15 days, and you know whether this patient is responding to hormone therapy.
That is also one angle, but I mean, I think we've heard so many times during the conference about how important the quality of life of this individual. So it is not just focusing on the entirely on the oncological where it is has the priority, but also, for example, if I give these patients chemotherapy and I discuss with the patient and I say, I am prepared to see whether I'm actual fact I can be converted from breast conserving from mastectomy to breast conserving surgery.
Correct.
I think that has to be taken
So
also into
absolutely.
consideration.
So if we're looking at downsizing the tumor to look at BCT as an option, then we're looking at some sort of neoadjuvant systemic, whether that's chemotherapy, hormone, and or CDK4/6, versus we're at a position where we have a large D cup size breast, 5 centimeters, allows you to do a breast conserving surgery. Would you be comfortable going ahead? And I think T3N0 is that group where you could have that discussion. I'm actually going to ask Dr. Smriti and then Dr. Gupta is comfort on using Oncotype DX in large operable tumors.
Well, I am not really comfortable in doing Oncotype DX in a T3 or T3 patient, so I wouldn't ask for it.
Dr. Gupta, any difference of opinion on that?
None whatsoever.
So I think that's where we are, is that we need to recognize and look at what the studies evaluated and what was the subset group in the studies and how we are extrapolating that into the clinic. And I don't think the T3s are part of that discussion yet. So where your patients are triple negative or HER2, I think the debate in neoadjuvant versus upfront is only in the early stage tumors. For the large operables, we're fairly clear that we'd want to be able to give our patients neoadjuvant chemotherapy. Our goal here is both downsizing as well as achieving PCR. And just going to ask the group at large is how many of your patients are able to take dual targeted therapy for a HER2 positive group? So you work with a national institution, so your experience on that.
Yes, quite a few patients now. It's close to one third of all patients are being given dual into HER2. The problem that I see right now, ongoing problem, is that our national programs, the Ayushman Bharat and so many other schemes, they do not permit pertuzumab. But yes, quite a few patients are now being given dual into HER2.
Rosina, any difference with your
Relatively
practice?
small. I don't think it's one third in our hospital. I mean, it's probably somewhere like 15 to 20%, I would say.
So any experience from the UK, which is different on use of dual HER2 targeted? Is it part of the MDT guidelines? Is it mandatory for all patients to be offered dual HER2? Are able to take it. Let me put it that way. The NHS would probably cover it.
Well, again, we are almost following in at guys and most probably UK. We are following what we discussed yesterday about when do you use the dual targeted, and that is again in patients who need it, then they actually have it upfront. And the only difference is that when we are dealing with tumors, which is less than 2 centimeter, because the chemotherapy component may be different when they are node positive or node negative. This is the group where it is, if it's possible, we do the surgery first.
So I think that debate will stay forever in early breast cancers on TNBC HER2 operate versus neoadjuvant. That debate's not going anywhere. But for the large operable tumors, I think we're fairly clear that we're doing that. Yes, Nikhil.
So one advantage of giving a neoadjuvant dual targeted therapy, as per the Neosphere trial, we have to give just 4 cycles of pertuzumab. The cost is less. Then if we consider we operate and then give adjuvant,
But I
then it
think
becomes
most of us don't
17
use
cycles.
affinity as much
Yeah.
in terms of doing it with dual targets in adjuvant. Where we would try and use it is probably the
So
neoadjuvant
in
setting.
neoadjuvant, many patients of mine will be taking, but in adjuvant, it is very difficult to convince for 17 cycle. The cost becomes an issue.
Fair enough. So we do need to look at financial toxicity and take that into consideration. I think that's an extremely important part of that. So fair enough, our patient's going to get planned for neoadjuvant chemotherapy. The first point that we need, and this is, I think, an appeal to all our medical oncology colleagues, is please make sure that the tumor is marked, both the primary and, if possible, the lymph node, if we're looking to move ahead to be able to do some sort of conservation later. The optimum marking, of course, would be that of a clip in the primary, but I think we know of other options. Dr. Gaurav Agarwal has been quite vocal about his choice on other options, and I'd just like to hear 2 words on that.
Yeah, uh, clipping of a tumor before initiation or soon after initiation of neoadjuvant chemo or targeted therapy has been the standard of care for quite some time now. So I would emphasize it is standard of care. If you are not offering this, you are offering something less than that. Now, the choice of what kind of clip you can use, as you referred to, we've used this low cost indigenous innovation where we use
Surgical
initially
clips.
silver wire sterilized, or now a Liga clip, which is a surgical
Straightened out.
clip straightened, loaded onto end of a lumbar puncture needle, and then inserted at the core of the tumor. And in certain selected patients who have patchy response after, say, 2 cycles of neoadjuvant chemo, at the margins to bracket the tumor. And that works fairly well. Migration of clips is is a possibility which has been discussed a number of times, but in our own experience with a fairly large number of patients, close to about 1,000 patients where these have been used, there been not even a single patient where we have faced real challenge due to migration of the clip. And that is for the primary. As for the lymph node, we have not been doing it routinely because, well, that is one area where it's still short of standard of care. It is an optional thing, perhaps desirable, but not mandatory.
So just to bring Dr. Benson in on this.
Yes, I've been doing this, we call the coil insertion inside the index lesion.
Okay.
For a good 25 years. I've never seen one being migrated. So it doesn't happen. Breast is not a hollow organ to travel somewhere else. What can happen is that if you put the lesion in the bit of a periphery of a large mass, obviously when it shrinks down, the residual lesion will stay off from the marker. That can happen. To avoid this happening, maybe instead of putting it in advance before the neoadjuvant chemotherapy, maybe you can put it in the first round or maybe it's after the second course, something like that. But you have to be cautious, obviously, because it can disappear. You might be too late to do so. At our experience and in our audit, 75% of the lesions that they become sonographically occult by the end of the treatment. So if you don't do this, there's a good risk chance that you will miss the lesion. And obviously, we do also know that half of the cases where we say complete imaging response, we do still see that there is
Correct.
pathological residual tumor. Uh, in regards to the axilla, we do put a small marker into the axilla.
So are you using just clips for it or using radiocolloid?
We are no,
Magnetic seeds.
we use we got the coil for the index lesion, which is a
Correct.
longer thing, and it can be anything. To be fair, I mean, I'm sure that you can produce something which could be much cheaper. The hydrogel marker is we are using for the satellite breast lesions when they're small because it does not give a bit of a signal void artifact on the MRI, so that you can still see those tiny 5, 6, 7 millimeter foci still thanks to this hydrogel marker, and also use the same marker in the axilla, which won't obscure anything.
A couple of things about the tattooing or stitch. I will be very skeptical about this because we are not dealing with an organ which does not go through changes. So where you are going to put your tattoo, that's one question. And wherever you're going to put the tattoo, I don't think that we will be able in complete radiological response. I don't think that I will be able to get, as a surgeon, I'm going to get an accurate location of the tumor. That will be very risky, I think, whatever you modify. In terms of the clipping the axilla, I think this is absolutely crucial. If you are actually practicing de-escalation of the axillary surgery, because we all know that the biopsy node is the most crucial node to recover, to be
Absolutely.
actually able to stage. And therefore, if I'm going to rely just on the sentinel node biopsy technique, we know that at least one third of
The clip node will be uh, not the sentinel node in about 30%. Yes, sir.
Yeah. So just to ask Gaurav and the rest of the surgeons here that if you have a radiologically positive node up front and you've given NACT, you will proceed for axillary clearance at the time of the surgery when you do it for the primary. What happens in the N0 situation, radiologically and clinically? If we are not clipping, what is the policy then for axillary management
If it's
without getting into the acrimony of yesterday?
no, if it's N0 up front, then you're going to do a sentinel lymph node biopsy. In any case, there's nothing to clip then. So you can't clip it. So, if it's N0, you're
You
going to
will
do a
you will go with the standard sentinel lymph.
absolutely.
Yes. So I'm actually just going to ask for a show of hands from the Indian audience in the group is how many of us are clipping lymph nodes prior to neoadjuvant chemotherapy?
We are doing a study at the moment using.
I'm going to say standard of care.
So, yeah, so as part of our study, we're doing it.
Okay.
Can I make a
So we have one person who's put their hand up, and I'm going to say that unfortunately is where we are in the Indian context.
Yeah, I think, what he said was right, but I think it has been shown very clearly that you do TAD or you don't do TAD, finally the results are the same. I mean, local recurrence and whatever you have. So sentinel node post NACT, when you remove 3 or 4 nodes, it's as good as doing a TAD.
So
The
I'm going to
other-
say that it depends on
I
the
know.
nodal burden. If
Yes.
you've got a small node, and you're happy to discuss that.
Right.
When you've got a fairly large node, which is
Yeah.
still N1, but it's a fairly large node, you're not sure if it's just that one or two. I think one would be a little skeptical not to be able to do targeted dissection.
One more thing about the clip placement. After reading his,
I think a lot of us are doing that
yeah.
now.
So the only modification we did was that we did it after 2 or 3 cycles. Because I believe that the tumor, when you are trying to target the center of a tumor in a 3 centimeter tumor versus a 6 centimeter tumor, you might miss the center when you are doing it upfront. So do it after 3 or 4 cycles when the tumor is really reduced in size. And then we place about 4 Liga clips.
So that goes
And they
crisscross
will
across
crisscross
it.
across them so that they don't migrate. One thing, if at all there is I've never seen it migrate, just like they said. But on the ultrasound, it's very easy for us to pick up those 4 clips.
Yeah, I think the Liga clips
Rather
are a
than
little easier
one-
to pick up than some of
one clip,
the
then
coils that we have.
Yeah, rather than only one clip or one little marker. And we don't have the expandable markers that he was talking
The hydrogel, I don't think we
Hydrogel
have
we don't.
access to.
And just back to the issue about clipping the axillary node, I think it is doesn't matter. It does matter because we in at least 1/3 of our patients after neoadjuvant chemotherapy, the only positive node was the clip node.
So about 30% of the clip nodes are going to be the non-sentinel node. So you're going to
Even apart from that, what
And
I'm saying that
continue
it
to be
It is
positive.
in actual fact to the residual disease. You will only see it in the clip node, and therefore, if I'm missing this node, I'm missing up the whole management of the axilla after neoadjuvant chemotherapy.
I just don't want to give you a misinformation in regards to the UK. I mean, guys in St. Thomas is we are doing this marking of the node, and I
But
see
does it
that as
happen
well.
across the UK?
In the UK, I can tell you only 5% of the hospitals are doing that. 95% are not doing it. They're just
So-
going A and C with any positive notes. That they don't mark the notes.
So I think that's where we are today. Is we're definitely marking the primary,
but
One
we are
last
not
point just
necessarily
on
doing
this.
it.
If he says that, I don't know how it's going to change the management of the axilla.
So, Dr. Benson, I'm going to bring you in on that also. Yes, can we have a question from the audience also. You wanted to say something, sir?
Oh, no, I was going to say we do clipping of the nodes. It's still a bit controversial in the UK, but I would still maintain that most people believe in the principle of clipping of the node. But you can have, 3-node sampling with dual localization. The problem with that is ensuring, that you've retrieved at least 3 nodes, and some people find that a little bit more.
So I'm going to say that, with a smaller tumor, with smaller nodal burden, these are conversations that we may be happy to accept. At a T3N1, I'm not sure where we're happy to take that. And I think that's a reality of our country, is there's a slightly different tumor burden where I would be very apprehensive in leaving behind a node that's positive or potentially positive for somebody like that, where then I need her coming on follow-up every 3 months, 6 months, making sure that we get accurate imaging.
Thank you for and also there is a very important point about changing the management of the axilla. If there is residual disease after you
Yeah,
adjuvant
we're
chemo,
going to do
I'm going to do
clearance.
axillary clearance.
Yeah.
So it does make a difference. That's number one. And number two, as far as the 3-node biopsy, I don't think that we keep talking about initially we accepted the false negative of 9% or 7% in cases primary presentation. I don't think this is we can carry on saying
The same numbers
after
in the
neoadjuvant
neoadjuvant.
chemotherapy.
Agreed.
Because these are residual
This is worse
resistance.
biology. I think this is dictating something
Exactly.
else. So we need to
So
have
we
slightly
cannot
different
rely on
standards for that.
absolutely.
Point well taken.
Yeah.
Yes.
But the
So
rates of
just going to raise one more point before I shift focus on what we're going to do is how many of us are using an MRI to assess to assess response assessment? And I'm not going to ask the UK faculty. I'm going to ask the Indian faculty first. So we have Nikhilesh and anybody else? Dr. Dalal doesn't seem to be agreeing with that. Do you use MRI routinely to assess PAT-CR or to evaluate response assessment?
No, not really. I mean, I would go by the
Mammogram.
mammography and maybe a sonography along with it.
Fair enough.
And usually they'll have a clip out there, so the radiologist knows where they are looking at.
Yeah,
Rosina.
not routinely, but in patients with dense breasts who have an MRI at the beginning.
So fair enough. If
we're
you've
going
done
to
an
get
MR, that's going
Yeah,
to be
then
your
we're going to
next
get
step.
it.
I'm talking about using it
No.
as a routine just for assessment
No,
of
not at all.
response. So we're not there yet. And I think a lot of it is not just resource constraints, but also utility and requirement. It's not particularly changing our plan because we are going to go ahead with it based on routine imaging. You want to say something,
We
Dr.
are
Sarkar?
using it, but I can tell you that you don't need to.
Fair
Honestly,
enough.
That's
Point
very
very
rational.
well
it's
taken.
waste of it's resources.
yeah, but I
So
think
absolutely. So
I
that's
mean,
what I'm saying. Most of us would continue to use the mammogram and
hardly ever
ultrasound.
you would see who is not responding, and I'm sure the ones that were non-responders can be also picked up by the clinicians.
Yes.
And then ultrasound is a wonderful modality to pick that
Completely
up. I
agreed.
mean, we are using it just for
Would,
no good
would
reason.
anybody use a follow-up PET CT?
So would anyone use a follow-up other than the medical oncologist? Would anybody else use a follow-up PET CT?
No, if they've progressed in the breast, then
Not progress. This is response.
otherwise,
So
no, not at
routine
all.
response post NACT. Fair enough. So
I've been trying to
okay.
I've been trying to dissuade its use. Unfortunately, not very successfully.
So you get your
So
medical oncologist to come and
that's
meet
right.
ours.
So it's some person in the team
Oh,
somehow
yes.
mentions it, and the patient is more than happy to have
Now,
it.
once you talk to a patient about it, they're going to get it done. I was just telling Shalaka this. I have a patient who came to me, 0.7 centimeter lesion on ultrasound, has a PET. I said, can you get a mammogram done first? So she had come workup of everything else done except for yeah.
Maybe the only indication, not mid-treatment, end of treatment, if you are going to change your management from mastectomy to lumpectomy in regards to complete imaging response, that might be the only indication to use an MRI, and then you can decide. And again, ultrasound can give you pretty much same information. But mid-treatment MRI is wasted.
Completely waste. All
Doctor,
right.
sorry, I'm digressing, but have anybody seen hoardings, advertisements of a mammography machine anywhere in the country?
Never.
And
But
how
of a
many of
PET
us?
scan for sure.
Okay, there lies the answer.
Okay, so we're just going to jump across to, I think this is a group that we're all quite happy to do breast conserving surgery post NACT. The debate still continues only for the T4 disease. I think with T3, we're quite happy with that. We did see data that came out in 2018 suggesting something related to a higher risk of local recurrence. Fortunately, a lot of that was potentially related to the two studies where no surgery was done. So, Dr. Gupta, if you're listening, we're still not out of the door as surgeons. And tumor localization is not our only job, but that is also an important thing. And that's why we need to map disease properly. Heterogeneous response patterns are associated with higher risk of recurrence, which is where getting appropriate mapping of disease, both pre and post NECT, is necessary. And I don't think there's a debate for us here on being able to offer a patient who has been downsized for a T3 disease a new using neoadjuvant systemic therapy, whether we can offer breast conserving surgery. My concern here, and I'm going to raise that to our radiation oncologists. First, we're going to start with the surgeons on do you excise the original tumor bed versus do the clipectomies or follow what is the current bed?
Start with me. Oh, yes, we remove what is necessary to be removed. So, if a complete clinical response, radiological response, clipectomy is the way to go. If the patient has patchy response and you're concerned there are islands of tumor all
Then
around,
you go wider.
and you have a bracketed patient, you do wider excision. Otherwise, the remnant tumor with sufficiently wide margins.
So, any
And any calcifications. Be
So
careful of that,
absolutely.
sir.
So, Dr. Munshi, is that when you have a patient who had a 8 centimeter tumor to start with, we gave neoadjuvant chemotherapy, downsized it. She has almost complete clinical response. We excised that 1 centimeter there. What is your boost bed?
So tell me, why do you excise just 1 centimeter?
Because that's what's the residual disease now.
So you think that is the only area at risk now?
So that's what my
So
concern
why
is
do you
on that.
extrapolate the boost principles to the initial volume then? So
Anushil, the reason for removing that 1 centimeter is to provide the pathologist the most
Whether it's PAT-CR or
because
not
you
also.
think
Yeah.
that is
representative
the
tissue for.
area that is at the highest risk of possible disease.
Well, not really so.
Not really
What
so.
I'm saying is that this is just an exercise to provide the pathologist with the most representative tissue to determine if the patient has achieved PCR or not.
Correct. So that
And
is
this
where the
should not
disease
be
could likely lie.
exactly. So
So would your
this
Right.
boost include only that?
Mostly it would be to a margin area beyond that, but not certainly that 8 centimeter and beyond. That would cover the
So
entire breast.
fair enough. And I'm going to ask one other question. So then we also see a couple of patients who have calcification, which is still beyond that. And you've been part of these cases where we've done what we called large volume excisions, and I give you an 8 centimeter cavity.
Now,
So
this perpetual debate is whether the volume that has been replaced, whether the inside of that volume is also
volume,
at risk.
correct.
So that is the debate that number one. So if you irradiate just the peripheral area of that, would that suffice? And many people have been doing that. However, the kind of arrangement that we have for treating breast is kind of a predominantly tangential kind of an arrangement. We don't usually treat full arcs. So you invariably end up, even if you want to spare, you invariably end up treating a big volume of that replaced tissue inadvertently as well. So,
So fair
so
enough. But so
that's where you are.
is that the case for majority of patients who have undergone plastic breast surgery.
yeah, so one is hoping that we don't do them for 8 and 10 centimeter volume replacements and that we have this MDT with our radiation oncologists also to understand what our boost volume is going to be so that we're able to do what's right for our patients. Yes, please.
We've actually had very interesting discussion yesterday. Is that the surgeons keep de-escalating, and the
Everybody
radiotherapists
else keeps
keep
escalating.
absolutely. So the point is that what is the point of giving patients chemotherapy, and then at the end you are going to ignore the effect of that
of it.
So just I wanted to add as a radiation oncologist, whatever sir has told definitely. But the thing is that many a times the response is not totally circumferential. Its response to the chemotherapy can be scattered. So as a radiation oncologist, it is difficult for us to finally correlate the clinical initial tumor disease as compared to what was on the pathology as a pathological response. So as sir mentioned that we do have tangential fields. That is why the whole breast radiotherapy has a lot of significance, because those microscopic metastases can be adequately treated. And of course, the tumor bed
No,
which
so
is
you
there.
are going to give a whole breast radiation for
Yes,
sure. The
definitely
point
we are
is,
going to.
yeah, the point is your boost going to be the original
The
volume
boost
or the
volume, usually we tend to follow it, what is the pathology, post pathology, post surgically. But at the same time, we also keep in mind that if there is a large volume disease has been there, and we tend to sort of, whatever is the tumor bed, we follow the clips, but also the abnormal areas which we see that can be present on the imaging that we do for the radiation planning,
so that's
also
where your
taken into
MRI will come in.
also taken into account. And
So, Neeta, the other point is that for such kind of patients, the 15 fraction schedule, the start trial is reasonably okay, but not the 5 fraction.
Correct.
One thing in the baseline MRI, when we are dealing with a very large tumor, and especially if it is multifocal, then we do say, as radiologists, we are saying that this patient should have mastectomy regardless the response. Then even if they are getting neoadjuvant chemotherapy, the decision is being made in the MDM beforehand by saying that this patient should not be changed with
So I
management.
think one has to be a little cognizant of the volume of excision, not just for that breast, but also what it's going to, how it's going to impact the other modalities of therapy, and take that into consideration. So we've got our last 30 seconds left, and before she starts screaming at me, we're just going to run through is that we're fairly happy to do a sentinel node biopsy for patients who have clinical radiologically been proven to be N0. Where we are for N1 disease, I think if we are not clipping the node, we need to be a little careful about whom we're offering it in. We are doing a lot more samplings for that group, and we have Dr. Vani here. And Madam, are you currently following LAS post NACT um, for patients who become N0? Can we get a mic to her, please?
Yeah, so for as far as the post chemotherapy N0 patients are concerned, we are following low axillary sampling. But the decision to do or not to do beyond this, I think, is a lot more dependent also on what kind of residual disease there is in the primary. If there's a large disease but differential response in axilla, I wouldn't be very comfortable in that disease to actually not complete the axilla. But yes, in some of them, yes, I would be comfortable in doing a low axillary sampling if there are at least 4 nodes picked up. So the number of nodes that you're able to harvest in the low axilla will also tell you this. If there are all 4 nodes are going to come out as positive, and I think it's better to complete the axilla in that situation. But if there's 1 node positive and you've been able to get, say, 4 or 5 nodes, probably I would be able to look. But
In a
in
post
majority,
NACT
in a
setting.
post NSCT majority, I would do a clearance.
Yes.
This is always a debate.
Just a word of caution when we extrapolate the response in the axilla from the breast. I think in about 26 we've
It's
done this workup,
discordant.
guys. There is
Yes.
this concordance. So I don't think that we can extrapolate.
Right. So just one last word is that now the next step, and like we said, we are de-escalating, they are escalating. We're also looking at radiation replacing axillary dissection for node positives, even post chemotherapy. The study results are still awaited, but that's going to be where we're going to be moving in that direction, I think, soon enough. Thank you very much for your attention.
Thank you very much, all the esteemed panelists, Dr. Neeta Nair, the chairpersons, Dr. Amish Talal and Dr. Rajiv Bhatt. May I request you all to please come on the podium for a group photo?
What if he goes behind me?
Thank you very much. We move on to our next session, which is again a panel discussion on advanced breast cancer, metastatic cancer, and precision. And as chairs, I would like to invite Dr. Mohan Menon, who's a medical oncologist at HN Reliance Foundation Hospital, Dr. Sevanthi Leme, the Director of Medical and Precision Oncology, Dr. Urvashi Jain, Consultant Oncoplastic and Reconstructive Breast Surgeon from London, UK. And as moderator, I would like to call upon Dr. Sudeep Gupta, who is one of the most eminent and respected medical oncologists and the director of Tata Memorial Hospital and ACTRAC Mumbai. In breast cancer, his areas of research include adjuvant therapy and management approach of metastasis from breast cancer. He's the editor-in-chief of the Indian Journal of Medical and Pediatric Oncology. May I quickly invite the panelists, Dr. Alistair Ring, Dr. Shona Nag, Dr. Philip Kootmans, Dr. Michael Gnand, Dr. Vani Parmar, Professor Chintamani, Dr. Ali Reza Siva, Dr. Hisham Hamid, Dr. Mary Ann Joseph, Dr. Nitesh Rohatgi, Dr. Eleanor Sawyer, Dr. Anjana Sainani, Dr. Timothy Crook, who I don't know, is he joining online? Okay, he's not joining. Dr. Michelle Parekh, who is a consultant ortho-oncologist at Sir H.N. Reliance Foundation Hospital, and Dr. Vikas Talreja. I hand it over to Dr. Gupta.
Connector.
So while the presentation is coming on, first of all, I would like to thank Dr. Hari Bhakti and Dr. Limaya for their invitation to participate in this excellent conference. We had such a great panel discussion. Dr. Neeta Nair was in her elements, and I think the panelists were up to the task. So just a little clarification. I'm neither the director of Tata Memorial Hospital nor ACTREC. I'm the director of Tata Memorial Center, and those two units have their own directors. So since this is a panel discussion that involves precision oncology, I thought I will request my good friend, Dr. Sevanti Limay, who's one of the most precise oncologists, to actually do the honors. So Sevanti, please come up. She has a series of excellent cases that she will put up for the kind consideration of the panelists, and then we'll elicit your opinion. So Sevanti, the floor is yours, please.
So, sir, I am just the case presenting student of Dr. Sudhir Gupta. That's the designate here. And I'm honored to be. So, he's the reason why I'm in India. And that's an honest declaration. So, I owe it to him everything. So, just beginning. So, first is a hormone positive advanced breast cancer. And this is a 53-year-old postmenopausal female, no significant family history, presented with lumps in both her breasts. And in the PET scan, you can read here lesions involving upper inner quadrant of the left breast, uh, irregular soft tissue density involving upper inner quadrant region of the left. Right axillary lymph node was also positive, multiple bilateral pulmonary nodules signifying metastatic disease. And the biopsy was done from the left breast lump as well as from the right breast lump, and ERPR positive, HER2 new, score was 1 plus. And at the time, we would call it HER2 negative. So the questions.
Go ahead, go ahead. I'm also
Questions?
looking at the cases along with yourself, so please.
So questions for the panel. How do we go about the next steps? How would you choose?
A very brief answer. This is Ribo, based in my practice, based on the overall survival benefit.
So I'm actually quite comfortable with all three in the metastatic setting. And we are lucky that we have a lot of generics for palbociclib available in India. So if my patient has a financial issue, I'll go with that. But I think all three are
Can I just ask you one question? So are you a little bit bothered about the fact that palbociclib did not formally at least prove an overall survival benefit, whereas ribociclib did?
So, Sudeep, we debated about this a lot, but the fact that the PFS has absolutely identical ratios, hazard ratios, the fact that I don't think the Palbo data was planned properly, overall survival was a secondary endpoint over here. Maybe it was not powered for OS, I'm not sure, but that 40% missing data and the way they did the study, I really don't think there's a difference. And
Excellent.
biasedly, Palbo came first, right? So all us Indian oncologists have had years of experience with Palbo. And I'm sure you and me have patients going on for 4 and 5 years on palbociclib. Then when I'm told there's no overall survival benefit, it becomes a little difficult to believe when you see your patients are doing so well.
So maybe we can have some other opinions between the three CDK4/6 inhibitors. Which one do you choose and for what reason?
I mean, I completely agree with your assessment about the overall survival data of palbociclib, but the problem is because the data feels more robust for ribociclib, I feel obliged to offer that, assuming the patient doesn't have any comorbidities or conmeds that preclude it.
I think I'm different on the panel here. I do, because I have three choices, I do try to tee out the little bit differences that we have kind of learned over the years. I do look at the fact that this patient has presented with lung mets at presentation, and I think that's a visceral disease, not crisis, certainly a visceral disease. Uh, Certainly, this patient will need a germline testing. She's bilateral breast cancer. But besides that, I would have preferred abemaciclib or ribociclib absolutely at that time because that has a survival advantage.
Okay. Okay. So the surgeons will go with whatever medical oncologists say. So any comments from the audience on the choice of the CDK4/6? Can I just ask any of you whether you think that the side effect profile
They all
comes in?
they always matter, and I think we are all presuming this conversation that we have taken the side effect profile into account between the liver toxicity, the diarrhea, the age, how far the patient lives, what the affordability is, and so on and on.
Right. Okay, so maybe we can proceed. I think some of the panelists have said that the overall survival data is the most robust for ribociclib. I'm very fond of saying that whatever Dennis Lemon touches turns to gold. I've never seen him report a trial that doesn't have an overall survival benefit. For some reason, he gets it right. But I think we could use one of the other two as well, especially given the fact that we have the generic versions of palbociclib available. Personally, I also prefer to use ribociclib, but I'm not completely dogmatic about that point.
So I have to say, it took me a while to leave the grandmother drug, Palbase, and move on to ribociclib. And of course, now we have so much data with heavy disease burden and abemaciclib, and it's a thought-provoking discussion. So this patient then continued to be in response, partial response. She never had complete response. And so active response tracking, that's what I remember about this patient, that I had to do active response tracking for this patient because I was never totally comfortable with her response. All of us have patients who don't have anything that you can see on a scan. This was not that patient. She continued to have some findings, and now from February there were some uh, messages coming through the imaging that the disease was brewing up.
How long was that into? From starting to
2021, May 2021 to now, around 3 years later, PET scan showing progressive disease. And so the question is progression on CDK4/6 inhibitor. What would you do next? So I can just.
So, I mean, you could do one of two things. You could change to fulvestrant, or you could look at ESR1 mutation, change to fulvestrant. So question is, which one do you choose to do? And of course, you want to look for PIK3 mutation, which I personally find incredibly difficult to give at full dose. I do a much tapered dose with some good responses. So I think it's a choice between patient to patient.
Sorry, I was just looking at the details of the scan and making sure she'd actually just progressed enough for me to change treatment
Okay.
because I'm quite, reluctant to change treatment as someone who's been on something for 3 years. And if If she'd only developed new bone metastases, I'd actually just done in a bone targeted therapy rather than change. But that's just a nuance.
And we waited actually. So three
Yeah.
successive scans
Yeah.
continued to show, and the patient also, I did not mention, has a psychosocial issue and was very nervous about the CA 120, CA 15.3 trending up.
Yeah.
So constantly upset with the trending up and on the edge, and that doesn't make you change treatment. So finally, when this happened, that there was a new bone metastasis, one was forced into looking at the biology a little deeper.
So can I just interrupt your reply for a moment to just re-emphasize what you said? I do exactly that. When a patient has been on a treatment for several years and does not have a new symptom, it is only something that is showing up on a scan, and especially if it is something like a bone metastasis, it is definitely worth the while to evaluate, to think about it, to not jump and change a treatment, and to perhaps follow up that patient over time and then take the time and take the decision with due deliberation and care. I will re-emphasize that.
Can I ask
And
that?
and yeah,
So do you see then the vaccine waning course also sometimes?
yes, of course, of course. You see, scans are not as accurate as everyone thinks they are. There are a number of factors that go into scans, and especially in a scan that measures both the morphology as well as the metabolism. And there are a number of reasons why metabolism could be up or down, and which is why I would also urge, this is my personal opinion, not to scan too much and too frequently, because one can let the noise confuse you and the signal gets obliterated. So maybe I'm sorry for interrupting you, but please carry on.
Can I have?
Can we please
She,
have him complete his answer, and then Dr. Smriti, you.
No, I've completed the key point I wanted to make, so that's fine. I'm happy to hand over to someone.
Okay, Dr. Smriti.
Yeah, just to put forward, if you have a patient who is on long-term endocrine therapy, I mean the combination, maybe 5, 6 years, 7 years, you have a single bone met or a local tumor which is growing, then would you just give a local treatment and continue the same? I mean, just as you do, say in lung.
So, Sevanti, where was the new bone metastasis here?
so actually, sir, this patient had earlier also, I think she had bone metastasis, or the bone building therapy was not a continuous treatment for this patient. So initially, the thought was to just change that, put her on denosumab, and see how things behaved. We haven't had the time to follow up on that yet.
Where was the new bone
I think it
metastasis? Was
was
it in the rib, or you see, Dr.
lytic
Smriti,
sclerotic, yes, left third rib.
left third rib is not really a very critical structure to even treat locally immediately. So, it's not a weight bearing bone. You don't
Yeah.
have a large lytic lesion there that with an imminent fracture is
Can we pass a mic there? Dr. Andy?
D6 vertebra,
Pleural deposit, yeah.
pleural
So
deposit.
all
Okay.
these new things came up, and they were brewing over a period.
So maybe
This is the third scan.
maybe indolent progression. Yes, you want to say something.
But absolutely, I agree with you that we treat patients, not scan reports. But I mean, this is clear progression. So what I would recommend is, doing a rebiopsy, doing a liquid biopsy for ESR1 mutation, because we need to assess the endocrine responsiveness. After 3 years, that's actually good response. However, obviously, first line is over, and now you need to know whether you go to a SERT, if there is an ESR1 mutation, you go to alpelisib if there is PI3 kinase, and if you see it started with very strong receptor content, if you see that coming down, you might also consider TDXD for as a second line treatment if you have it available.
So can I just ask you, if I understood you correctly, you said we should rebiopsy the somatic tumor as well as a liquid biopsy.
If when
Would you recommend both?
so either one, if you can do the ESR1 for regulatory reasons, crazily enough, in my environment, we have to do the liquid biopsy for the ESR1. So it's not accepted from tissue, which is crazy. And it's going to change, but right now this is the case. However, you may not have easily accessible biopsies, then the liquid biopsy is better than not doing it.
Okay, I think you want to say
Yes,
something.
indeed. Three things very short to reply to the question about if there is one place where it is progressive. We don't call it oligometastatic, but oligoprogressive disease, and that indeed you can approach with local treatment. But this is not oligoprogression. Then the always think about an intercostal bone met, often that are internal memory lymph nodes and not bone metastasis. And then third, either there is an error on the slide, the last slide that you showed before, or because it influences hugely, you wrote on the slide there is progression after 8 months.
Yeah, that was a mistake.
That is
That was
2
a
years and
mistake.
8
My
months.
uh,
Okay.
team just corrected me. So, to your point, this wasn't oligoprogression. This was clear-cut progression after a waiting period of 6 months. So, warranted other thoughts, and in sync with what Dr. Gnan just said, we did a repeat biopsy to confirm the persistent hormone positive status and also understand the biology further. This patient.
No, I was
Yes.
just going to say I would do.
Can I make a point here?
Yeah, sure.
Can I?
So she wants to make
Oh, so sorry. I thought she said no.
You've made the point. You're
Okay.
watering the garden.
Okay, Anjana.
Yeah. So apart from what single meds, oligoprogression or oligomeds, we deal with it if it's symptomatic and we can observe further. Another point which I want to highlight here, sometimes we have a bone marrow mets as well, not just the bone mets. And when we are treating them with letrozole and ribociclib, it can be confusing whether it's my drugs which is causing this bone marrow, like hemoglobin low or platelet low, or is the mets which I'm seeing on the scan which is causing suppression of the bone marrow because of the bone mets. So sometimes I still believe in observing, which has been, I think, the consensus here. That it's better to observe because I have had managed patients which with supportive care, and actually what you see on scan doesn't correlate with the bone or bone marrow mets also, which is much more severe. Like young ladies with anemia, we don't know whether it's ribociclib or whether it is the bone mets progressing. So it can be confusing, but I think it's good to observe, see, and we have managed, and we don't have to really deal with those mets.
Fair point. Fair point. Yeah. So this patient then repeat biopsy and foundation one, liquid, tissues, and germline. And here are the reports. So you have AKT1 mutation, FGFR amplification. You don't have ESR1, and Gardant was also done. So the patient was seeing multiple providers, and every provider recommended their specific tests. So the Gardant liquid was with FGFR and no AKT seen here, and Datar AKT seen, and germline strand negative. So you have two liquid biopsies, one with FGFR, other one with AKT, and you have a tissue. I think the order is, one should show the liquid first because the liquids were sent first. And in that, you have both AKT and FGFR1 amplification. So you have two pathways.
So I assume we've run out of money to pay for any treatment now.
And some patients in India can buy the moon.
Okay,
So
all right.
But
So
not all of them. Not all of them.
that's a
So
very small.
okay, all right.
This is
So
that.
basically, we've got negative germline, and we've got that's an E17 case, an activating mutation of AKT. Yeah. So the significance of that is capivasertib, if available, from Capitello studies. So fulvestrant and capivasertib might be a treatment one would consider. There's quite a lot of talk about FGFR mutations and amplifications, which are more relevant for FGFR in the earlier sessions. But there are not licensed drugs available to treat breast cancer for FGFR amplifications, so it's not something I specifically tend to look for personally. If there may be clinical trials, but not drugs for breast cancer as such.
Yes, please.
I'm sure you took it to a molecular board. Was FGFR1 amplification considered the mechanism of resistance or just a passenger to see? Because most drug resistance will manifest as amplification of one mutation of another. So I think, as Alistair said, it seemed like the key driver was AKT1. So you will see some amplification somewhere.
You also have to look at the degree of amplification,
Molecular
don't
people
you?
in the room.
So was this FGFR amplification? I can't see it very well here. Yes, it's
Yes, sir. There is
amplification. Yes,
FGFR
yes.
But
amplification.
we also need to go to the next page and see what level of amplification that was and what that.
Yes.
You know, I'm really astonished by the number of tests. It's only very few institutions in the world that will
We
regularly
didn't
do
show
that.
you as we were developing this case. My team, all the cases are prepared by my team, and I'll acknowledge them at the end. They said the patient had done a foundation one at the start,
Yeah.
first
Okay.
therapy, exact same pathways. We didn't put it up because we are fully aware. So we said, let that be, let that be. We'll
No, but-
just put the ones that we see
But
now.
Seventy, that would be relevant if the VAF changed. Actually, it would show you which pathway is more relevant here.
So it's AKT.
But what I would like to say is that for us ordinary people, you know, the main information comes from your biopsy. It's still luminal disease. It's low Ki67. So if you I would go with copy in this case because we have it available, but I cannot advertise this globally because it's not available in most places. And I think it's still a reasonable situation here to have excellent response in first line. Now that expired to keep being classically endocrine. If you have, I mean, there's no reason to switch to anything like chemo ADC. So why not even old-fashioned fulvestrant if you don't have it available, because you prove that this is still endocrine responsive disease, which I think is the generally usable of all of this, and even more so that we know that there's no ESR1
Correct.
mutation, so it's wild type. So there's chances that you can have reasonable response towards second line fulvestrant, right?
Could we continue ribo like in the maintain study?
What did you? So let me just say one thing. You know, of course, foundation one was done, and most of us would not have then gone on to do two other tests. But the one thing that I wish to add here is that if there is no possibility of getting the drugs that can be suggested by this molecular testing,
What's the point?
I don't think there's any point in doing these tests. Most of the times, and these are not inexpensive tests, they cost some $4,000 or $5,000, which is quite a lot of money for patients, especially if they have to pay by themselves. So, capivasertib is not available, at least not routinely available in India. It can be imported by some patients at an enormous cost. And then, of course, one can go ahead and discuss the Capitalo study of which we were also a part. So maybe you can continue.
So this patient, like I said, right from the beginning was.
I also want to, sorry, add one more point. The fact that you saw that the liquid biopsy both did not capture the entire spectrum of genetic alterations that were present in the solid tumor suggests that there is an issue, there is a continuing issue about sensitivity in some of the liquid biopsy tests. And I don't know at what coverage this was done. Was this 50,000x?
So
Does anybody know?
17,000.
1.7. And the other one, the Gardent. Gardent is usually between 50 to 100,000x, right?
15,000.
1.5. 1.5. The Gardent. So, just yesterday, I was discussing a manuscript that we are writing. So, what we did was we did ctDNA and the solid tumor biopsy in patients who had become endocrine treatment resistant, and this is funded by the DBT. And we performed our liquid biopsy at 11,000x, and this is an in-house test that we did at Actract. And actually, out of the 4 patients with uh, um, ESR1 mutations, we actually missed one. And the quality control was absolutely perfect. The coverage was uniform. It was fine. It is a 430 gene panel. So I do think that, while a positive test on a liquid biopsy may be useful, but a negative test can still may not definitely mean the absence of an alteration.
Great
So,
point,
so,
sir.
so, so from my point of view, if a solid tumor biopsy is possible, then I think I always prefer a tumor biopsy rather than the liquid biopsy. Of course, you said that for regulatory purposes, you can't uh, do without a liquid biopsy for ESR1 mutation.
And so the point that was made here is that the depth of coverage for liquid varies from the depth of coverage for tissue. 500x is the routine, around 500x is the routine for tissue coverage, and above 10,000x is the routine, has to be the routine for liquid biopsies. So in this case, you saw 2 different reports, 15,000x and 17,000x, and there was a difference in the reports. One was with FGFR findings, the other one was with AKT findings. And this patient having progressed clearly on the frontline therapy. And as I mentioned, the patient had been seeking multiple different clinicians. Capivasertib had already been discussed. We facilitated the prescription. Now, the patient has yet to start capivasertib. Question to the panel from my side, some may have different, from both our sides, is if you could share your experience with capivasertib and anything that you would do differently in a resource limited setting. Would there be some other treatment that you would offer? So both options. If we gave capivasertib, what's the experience? And if we couldn't give capivasertib, what would you do?
So maybe we can ask anybody who has used capivasertib.
Yeah, very limited experience. I think we have 2 patients, and they are still early on. Can say too much, and my alternative would be fulvestrant only.
Yeah, so we've used quite a lot of capivasertib in plasma match and Capitello and various other studies, and it's pretty well tolerated. And so no concerns on that front. But I want to reinforce the resource limitation comment because we don't routinely have capivasertib outside of clinical trials, and reinforce really Michael's point. This lady's got quite a long progression-free interval on endocrine therapy approach. She's still hormone sensitive. So for me, all endocrine therapy or endocrine therapy plus options are still open. So I wouldn't rule out exemestane and everolimus. To be honest, I wouldn't rule out tamoxifen in this lady. I wouldn't rule out fulvestrant. I think they're all reasonable options. She doesn't need chemo.
What do you think of her comment on continuing the ribociclib and changing the endocrine partner?
So there is some data doing that, as you say. I wouldn't be able to do that because we can't continue a CDK4/6 inhibitor beyond progression. And the similar question that comes arise, what about switching the CDK4/6 inhibitor? Again, some limited data doing that, maybe switch to a BEMA as being a little bit different in terms of ratio CDK4 and 6 inhibition. But again, you're talking about very small sort of retrospective analyses of studies. And in that setting, I personally wouldn't do it and I wouldn't be allowed to do it.
So
So
actually,
let's ask anybody from
So
the
can I just,
audience because this is a
yeah,
yes.
I was just going to say, I think I wouldn't use fulvestrant here because what would happen in the UK is that when we get capivasertib, we wouldn't be able to give it because we've already used the fulvestrant. So that I wouldn't give
So I
fulvestrant in
didn't.
this case.
I did not utilize fulvestrant for that very
I think
reason.
Preetham also has a comment. This is a fairly common clinical scenario, so please, feel free to
So,
comment.
sir, FGFR amplification can be also one of the resistant pathway for CDK4/6. So, can you continue ribociclib and add pazopanib or something of that sort if capivasertib is not available? That's one thing. And whether you would perform a liquid biopsy for ESR1 because the the detection would be much better with liquid biopsy as compared to the tumor biopsy.
ESR1 was negative here, no?
Yeah, no, but not in
It's
general.
negative.
Making a
Yeah.
point that
Yeah.
we should do the liquid.
So whether we can add pazopanib with this ribociclib, I mean, just a food for thought.
Pazopanib. Anybody for pazopanib based on the FGFR
I
amplification?
I actually would not do that because if this is really a mechanism of evolution, it'll evolve again. You must try and target your driver mutations to whatever level possible. When you have no other therapies left, that's a different question. This patient is actually very much treatable first by more hormonal therapy, as we're discussing, and then the whole line of standard of care left behind.
You have it.
Yeah, do you have access to a lecastrond here in India?
We don't.
Okay, I just wonder whether, following on from the endocrine theme, and we haven't exhausted everything in that area, whether that's an option.
And that's a great point. I feel that would be an option,
Yeah.
except that for us.
But she's ESR negative.
Yeah.
You
Don't
can
use
import it.
LR40.
So I
Seventy,
think
I think you can import it.
Yeah. Yeah, we can import it. Yeah.
Can I ask you another question?
Please.
How confident are you that the AKT is the driver mutation here? I mean, you're hanging the whole thing on that. Is it better to go with something more non-specific than that, or how confident are you about that?
So this actually so it came to my mind as well because the patient had the presentation of both AKT and FGFR at the baseline. So this is a pathway that was there inherent right from the start. If this was the reason for resistance, then 3 years of response in this patient or 2 years of response in this patient was.
But we have seen that.
Yeah.
We have seen, for example, with Day-3, we've seen that all the time.
All the time.
That you do have mutations, and they take, especially in these kind of tumors, they take time to develop that resistance. And you've in fact shown that over a year she was slowly, indolently developing
Progressing.
resistance.
Yeah.
So I think considering that by serendipity she had a foundation one at baseline as well, and if you especially seeing that the VAF has gone up mainly on that, then this is a evolution. It's a clonal evolution of a driver mutation, which is a known driver mutation on AKT. It's not a known driver mutation.
So a lot of thought, a lot of deliberation, and then the thought process that this is a pathway that has been dominant right from the start. When we weren't doing these genomic analyses, even then the next step would have been everolimus exemestane, and you would have been addressing that pathway. There's some reason why these drugs historically have worked in the next line because these are the pathways that evolved AKT, PIK3CA, all these pathways. Pazopanib, on the other hand, has not made it into the front line. And so, just from a historical evidence, also made sense to approach AKT first than the FGFR.
I think practically speaking, in most situations in India, in this scenario, the next treatment would practically be either
Everolimus.
fulvestrant or exemestane and everolimus. Am I correct in summarizing that?
Absolutely.
I think, I just wish to reinforce the message that, while it was good to have done all the tests that we did, they're not absolutely necessary to care for such patients.
Brilliant point.
So, fulvestrant as well as exemestane and everolimus are both valid options, and that is what most of us would use in this situation.
And if I may add, with very careful observation and no testing, we would have possibly reached the
Done the
same
same thing.
level of survival or whatever we can.
So, this patient actually, while awaiting any further changes in therapy and specifics, we put her on everolimus exemestane because here, if you have to import the drug, that also takes a while. It's not an immediate process. The drug, so the combination, so second line therapy was started, and then the prescriptions for importing. And I don't know if the drug has
And
arrived
if
yet.
if she improves, will you continue everolimus exemestane or?
Very, very good question, Nitish. What depends here on is, and why was I hesitant? I could have done the everolimus even 3 months ago. Patient is very fragile. This patient is very fragile. I did not mention, she's under psychiatric treatment. She's obese. She's very sensitive. There are many, many different layers to her. So you're very cautious about changing. You want to give, easily tolerated therapy, and being mindful. Just
I
being
think we also need to take into account what she just said, that, these days information is not just available only to doctors. Even patients are aware of all the testing, even the implications of all the molecular tests. So, there is always a kind of a conversation that you have with some patients, and it is not for the doctors to impose that this is how it will be done. And if the patient, would accept a drug that is imported, which is also evidence based, it is not without evidence, then I think that's what she should get.
So to wrap up, the patient told me after he had done the liquid biopsy here and traveled back to Raipur, बाल को गया था वहाँ गार्डन करा दिया तो करा लिया मैंने. So that's to complete the picture. So I think multiple different providers involved, and so hence the number of tests. So now a very interesting case, and I think we had 4 cases, but maybe we'll be
Which
able to
time do
just
we have?
so 20 minutes
Okay.
exactly. So I think just this case probably. So a 51-year-old female with a lump in the right breast.
They wanting to say something.
I was just suggesting this also a precision case. It's also a precision oriented case. The second
So this one?
So the surgeons are getting restless.
No, not for that. I'm just saying because we have some more ordinary stuff also. So yeah. The,
Do you want to present?
no. So we have one. Yeah, we have
You want to present? It's okay.
20 minutes. Yeah. So I just wanted to know because if it's yeah, then we can get that case. It's a
Yes, please.
Sure.
Let them,
Please,
yeah.
please go ahead.
Come.
This we had some
उनका हेल्प करो ना
out of
उनका
discussion over
लैपटॉप
some
लगाने को.
good one.
Please.
Come.
So Alvin,
Great case.
thank you.
Great case.
This is what we here. I mean, it's not about she's presenting that business. Yeah, you don't have to go down.
Sorry, I'll just need to.
Okay, this was a these situations do happen now and again, and she's going to present it. This was actually a 77-year-old lady, very well preserved otherwise, and 77-year-old. 3 years before, she had undergone surgery for a DCIS in the left breast, uh, and she was treated with post-operative radiation and kept on follow-up, and she was fine. She was disease-free for 4 years, and then this happened. So you can present it here.
Can we display this, please?
This
You can have this. There's a mic here.
Yeah.
So this was a 77-year-old lady.
Zoom in a little.
Let me.
Yeah. Yeah, that's better. That's better. Yeah, go ahead.
So this is a 77-year-old lady who presented with a recurrent lump in her left breast in October. She was previously treated for a left breast DCIS in 2010, for which she had a wide local excision followed by radiotherapy and then tamoxifen. The recurrent cancer in the same breast was an invasive lobular carcinoma, ERPR positive, HER2 negative. Staging PET was normal. She underwent a left mastectomy with a sentinel node biopsy, and the histology showed a 3.5 centimeter lobular cancer, grade 2. And there were 2 lymph nodes that were negative on frozen section. Also, the staging ultrasound before this surgery was normal for the axilla. However, the final histopathology report had one sentinel node which had 2 millimeter macrometastatic disease with extranodal spread. I want to know from the panel how they would address the axilla. Would you give radiotherapy? Would you
She needs
clear the axilla?
She needs clearance. This is lobular carcinoma. I don't think you can rely, to my mind, in lobular carcinoma surgeon.
No. With bone surgery,
So maybe anybody, yes, please.
I
I think the clue of what to do with the axilla came from your introduction of being very fit, 77-year-old lady, whatever age. You subjected her to mastectomy and sentinel biopsy. You should be prepared to act on the results. And if she was 35, you wouldn't do anything other than axillary clearance.
Yeah, I'm now. That's probably the only case where I would not go back to the axilla and I would accept the radiotherapy option. She's 77 years old. It's super, it's super unlikely that there is any additional nodes. If there is something, some single cells, clearance is not going to change her fate, not by a single day.
But this would be
So
re-radiation. I mean, she
that
was
that's the
radiated.
next thing. It
Yeah.
would be re-radiation. All the axillary things have been now twice operated on in 15 years, and she's 77. So I was speaking against substituting axillary surgery with radiotherapy all this conference, but that's the case where I would not go back to do another
Michael,
surgery.
wouldn't the lobular histology trouble you?
Not at all. There's no
Because they're far
difference
more likely
whatsoever
to be
between lobular
node
and in terms
positive,
of
and
axillary.
and you don't pick them up on the scans.
Yeah, but who cares? Then it will show. Let's control the disease.
May I ask if the extranodal extension would change this for you, Professor Gnant, in any way? Because this was underestimated.
Actually, I will beat up my pathologist in the first place because if I get a frozen section and then that's a mistake. And I accept that it's difficult to find the micromet, but the macromet you should see on frozen section. So it's an unfortunate case. Why put the burden of repeat surgery on the patient? Well, that's even another.
was told.
That's even an argument not to go back.
Now, I think personally that for radiation therapy, the lobular does matter because we know from the pooled analysis of the old mastectomy versus breast conserving therapy trials from the Danish and from EORTC that the lobular, and that were N0 patients, maximum tumor size in one trial was 3 centimeters, in the other 5. They have a much higher local regional recurrence rate if no radiation therapy. Now, I think that there are two options: axillary lymph node dissection and hoping you don't find anything else, or you could indeed re-irradiate. For the re-irradiation, those cases are eligible for hyperthermia. There are internationally accepted protocols for that. The tissue quality has to be good, like I explained yesterday for the second breast conserving therapy. I would not go to full nodal radiation therapy. I would take in such a case only level 1 and 2 below the brachial plexus, below the vessel. So it's one smooth area. Also for the chest wall, if the tumor was upper outer, I would not treat the entire chest wall. I would only treat, let's say, the upper outer quadrant, the quadrant where the tumor was, with a generous margin around it, but not the entire chest wall. And then in general, the re-irradiation is possible.
Yeah.
Mr. Ham.
Yes,
Can I just point out, I would tend to agree with that, but we are talking here about a micromet, technically, although she's got extranodal extension. Micromets are 2 millimeters or less. Macro are more than 2 millimeters.
Yes, that's correct.
Yeah.
There's a, yeah.
I'm going to ask a provocative question here. So why are we avoiding axillary clearance, which will take me 45 minutes to do? The patients will go home same day, and committing these patients to probably 15 visits to the hospital for radiotherapy. And that's what I said yesterday. We started to talk about axillary clearance as if it is the immortal sin in breast surgery.
But I think it would be a mortal sin here, wouldn't it, in a 77-year-old?
Do you want to?
And she's got a micromet, actually.
Yeah, I would
It was actually a
clearance.
macromet. I think this was meant to be more than 2 millimeters. Dr. Ivan.
Well, that's how it was described, a 2 millimeter macromet. That's how the pathologist described it.
So in this case, I think Hisham, John is absolutely right. It's a micromet. The only reason why you'd want to do something is for the extranodal extension. So let's not argue about what to do with micromets because that has been proven in a clinical trial. What do we do? Do we go back just because there's a little bit of extranodal extension
And the
and
fact
clear
that
the axilla?
is
And hang on, and give her at 77 the morbidity associated with this because we're not sure what to do with an extranodal extension.
My point is very simple. If you are going to treat the axilla at all,
It's treated. According to clinical trial data, listen to me, please.
yeah, I'm just
According to clinical trial data, micrometastases do not benefit from any additional treatment to the axilla. This is a clinical trial randomized.
no.
The only thing that changes in this patient is that you are now having extranodal extension.
I'm not worried about that at all. Decide whatever you want to decide. But we are not talking about leaving the axilla alone. We are talking about replacing surgery with radiotherapy.
No. It is an option
Hold
not
on,
to do
hold
anything.
on, hold on, please. I'll use the moderator's prerogative. Let me ask Dr. Ring, what would you do? You want to make a comment?
I'd suggest we move on from the axilla. In all seriousness.
No, I'm
Dr. Hari Bhakti, what did you eventually do?
Yeah, after all this going around, she's had about 8 or 10 opinions. Now, just to tell you, she, when we did her axilla, it was fully studied. We even went with the probe at all levels. There was no activity. It was a clean axilla, and we found two sentinel nodes which were reported negative on frozen. I didn't beat up my pathologist because she said there was a genuine reason she found. So it was anyway. Now we went through a detailed discussion with her. I'm not, as a surgeon, very inclined to go back and do a complete axillary clearance. I'm very convinced it's not going to yield any nodes because we found nothing over there. And she's on endocrine treatment. And I'm not keen on radiation either. So what we have currently said is we'll watch you, we'll keep you on close surveillance. And that's what I want to know, whether how many of you would be inclined to accept that policy.
I'm happy with that and very comfortable. If you are saying I'm not treating the axilla at all, but has been the discussion over the last 2 days, running away from surgery and replacing with radiotherapy. If you say I'm not touching the axilla at all, radiotherapy, I'll accept it 100%.
Okay, thank you. So that was interesting. Yeah.
Okay, I think that's an interest. So the medical oncologists are getting fidgety because they know nothing about the axilla. Let me poll the audience. This is a good situation to discuss because it's unusual, but it does require decision making. So, how many of you would perform repeat axillary? I mean, the full axillary dissection here. Please, by a show of hands. Yes, you can raise your hand. You are a medical oncologist. That's fine. So there are three. How many of you will radiate the axilla?
So if
Three, four, five,
no,
five,
surgery.
five. How many of you will keep this woman under close observation without either radiotherapy or surgery? I think about 15, 17. Okay.
Majority.
So I think, Dr. Hari Bhakti, the majority of the audience would feel comfortable with your decision. Although having said that, you know, once we say that we are convinced that there is nothing else in the axilla, that's just your surgeon's feeling. But you know that on the first occasion when you did the sentinel node biopsy, when you did everything, it did turn out positive, and there is a macromet with extranodal extension. So one can't be completely certain about these things. There may be, and especially with lobular carcinoma, I've seen that it behaves in a very funny manner. It may or may not get picked up either in the axilla or elsewhere. So, but I think there is no one correct answer here. Your point is well made. Your point is well made that, it is just a question of putting this woman on the table again and performing an axillary dissection. And that will, of course, definitively answer all the questions that we have. So that is one option. But
In summary, whatever discussion we need to think, are we compromising this patient by offering one treatment to the other? If we say that no further surgery or no further treatment and putting her on endocrine treatment is an appropriate and safe, I wouldn't operate and I wouldn't treat. So we shouldn't actually be arguing about which modality.
the question here is that there's no that that this clinical situation here does not have a definitive answer. That's that's the conundrum. Okay, so you have any other cases? Okay,
To another
perfect.
one.
Go ahead.
Can I
This
just
is
add
Try to
something?
press the
multidisciplinary.
oncologists a bit more.
Can I just ask one more point on that, on the previous case?
Who is this?
This is me here.
Yeah.
Yeah. So the point I'm trying to make is this is sort of an unusual case in the sense that we are not able to correctly predict what the risk is. You're talking about local risk. What about systemic risk? Yes, she's 77 years old, but I happen to meet her and she's reasonably fit, quite fit in terms of um, would you consider treating her with adjuvant chemotherapy in this setting? That's the question. I mean, the reason is only because we are not able to predict what's going on.
No, but the reason why we are not able to predict what's in the remainder of the axilla is not, in my opinion, sufficient reason to give her chemotherapy.
Absolutely.
So now the point here is that the clinical situation, it was unusual because this woman had already had a prior surgery, had radiotherapy, and now has a sentinel lymph node which turns out positive on the paraffin block but not on the frozen. So that's the situation. And I don't think
The
anybody
key
here will
67
argue
was
to
5. The key 67 was 5. I'm just
right. So
letting.
key 67 is 5. But the point here is that, nobody here will argue that we should use chemotherapy because the axilla, there is some uncertainty about the axilla. Can we please move ahead? Otherwise, we've already made our points, and beyond a point, I think we are repetitive. So let's, please move to the next case, please.
So this is a 45-year-old premenopausal lady who's got a hormone receptor positive, HER2 negative, clinically T2N0 breast cancer with limited liver only metastasis that fits for a oligometastatic definition. Would you recommend upfront surgery for locoregional disease only, or for both the primary and the distant metastatic sites? Or would you only recommend this after a course of systemic treatment?
So I think since we have only 1 minute and 18 seconds left, I will request Dr. Shona Nag to please make her comment. And you will have the last word on this. And after this, any discussion on this case will happen in the coffee room or the lunch break.
So we are talking of oligometastatic disease, right? So we've had a huge discussion this morning, and I'd be much more comfortable in whatever subtype there is in giving systemic therapy first, and then taking a call on local regional therapy.
Yeah.
So you say that you will use some kind of systemic therapy followed by local treatment. You want to make a comment? Let me use an
I
exception.
think we need to be clear in the messages. There's no place for primary surgery in such a case, period. Neither in India, nor in the US, nor anywhere in the world, period. So that's really has been defined. We consider local regional surgery once we have excellent, hopefully durable response. The longer, the better, and then shrinkage and almost disappearance. And then in very selected cases, you might want to discuss liver surgery in very selected cases. And I'm saying this as a cancer surgeon. This is like 1 in 100. They eventually do it. The primary is different because the patient will request that you take it out once she is in stable disease.
If you're treating the metastatic site with a curative intent, how will you address the breast and the axilla
So
in
he
such?
said that
Yeah.
they will operate on the woman
If
because she will ask for it. And
if curative because of oligometastatic and good response, then we go for the finish line. So then we
okay,
do everything appropriate.
perfect. So let me end this. So okay, so Seventy, I can't refuse Seventy. You want to?
So in this situation, metastatic hormone additional maintenance therapy and how long?
I think we'll discuss that. That's a matter of detail. But let me poll the audience because I have, except in very rare situations, I've never ever been convinced about the concept of oligometastasis. How many of you know of patients with liver metastasis treated with curative intent who remain disease free in the long run with such kind of oligometastatic disease? How many of you? How many of you know of such patients who remain long term disease free without local treatment? Without local treatment, not having offered. So there are. Okay, so there is equipoise on this in this scenario. Personally, I'm not a great fan of, coiling the liver, radio frequency ablation, performing complicated resections. But, it's a matter of debate. I don't claim to be right, but I think this is still a situation that demands a well-conducted clinical trial. On that note, I think we'll end, and thank you very much for your participation and attention.
Thank you.
Thank you very much, Dr. Sudeep Gupta, for leading and moderating such an excellent session. And you all will agree that it was a beautiful discussion on advanced breast cancer. May we have a group picture, please? And after advanced breast cancer, I think we need to treat advanced hypoglycemia. And I'm the one who has perpetrated it by canceling the coffee break. But I'm sure your food for thought was equally satisfying and gratifying. We now have a lunch break. I request you all to please be back at 2 for the consensus meeting on the 5th floor. The consensus meeting will take place on the 5th floor. So please, after having your lunch, proceed to the hall. Ah, lunch on 5th floor. Why are you confusing me? Hello? Hello? Yeah, a slight confusion here. The lunch is on 5th floor and the meeting will take place here in this hall. So after you finish your lunch, please come back here for the consensus meeting. I'm sorry for the confusion. Over to you. Maybe Sevanti or Urvashi, maybe.
So we are starting with the consensus meeting, and the way it will be structured is we have a panel, and there'll be a voting by the panel, and the results will be displayed, and there will be a brief discussion on each issue. So everybody, okay, fine.
Yeah, okay, yeah. So I think we have a consensus on that point. So the people voting will be the panelists. Yes. Because the technology doesn't allow differentiation between, panel and audience votes. So, but you'll see the results for the panel decisions, and we're going to have some kind of brief comments after each question. So there's 35 questions relating to early breast cancer, locally advanced cancer, and metastatic breast cancer. So hopefully they all relate to sort of key points in clinical sort of decision making. And we've sort of, carefully sort of selected and crafted these questions and worded them, as carefully as possible to be useful in a pragmatic sort of manner. So again, if the lighting person can try and deal with the lights, otherwise I can get my sunglasses out. It's very, very bright. Anyway, this microphone is on, isn't it? I'll switch that on. Yeah, that's better. Yeah. Yeah, I don't need that as well. I'll hold on to that just in case I start.
Yeah, so I
walking
just
around.
wanted to quickly make. Do you want to announce the panel members?
No, you could do that
names? Yeah,
actually.
okay.
Yeah.
So at
This is the pen. I don't think.
no, even Dr. Gaurav, Dr. Sarah, yeah.
Yeah. I
Rosina.
think we'll have to have rent a panel.
Okay,
I
so
think,
so
won't
Rosina,
we?
can you please? Okay, it's fine. So 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 let's say it's every. I'm not naming because there are many. So I think
Thank you.
it's all people until the fourth row from here. So that's fine. I think
Yeah.
that's the panel.
That's great. Okay. So, so long as we've got a sort of cohort of panelists who are actually voting, so we've got some reasonable numbers, that'll be helpful. Okay. Do you want to show the first question then? So this is the first question, fairly straightforward. I don't think I need to actually read them out, but this relates to the minimum age for patients undergoing mammography in a symptomatic context as opposed to screening. Okay, we'll just give you a moment to do that. Yeah, we can explain. Huh? Yeah.
So in the app, you have to go to polls.
No, but let's make an announcement for everyone.
Yes. So in the app, it doesn't work the traditional way like it worked yesterday.
Oh.
So there's polls in the app, and when you activate that, you will be consensus poll.
Okay. You got 27. Okay. So is it still increasing a little bit? Oh. Oh, so it's somebody else voting as well then. Yeah. Go and confiscate their phones for the duration of the session. That's what we have to do in the exams now because they all keep conferring. Oh. Well, can we put the lights off, please? Um, yeah, it's very bright. Um, so okay, so yeah, so 40 consensus on that. So actually we've only relatively recently increased our age threshold from 35 to 40. There's a lot of controversy over women who are presenting just with breast pain should undergo an opportunistic mammogram if they're 40 or over. Any particular comments on the age threshold here? What? Yes, Philip.
Now, maybe a comment, just a thought is that age of 40, it's good to have a baseline mammography. If after a couple of years you
Okay,
have a new
yeah.
mammography, you can compare it.
Yes,
That's
yes,
an extra reason why I voted yes.
yes, yeah, no, that's reasonable.
The only reason why we had this discussion before, because this turns out to be opportunistic
Yes,
screening.
yes,
And therefore, you are offering for someone who just because they walked into your hospital
yes,
and not offering it to somebody else.
yeah. And it's not screening, no, but it's like an opportunistic screen, isn't it? Yeah.
These patients were 35 years of age.
Yes. Okay, we got consensus. Okay, right. Next question. Next question. Okay, there we go. So again, this is all sort of basic sort of principles. Yes, hopefully 100%. Notice it does say, should. So it's a bit idealistic, isn't it? Um, so, so can I just ask you here in India, do you do any freehand core biopsies? Are they all done under ultrasound? You do freehand, yeah. 21, okay. Well, yeah, okay, results. Okay, we got the results. Okay, yeah. Yes. So can somebody who's abstained on the panel, why have you abstained? Is it just one? Hmm?
Yeah, I'm sorry for that. I'm just saying, the reason why we are pushing for biopsy is we want, and that was the original Basel reason actually 40 years ago, because we wanted to hinder surgeons from just cutting it out. Now, when you consider it, why are we doing it? We're not only for diagnostic purposes, but for for the indication of neoadjuvant treatment. So, in a, let's say, 75-year-old lady with a clearly malignant finding on imaging of 8 millimeters, there is no chance we're going to change the treatment. So I think primary surgery is not a mistake. And I know it's against that political push, but once we are over the diagnostic surgery, why would we need 100%? So 96% is good. but there are cases where treatment is not changed and you can just do the surgery.
What about receptors?
What what are you doing in a
Because
4
because
millimeter
because
with
if it is an elderly lady who's frail with ER positive, I wouldn't offer her surgery at all. So I need to know the receptors before I take her to
Yeah,
surgery.
we
well,
would
that's
never.
that's a
let me
difference
let
because
me
I
give.
will never leave a cancer
Can I
behind,
can I
even
have a
if my
comment?
oldest
Sure,
patient
sure.
is
Yeah.
101
May I have a comment?
and still she had surgery.
So we are looking here in as a diagnostic procedure, the choice between a core biopsy and excision biopsy. We have not discussed whether it's a small lump or a big lump.
Yeah.
It's clinically suspicious. So if you have a clinically suspicious lump, you should do a biopsy to get a diagnosis. It says breast clinic with a suspicious lump, both clinically and on imaging.
Yes.
Both clinically and on imaging, I would get a diagnosis before I go ahead.
Yes. But certainly, yes. No. But we want to have definitive diagnosis before we do any kind of therapeutic surgery or treatment. And often, with little old ladies who are not going to get surgery, who are going to get primary endocrine, we would want to have a core biopsy for the ER status to confirm that ER positive. Okay, next question, please. Yeah, that's a good question. I don't know what Monica Morrow's answer would be to this. Yeah, interesting actually. Yeah. No, I saw. Yeah. No, it's not all. This is early at the moment, sort of thing. Yes. Yeah, no. We've tried to keep them reasonably well classified. Yeah, these are warm-ups. Yes. After a big lunch. Yeah. Fine. Well, it is a biopsy. FNAC is a sort of biopsy, isn't it? It's fine needle aspiration biopsy. Okay, shall we? I think we've almost. Okay, we've got a result. Yeah. Okay, excellent. Yes, no, I should not have gone on to say. Okay, so some of you are disciples of Monica Morrow, are you? Possibly. We've got 20% saying no. We've got 20% with no.
One is that FNA should be included. Yes. Yeah. There are patients where it may not be necessary. Immediate part. No, that's why it was instance early breast cancer. Well,
Yeah. So obviously they have an ultrasound.
Now, suppose it's a ER positive tumor, and you're going to do a sentinel node biopsy. I have answered yes, but then it's not a must that you should have a biopsy of the node.
No, if
So-
the abnormal nodes fulfill the criteria for
No,
biopsy,
no.
and there's objective criteria,
No.
that node should be biopsied.
No, I'm saying that if it is a small ER positive tumor
Yes.
and one indeterminate node,
Yes.
you may not do an FNAC or biopsy of the node because you will anyway be doing a sentinel node, and
No,
that
so-
will
no.
not change your management.
No, okay, but okay. Wow. Well, it says indeterminate. Okay, do you want to sort of redo the poll? Yeah, redo the poll. So what is the cortical thickness which prompts biopsy here in India? 3 millimeters. Okay.
Okay, let's argue it again. Pay attention. Okay. Here we are. 100%. No, but I work harder than that.
Early breast cancer and FNA core biopsy.
Please caveat like inflammatory, locally advanced being the question.
Yeah, I think in the UK, probably Ash is about a third of units do FNAs of the nodes. We don't do FNAC of the breast lumps anymore, but of the nodes. Yeah.
Question is the same. You don't promote the way you know.
One is should undergo actually there are some yes, but should undergo ultrasound and biopsy and everything that may be determined.
No. They only undergo biopsy if prompted by the ultrasound. Yeah, don't read into the questions too much. I mean, just just Okay. Anyway, so how did we change that back to 100%? Was that did I see 95? Okay. Okay. So we've obviously got one nitpicker amongst us, I think. Yes. Okay. Third question.
Next question.
Fine. So again, sticking on the theme of early breast cancer. Yeah. So this is very interesting. I'm interested to know what's happening here in India with respect to radiation schedules after publication of the Fast Forward trial. Oh yes, Philip must
Just add after radiotherapy alone.
Okay.
It's breast or chest wall radiotherapy alone.
Alone, yes.
Without the nodes.
Yeah, so yeah, we
but Fast Forward includes a nodal component as well. 462 patients.
Yeah, alone, yes. Just make a note of the picture. You're going to be going back and writing this up. Yeah. Okay. So yeah. So that's very encouraging, isn't it? So how widespread is the 5-fraction regimen here in India? Has it been adopted?
It was adopted during COVID
Yes.
because we couldn't fit everybody in and patients were not coming. But if you ask me what's the standard, standard is 15 fractions, not 5. It's
Yeah.
15, not
So
5.
why haven't you adopted 5?
It hasn't been adopted. That's it. The radiation oncologists are not comfortable doing the 5 for everybody. So we are doing 15 right now, not 8.
Our hospital is leading a. Can I just say,
For a few, we've also done for a few.
Okay, can we have a radiation oncologist commenting on this from India?
The question is very clear. Is it a preferred?
You preferred?
So the
Yeah.
answer to this question that I have given is no, because it is not preferred. It is an option. We actually were the first ones to adopt 5 fractions in India. We have treated more than 120 patients. We are very happy with the results. There is some question about the long-term hardness of the breast in large-breasted women. So it's an option we give to our patients. It's not preferred. I mean, I said no because it said preferred, but it's definitely an option.
May I just made a.
Overall outweigh any disadvantage.
Sorry, I couldn't hear you.
Sorry. Don't you think that over?
It's all right. It's okay. It's okay.
Sorry.
Short your say.
Sorry.
Just saying that our hospital is leading a multi-center RCT, which I think has about 2,500 patients to be randomized. Of 5 versus 15. This is for all comers. So I think recruitment may be nearly finished.
Okay, and what are your main primary endpoints for that?
It's being run by the radiation department. I can't tell you exactly, but
Okay. Okay, so are there generally concerns then about the longer term impact of the higher fraction size of 5.2? Is that what people are concerned about?
But it's also so it's all comers. Fast Forward had, I think, fairly restricted, a group of patients. So this is all comers. This is with advanced disease and everything. So it's an all comers trial.
Okay.
So I think recruitment is close to being finished now.
Yes. Because it's also a bit cheaper, of course.
Yes,
fractions,
it's easier for the
but
patients,
there's
of
less
course.
remuneration potentially, I suppose.
But here, remuneration, I don't think is by days. At least, I'm not sure how it works in other places, but in our hospital, it's radiotherapy for the breast, and it's the same.
Yes. So, Philip, will there eventually be data
that
on
may be.
whether
That's a different
5
issue.
fractions are okay for the axilla?
Yeah.
Is that data coming from
Yes,
the fast forward?
the data for the fast forward nodal will be presented. They have been presented at 2 years for side effects. They're identical. So it looks like it will work as well, but it will not be sufficiently powered to nominate it as a new standard.
Okay.
That's a big issue. Now, for us, we started in April 2020 with the 5 fraction schedule, and it's our unique schedule: breast only, chest wall only, DCIS, lobular, ductal, 25 years of age, 90 years of age. All those patients receive 26 gray in 5 fractions
Right.
without any discrimination. Of course, you need to give homogeneous dose distribution. You have to take care of the inframammary fold, as I demonstrated on the images yesterday, which is much more an issue of target volume contouring and be smart in your treatment planning than in the fractionation. So for me, it's the standard, and of
Yes.
course, 40 and 15 remains
Yes.
another standard.
Yes. So it's clearly a standard of care, but not necessarily the standard of care. Hisham, have you got?
Yes, I
Sorry,
just
can
wanted to say a very simple thing is that firstly, we have to establish that they're equiposed. I mean, we start talking about the effect of fibrosis, the effect of the size of the breast before we even agreed. Is the 5 fraction equivalent into the 15?
In terms of efficacy, yes, on the basis of the
Fine.
forward
So,
trial, yes.
For why would you give 15?
And in terms of the acute toxicities and things.
And in terms of fibrosis, there is no significant difference. The 27 in 5 fractions is equitoxic to 50 and 25. The 26 in 5 fractions to 40 and 15.
Yes.
And Charlotte will present probably next year an update of 10 years of fast forward.
Yes.
An important point, very important in the Lancet commissioning, with the official presentation in 8 days, we found out that the adoption of the 5 fraction schedule is inversely related with the healthcare infrastructure availability. Inversely related.
Yes. Okay, Anand, did you have a quick point you wanted to make? If you address it to me and not to.
Sorry, I was saying, did this fast? I've not really read this trial. Did this trial include patients who had some flaps put in? Was the fat necrosis rate higher in these patients?
Patients with breast reconstruction, we give 40 and 15 because we have not sufficient data. It was about 1% of the patient in fast forward who had a form of reconstruction after mastectomy. The majority had breast conserving therapy.
Yes. Yeah.
Asking about
So,
other oncoplastic.
with oncoplastic, it was a UK trial, and quite some UK surgeons are very much in love with oncoplastic surgery.
But I think in
yes.
the future, for irradiation of the implants, it'll be very interesting to see whether the higher fraction size has an impact on the
So
longer
our
term
experience with the
cosmetic.
perforator flaps and the fast forward has been a lot of fat necrosis, and patients had to be intervened in with the perforator flaps taken off and LDs done to palliate because there was a lot of chest wall fibrosis. So
Right.
hence we have kept it only for select. So the question is it preferred radiotherapy treat fractionation? Our oncoplasty rate has gone up significantly. So it's not preferred. We still stick to 15 fractions.
Okay.
And some select ones, maybe the elderlies and somebody who's outstation cannot stay. They are selected out, but
Yes.
it's not the
Yes.
preferred
But anyway,
option.
it'll be
Now,
interesting to see if
we-
that's replicated elsewhere.
We have to be careful. You have to do it properly. I just rejected a paper submitted by an Indian group about post-mastectomy radiation therapy. It was telecobalt and 2D radiation therapy. Sorry, with that, I would say stick to 40 and 15. But if you have modern image and target volume-based radiation therapy, 26 in 5 is perfectly safe.
Thank
Yeah,
you.
I mean, in
So,
the UK, we do the 5 fraction regime, but we don't, we avoid it when we have the recon or the implant. We stick with the 15 still. It's not mandatory, but it's certainly encouraged. It's not, no, we don't have to give it. So yeah, everybody gets 5 unless there's a so if we want to give a boost, then we don't give 5 because we give a synchronous boost. So we would give that. Okay, so for us it's 5 and
okay,
15 for select
fine.
patients. Yeah.
Now,
It's
Yeah.
not like I'm shooting down 5. 5 is
Can I,
there.
can I
Select
just
pick.
can I just remind you of
And
that?
you can
Give you
can
some
be you can
Sankaln
have these
experience,
more
okay?
yeah.
nuanced discussions
The
afterwards.
nature
Can we
of
move-
such a consensus
Yes,
vote,
yes.
the nature is not that everybody says, I'm fine with it. Because when innovation challenges the current state of the art, there's some point in time where one guy proposes something and 99% are against. Then in transition of our knowledge, we will move up, up, up. Some of you might remember that I did the bisphosphonate trial about 15 years ago. Sangaln voted it down with 88% no. It took a decade until the vote went up to a positive one. And the same is here. I think it's perfectly fine for some people saying
63.
we are not comfortable, so we vote no, it's not preferred for us. The question is, this is already a 2/3 to 1/3 majority and
yeah.
indicates towards where will we be in 5 to 10 years. And that's the nature of a vote. So not everybody has to agree on every question.
Yeah, thank you. So, shall we move on with our 2/3 majority on that one? So, next one. Yeah, so these are patients that are clinically and radiologically node negative at presentation and who have primary systemic therapy. So, what auxiliary surgery should they have after? Okay, so we've got 17 voting, 18. Okay, do you want to give us the result? Wow, fantastic. Very good. Okay, fine. Next question, I think. Yeah, so this is obviously a sort of evolving area at the moment. So, management of the node positive patient who's having neoadjuvant chemotherapy in terms of their auxiliary treatment. Yeah, yeah. I will just qualify that by saying, well, that radiologically they haven't got evidence of more than 3 nodes. So radiologically at presentation, there's no evidence of more than 3 nodes being abnormal. Okay. Does anybody else want to vote? We've got up to 17. Yes, don't overthink it. Yes. Right. Okay, do you want to give us the result we've got so far if we're not going to have anyone else? Okay, so 3/4 and a quarter. So I presume the quarter you'd all do an auxiliary clearance, would you? Mm. So are some of you not believers in de-escalation of axillary surgery in the context of core biopsy proven node positive disease? Is that so some of you have reservations or you're not sure that this is a safe procedure? Because quite a few of you have voted no. So does anybody who's voted no want to say why? Yes. Who's voted no?
No, I have voted yes, but I would say that there would be somebody who would say no here because the real world situation in India is you will not be doing a post chemo sentinel node biopsy in every center. So some of them will still do a clearance, and that is a real world
No, but that's
Can-
not the question.
we need really to understand very clearly. We are not here to establish what happens in India. We are establishing what is the correct practice.
Yes, I'm just. Who said no? Said no.
Well, I mean, amongst the Indian members of the audience, that's what I mean.
The question is, should it be done? Well, the answer, I mean, if it is not must be done, so the answer can be yes.
Well, yeah,
but
it should
but
be. Yeah.
so it is not a must. It is not a definite.
We rarely use words like must in medicine. And
Or shall, should, shall.
Okay, so we're going to stick with that consensus. Okay, shall we move on to the next one? So this is a very topical area at the minute. So is it compulsory to do an axillary dissection if there are residual isolated tumor cells after chemotherapy in the clinically node positive patients? I have my own but I would probably not offer it. It's too much. Well, clinic the test language as a here we go. Again, results.
If you want to offer nothing, you never
Yes. First vote, then discuss.
If you want
Yes, yes. Yeah, so if you can vote, make sure we have only got 19. If we can do your voting, yeah, we can have a chat afterwards. We've only got 19. Okay. So, yeah. Oh, okay. It's probably reasonable to have a quarter abstaining for this, actually. I'm not surprised by that. Yeah. So are most of you familiar with the ICARO study that is about to be published? Yes, okay, yes. Yeah. Okay, so
I think that now we need a comment. There's several options for abstaining. I mean, my reasoning was that, and then you can answer this: should be offered nodal radiotherapy. No, because I do an axillary clearance, which is not my position. But you could also say shouldn't be offered nodal radiotherapy because maybe doing nothing with the axilla after that would be also good. We don't know yet, which is why I abstained. But I think that's a reasonable voting result for work in progress.
Yeah. Yeah, so we need to wait for the results of the Alliance trial.
But the problem is that those who voted yes means that they are prepared to deliver this treatment before even the trial.
We
itself.
call these
Sure.
we call these colleagues early adopters of
Yeah, but we have this large, 600 odd patients, real world data sort of study that was done. But anyway, I think as Michael said, it's a reasonable result to have. So can we move on to the next question? Don't remember seeing that one actually. Um, hmm. Okay, I think that's a very quickie. So we can. Well, you should. Yes, even with protocols, you probably should still be discussing the cases. So. Okay, have you all voted? Okay, shall we see what we've got? Yes, I think that's. So who's against?
No, I doubted between abstaining and yes. I voted yes, but the abstaining would be because whether it is in the absence or the presence, it always has to be
Yeah, it
done.
always has to be. Yes, yes.
But I voted
But
yes.
it's still yes, though, isn't it? But okay, shall we move on to the next question? Yes. Okay. So.
As a moderator, I think all three of you are
No. Translated the meaning of the question. Because that's this concept. It's like this possible, in that should be, could be. Is an option, is a preferred option, is the better option. One of the options. So, and we discuss it with people. Lucky you. Yes. Yeah, but I'm taking my medication. But I think shared decision making, informed consent, they're all very topical these days. Okay. Let's have a look. Next one. Yeah, that's fine. Shall we move on to the next one? Yes, okay. I don't. Yeah. Okay, fairly straightforward one, I think. Well, it is. I think it is mandatory. It is mandatory. So what's controversial about mandatory? Why would you not X-ray the specimen? If it's specimen radiography.
No.
Sorry, can we just have one person at a time? Because it's making this
Lesions
job
which are
very difficult.
mammographically not seen. So why would you do a specimen radiography on those lesions? Yeah. So then this is wrong.
Desirable. So
Yes.
desirable rather than mandatory.
Yes, exactly. So you.
We call it imaging.
If it's non-palpable and non-seen on mammography, how you would
Yes, how would
detect
you
it?
take it out?
Because you localize it with
You use ultrasound in screening?
That's right. No, it's very rare we would have a link.
How do
You're
you
not
find
Yes.
the patient?
We don't do screening.
It's not about
We
what
have
you do.
opportunistic, even in opportunistic, mammo didn't pick up. but there was something
That-
suspicious. I got an ultrasound done. I find a lesion there.
Yes, so
I will
then
localize it with an ultrasound and I'll excise it.
you're not seeing the
Ultrasound.
lesion on.
Mark it on the skin. I can put a marker. Yeah, I can.
There are some
I
lesions
can
which
do a
are
skin marker. I can do a wire, but even a wire can go in with an ultrasound.
1 minute. There are there are. Can I say something?
Yes.
No.
Well, that's still a kind of specimen.
Can I just say something?
I might,
There are some.
yes. You have to
Doctor,
confirm.
no. There are some,
been removed.
in our experience at least, there are some lesions which are seen on a contrast mammography or on an MRI and are not seen on regular mammography. So they are seen on ultrasound because then on second look ultrasound, you localize the lesion. Then you put a wire into it or a clip into it, whatever, you remove it. Then probably, yes, mammography is possible. But that you have removed the clip.
But you'd
But
still,
you will not be able to see the lesion.
no, but you'd still do the X-ray to check the clips out.
So that's why for our situation, a frozen section establishing that yes, there is the lesion in your specimen
no,
is important.
John,
No.
So
if you are using
I suggest
Yeah.
your
no, if you had said specimen radiography should be done following surgical excision of all non-palpable localized by mammogram. If it is,
No, because
you
you
do
have
the
to
same
confirm the
tool.
clips
You use
out.
the same tool that you localized with.
No,
If you've done an ultrasound localization, use an ultrasound. If you've done a mammogram, localize like mammogram.
Yeah, okay. Finish.
we don't have a radiologist and an ultrasoundographist replace radiography by imaging. I think there are indeed occasions where a non-X-ray approach might be available, and there is now a new tool in town which uses a nuclear imaging technique where you can go much finer and evaluate at the same time in the imaging.
Okay,
the
but it's kind
margins.
of way, it's the
Exactly, just
principle.
replace it by
You have to confirm that you've taken a lesion out.
yes, but with imaging point, not
if you have accurate localization with MAC seed, you don't X-ray it because you have the probe to tell you you've taken the MAC seed with the lesion.
Yeah, okay. Well, specimen imaging then, or we, you know.
That's what I'm saying.
Anyway, okay. We've debated that ad nauseam. Can we move on to the next question? This is very interesting. I suspect, yes, we overstage patients, I think. Especially, I think here you do a lot of PET scans, actually. Okay, if you just finish off voting and then we can get the result? Yeah, Philip?
No.
Okay.
So okay, so in the ESMO guidelines, it was nearly taken out. It was put in again that it is not indicated. And look at the outcomes in the European countries for stage early stage, these ones, then non-metastasized, more advanced stage, and then altogether. The Netherlands does worse than many other countries for the very early stage. does a little bit better for the advanced and does significantly better for the overall, because it's a Will Rogers phenomenon.
Yeah.
Once you're gonna overstage a very early stage, you move them from stage 1 to stage 2 to stage 3,
Yes.
and at the end, everybody does better.
Yes.
So as long as it's not proven that, like Michael said, indeed, a certain percentage will be demonstrated to have more advanced disease, as long as it is not proven that this will impact on your prognosis.
Yeah.
And the issue is also all the overdiagnosis leads to the non-relevant lesions, which cause a lot of stress, a lot of other exams, and sometimes even lethal complications.
Yes. 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 Yes.
Yeah.
Yes. Yes. Who would generally stage for tumors more than 5 centimeters or 4 more nodes positive? Yes. Yeah, but mainly for those. That's what I'm saying.
Then you put very right those who are eligible for primary systemic therapy, that are the high risk patients. Yes, there I agree. That's a little bit different.
And also I think the essence of the question is that how many patients you are going in actual fact to have a stage by staging them. So you are probably going to do expensive staging for 100 patients to pick up 3 or 4 who are asymptomatic.
Yeah.
Actually true. Yeah. Okay. Next question.
That's what we call a homozygous surgeon.
Yes, I'm not sure why we had this one in, but anyway. Yes. I think we're sort of yeah.
I think also who are suitable. I mean, I think it should be everybody going mastectomy should be offered, and then
but some of them are not suitable.
Already said that.
Yeah. Yes. 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 But there are also people, for example, with mental health issues, alcoholics who are not very compliant. And you have to be cooperative if you have immediate reconstruction. So, okay, have we got a result? 19, we've got 21, okay. Fine, okay, so that's, can I just ask, um,
Yeah, because see, I think it's cultural. In fact, it's like this. Uh, Strangely, I know it's not nice to make this comment, but really, uh, repeatedly we hear it from patients themselves in our OPDs when they are 70, 75 plus. They never are interested in reconstruction. So it is, yeah, yeah. But that's what I'm saying. It's yeah.
But that is but that is exactly why I said it shouldn't be who is suitable. Every woman is suitable for reconstruction unless she decides she is not, or you decide it is very harmful. But that is a discussion you have after you offer the reconstruction. And he said, but you are 78 and it's not working.
No,
but you
no,
don't want to give
no,
a child a
no.
toy and
I'm
then take it
sorry.
away.
I'm
So,
sorry.
yes, yeah. Yeah, that's a bit of a cruel approach, I think. Shall we move on to the next question? Okay. So this is lobular cancers. So yeah, this is always a slightly controversial. The issue of MRI and lobular cancers. So about have you voted, Ash? Yeah, good. 14, 16.
No, he's right. Edit and then.
Low pressure.
Okay, can we have the result? Okay. Oh, yeah. What's interesting?
That gives a wonderful discussion.
Yes, we should have put in an age here actually, because I think older patients, that's younger patients. We probably would
So,
always do an
can
MRI.
I comment?
But
Okay.
okay,
To you.
who wants to ask?
Yeah, just a small remark. Lobular cancers are more radiosensitive. And if you do a lumpectomy and the margins are clear, I don't bother about having not had an MRI. But I would not do partial breast irradiation. They're excluded from partial breast. It's whole breast irradiation, and they are likely in the next phase of guidelines be excluded from a boost because they don't need it.
Okay, okay.
So, lobular cancers, in my experience, we've had imaging missing, a standard mammogram missing the lobular cancer. They're very diffuse lesions. So, we've had surprises many a times. For
Yes.
lobular cancers, we now do a standard, we do an MRI.
Yes, yeah. We would generally do one, but for older patients who have very lucent mammograms and they're very obviously radiologically, confined lesion, no suspicion of multifocality, we probably wouldn't do an MRI.
And
Yes.
if we go
Yeah, I know.
if we go 40 years ago,
Yeah.
when we had the mastectomy versus breast conserving surgery, the patients who had no MRI scan for lobular cancer and they treated appropriately did not have any higher risk of local recurrence.
If they had breast conserving therapy, if they had a mastectomy,
No.
local recurrence risk was double. Exactly. And in Nijmegen, they did an evaluation of the use of the MRI. It
Yes.
increases the mastectomy
Yes.
rates and it has no impact on overall outcome.
Yes, and the COMIS trial also showed no reduction in rates of re-excision either.
No, including lobular.
So if you
Exclude, let
don't,
me put it differently. If you exclude all the other cancers and look at lobulars, it makes no difference.
but there's a logical sequence in all your remarks, because if you say that after mastectomy the lobulars do worse, that's a fact. Then you say you do an MRI that will increase your mastectomy rate, that's a fact. But the consequence is do breast conservation, don't do an MRI, because that's the optimal outcome for the patient. You're not going to cure anybody because you do an unnecessary mastectomy based on an unnecessary MRI leading to unnecessary radiotherapy.
Yeah, but we cannot actually again follow the issue about it's not going to make a difference to survival. If there is higher rate of local recurrence, that is unacceptable practice. No. But in ignoring gross multifocal disease, that's different. What we are talking about is the multifocality or unifocality.
Yes. Yes. Yes.
Mammogram and MRI scan in patients even when it is indicated. So you want to drop
But-
them.
Yeah, that's what. No. I'm saying in this situation,
Yeah.
if you have an unclear situation or you have a dynamic situation, neoadjuvant treatment, then you do it. But that's a clear situation.
Yeah.
So MRI in a clear situation will unnecessarily increase mastectomy, will not change survival.
Okay, but yeah. I think most people, if they were doing breast conservation with a level 2 oncoplastic procedure, would want an MRI first. Okay, shall we move on to the next question? Genetic testing. Yeah. So our thresholds for genetic testing, I think, Ash, they fell in about 2015 from 20% down to 10% when there was a chance of having a BRCA1 or BRCA2 mutation. Mm, mm. Yeah, we're doing a lot more genetic testing. Yeah. Okay, results, yes. Okay. Yeah. Yeah. So obviously,
So I voted no.
yes.
And I will be very clear, unless you are ever stage 1 and or below 40 years of age, it doesn't impact on your prognosis. If you have a 50 years old with a stage 2B or a 3 tumor, whatever you do, it will not impact. I would do it maybe 3 or 5 years later when she's still disease-free. Then you can discuss a genetic testing, because then it can have an impact on subsequent management.
Yeah, but it may influence primary surgical therapy. wouldn't
That's
it?
what I say. If you have a stage 2B or 3,
Yes.
independent of the age, primary surgery, a mastectomy is not better than breast conserving therapy. Absolutely
There
not.
there are many few points against that. Number one, we excluded the patient decision out of the equation. We decided for the patient, which is unacceptable.
Yeah, and obviously their family history.
Secondly, we do know that they have higher rate of local recurrence compared with sporadic cancer. So that's very important for the patient to say, I'm not going to wait until I have this. Thirdly, in terms of the actual fact survival, if they present with early stage of the disease, the contralateral risk reducing mastectomy makes a difference to survival. No?
Well,
I'm sorry.
I can
Sorry. That's simply not. It's simply not true, because we have. No, I'm sorry. I respect your opinion, but the facts are against it. Presented this year in San Antonio. Many thousands of patients. Yes, you cut in half the contralateral disease. You're not at all affecting overall survival, neither from the primary nor from the contralateral. And what in mutated patients. So the Angelina Jolie push was a fake. And it's perfectly logical, because any prophylactic risk reducing surgery, and I'm consulting my patients very open, because yes, I agree, it's their decision, but it will only take care of the future risk. It will not reduce the risk of the disease they already have. So the maximum risk reduction is actually in the healthy system of your patient and not in the patient herself. I'm not saying that it's not a good thing to do that if a patient's after serious consultation, but in some environments, BRCA carriers, and even more terribly, non-carriers are pushed into these prophylactic surgeries. And I think we should, based on the fact, and we now know for the first time, we really know 10,000 patients, no one survives a day longer.
If
you do that.
If you divide them to BRCA1 and BRCA2, what you are arguing is applicable to BRCA2 patients, but not to BRCA1.
Well, it's a pity Orit is not here, because she published a series of patients, breast conserving, known BRCA carriers, breast conserving therapy, mastectomy, and the high risk after mastectomy receive post-mastectomy radiation therapy. Those who had a mastectomy with radiation therapy, 0 recurrences. Those who had breast conserving therapy, equal to their non-carriers population, because they receive systemic therapy. It's only those who don't receive systemic therapy have an excess risk. And then those who had a mastectomy because of lower risk factors, no indication for radiation therapy, they had a very high risk of local recurrences after mastectomy with immediate breast reconstruction. And the issue there is, the surgeons are moving to flaps of 3 centimeters thickness, without trials.
Yes, yes, yes.
No, can I make a point? Can I make a
But yeah, I mean, if you've got
adjuvant olaparib? So that's a reason.
if you have a patient who's having primary systemic therapy and they've got a reasonable chance of having a gene mutation, it's useful to have that information by the time they come to surgery, because they may choose to have bilateral therapeutic mastectomy and a contralateral risk reducing mastectomy.
I
It can do, yes, yes.
and I
Yeah. Yeah, okay.
yeah.
Yes, yes. Right, okay, fine. Let's move on to the next one. Okay, so yes, okay, margins. Yeah, I think we've got a consensus on this already, haven't we? We want to vote quickly on this one. Um, I think I sort of Ash was saying yesterday that everybody knows the answer to this, although ABS haven't formally changed their guidelines yet. So 18. Okay, last couple more to vote. I don't know. 18. Okay, do you want to show the result? It's stuck on 18. Yeah. Okay. Oh, that's very interesting. So we've got nobody on 1 millimeter.
Me. I'm brainwashed by the Dutch. The Dutch apply that since nearly 15 years. And indeed, there is an effect in recurrence risk, but the overall recurrence risk, also in those with closer margins, is way lower than 15, 20 years ago. Their rate of recurrences, I have to check, but it's around 3% at 10 years now in breast conserving surgery. And the 2 millimeters is all. The aim is always to do a wide excision. But when the margin is smaller than 2 millimeters, the no tumor on INCT is already accepted for something like between 12 and 15 years in the Netherlands.
Okay, interesting. Yeah. Okay, but everybody else is 2 millimeters, I think, for pure DSOs.
There are people who believe in
One, yeah, only one the most. Okay, well.
I agree with you, but I didn't vote.
We haven't got some because we're staying here. Okay. Okay, shall we move on to the next one? Oh. Yes, we're completely excised with a 2 millimeter margin. Mhm. And it should be considered, not necessarily given, but considered. And it's most patients, not all patients. Okay, I think we're on 20. Yeah, that's not bad. Yeah. Okay, shall we see what the result is? Okay, so just one abstain. Can we just ask on the abstainer what the issue is here? Do we know? Does anybody want to comment on why they might have
I think
abstained?
it's true. Just for as a thought provocation. I have very modern radiotherapists, and they start stopping radiotherapy for low-grade, smaller DCIS if adequately excised. Now, most patients we were discussing is that 80%, 75%, or what is most. Probably for most patients, it is a yes. But I abstain because I think the door is opening to omitting radiotherapy from smallish, low-grade, adequately excised DCIS. But
Yes.
it needs to be shown. that
Sure,
it's-
sure. I mean, we were going to confine this to intermediate and high grade, weren't we, Sarah? But
Yeah,
I got outvoted.
I abstained because it says all or most, but does not qualify the grade. So for low
Most.
grade, completely
Yes.
excised.
Yeah. I mean, does any, well, I mean, you don't have a lot of low grade DCS here anyway, I don't suspect in India, but, yeah. Pardon? 2 millimeters. Yes. 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 Can I just ask for the? I think we did discuss this previously. For the high-grade lesions, is there a size below which you would not give radiation treatment? I mean, what about 5 millimeters, for example, 4 millimeters? You know, we sometimes exercise some discretion. Yeah, can you use the mic? Yeah, sorry.
It's the ECOG study we mentioned whenever it was 2
Yeah,
days
which
ago.
had 3 millimeter margins.
Yeah, but they still had a high recurrence rate.
They had minimally 3 millimeters. In reality, they had 10 millimeters margins in the grade 3.
Okay.
So for
okay.
recruitment,
Yes,
eligibility
yes.
criteria was minimum 3 millimeters
Yes.
in the grade 3. Yeah?
Yes, and it was up to 10 millimeters, I think, for the
Yes,
grade
but
3, wasn't it?
the mean
Yes.
size was
Yes.
5 millimeters, and
Yes.
the mean tumor-free margin was in more than 80% above 5 millimeters, and in half of the patients above 10 millimeters.
It was a very surprising result, I think, to
Very
everybody. Yeah.
much more recurrences
Than
than
anybody
anybody would have expected.
And also there is the factor that you don't include in the size the amount you remove during the biopsy.
Amount during the what?
Remove during the VAM biopsy.
Well, you should. I mean, you should
Yes.
take the microcalcification.
Now, that's a good one, because in general, if the DCIS is biopsied
Yes.
and you don't find anything in the lobectomy, those in general, I say, let's follow up.
Yes,
Let's
yes,
follow up.
I would agree with that. Yeah.
Not if it's
I'd
high
one or
grade.
two like that.
Not if it's high grade, it's high grade. If it's small and
I
you completely
agree, but
remove it with your fab, then it's it's a small focus, and then you need to go back and look at what the grade was on the VAB.
Okay, so Sarah, just to clarify, there's no size below which you would not give radiotherapy, though, for high grade.
For high grade, no, I'd give it.
Okay,
For it,
that's good to know.
Oh, yeah.
Okay.
That's I do what Ellie says. She's in charge when it comes to radiotherapy.
No. Okay. Right. Next question, please. So, oh yes. Okay. Yeah. This is the other controversial area. Yeah. So, do you want to get voting? I think we're 3, 6, 9. So I think perhaps a couple more to vote. Yeah, I think we're on 18. Yeah. Okay, shall we show the results for that? Okay, 80%. Oh yeah, okay, 10%, 10%. Yeah, so that's interesting then. So, people are sort of generally advocating endocrine treatment then. As I think I sort of implied yesterday, we generally don't use a lot of endocrine treatment in the UK for pure DCIS. Does anybody want to sort of
No,
comment?
I abstained only because of the oblique chemoprophylaxis. So I mean, we don't do chemoprophylaxis.
Well, it means the
routine.
prophylaxis of the contralateral breast. That's what it means.
Yeah. Well,
Prevention.
I wanted to write yes, but then I abstained because we don't use it
I think we all agree.
So,
That's a very.
so
I'm sorry. Go
it
ahead.
will prevent the contralateral breast recurrences also. So those patients who would have a DCIS, they will be at risk of developing breast cancer in future in the ipsilateral or the contralateral breast.
Yeah.
So it will be acting as a prophylaxis, you could say.
Yes, but the fact is that the trials, the B24 and the UK, Australia, New Zealand trial, did not show a benefit statistically from endocrine treatment.
But
so that's a problem that we have.
But
No, but
And also this Sloan chart.
the
didn't
statement
either.
is should be offered or not.
yes, I think
Should
that's
be
important. We all agree that it's not 82% of patients getting this treatment for 5 to 7 years. Should be offered
offered.
based on IBIS-2 and others. I think we would also all agree that we have a very limited side effect threshold. We are not punishing these patients for 5 years to get that. But if patient tolerate it well, just take the IBIS-2 benefit and run in terms of prophylactic. And baby time, maybe
I mean,
even. I'm
the
not so sure.
prevention trials, like Jack Cusack's, have shown that it reduces the risk of breast cancer. Yeah, exactly.
Yeah, no, but those were done on patients who have a very strong family history and this kind of thing. It
They
wasn't done
also
on.
no, they
I know they
included
included
BCIS.
some of those,
Yeah.
but not in very large numbers.
That was yeah. So I think it's not correct to say that there's no benefit from clinical trials.
Yes. Okay. So. Yes. So I'm still not clear who we would be offering it to then here.
But this is not. This is a matter of. It's always also when we have patients' wish. You find it, and it's a showstopper for discussion. Meanwhile, which it shouldn't be, because the patient's wish doesn't come from the Lord; it comes from the communication with us. So, for example, I don't accept patient wish for a mastectomy indication. I've never seen in 36 years of treating breast cancer a patient who came well informed, wanted to have a mastectomy. Yes, informed in error. It would be safer, it would keep the metastasis away. That's all fine. And the same here. If you have a patient on endocrine treatment and she comes and say, I have hot flashes and my joints are aching, you say, okay, stop it. That's different from sit down. How old are you? Let's do a drug holiday. Oh, the joint pain is still here. Maybe you're getting older. May not be the pill. So you can fight for a treatment or not. So when I said low threshold, I mean, we would be more quickly accept that than in a luminal T3 cancer, where we know that we cut
Yes.
away half of the recurrences.
Yeah. So, I mean, I don't know how often the Van Nice index is used, but I suppose if you got an index 7, 8 or 9, you might consider adding in endocrine therapy there. But, certainly in my, the experience of my practice and most of my immediate colleagues, it's used very, very selectively, often in patients who don't want radiation treatment.
I think also we have to remember, if we are advising patients on basis of information, the easiest way is to look at the indication in the prevention trial. It will actually set the way for you.
Yes, but as you know, chemoprevention has a very, very low take-up, doesn't it? I mean, it's only about 10 or 15%, I know, in the United States. But
Patient wish will be taken into consideration when we counsel patient chemoprevention. The first, this is a soft option.
okay,
I don't want
okay.
So can I
Okay,
just say, I
so-
think the reason it's not
Sorry,
taken up is
sorry,
because
sorry.
we don't offer it to them. If you don't offer it to them, they're not going to take it
No,
up.
no. But I'm talking about the take-up. This is where they have been offered it, but they haven't taken it up. And there's no. But in the United States, they have done. There's published studies. Yeah. So so when you give endocrine therapy for these patients, are you kind of selling it chemoprevention of the opposite breast? Is that the largely? Yeah, that's interesting. Okay. Right. Let's move on to the next question. So multiple invasive cancers, multifocal or multicentric. Oh, all right. I think that's fairly straightforward.
I agree.
Oh, I've got 21 now. Shall we show the result for that? Yeah. Can we ask then the person who's voted yes? Is it you, Hisham?
No. I say I wouldn't ask.
Okay. Okay.
Next
Fine.
question.
Okay, with definite consensus. Okay, shall we move on to the next question then?
This is the takeaway, so it should be done.
So just so we're not being too exclusive down here at the front. For those of you at the back, you're very welcome to make any comments. Perhaps we can keep some microphones at the back of the room so that you can sort of speak up if you wish. So don't feel excluded. Um, oh, okay. I don't remember seeing this question actually. Uh,
I just would like to add that there was an ERTC trial number 10873. It failed to accrue sufficiently, only 106 patients. The primary investigator was Erik van Limbergen. They published a series, small series, where the patients even did not receive surgery, only a biopsy, and then whole breast irradiation with an electron boost to the nipple. And they had 2 or 3 local recurrences on the more than 100 patients.
Yeah. So.
Hmm?
Next one.
I agree on that, but it supports that you
Yeah.
don't need to do a mastectomy.
Yeah. But it was probably confined to the
No,
nipple.
it's radiotherapy, yeah. Yeah.
Yes.
But certainly, let me defend Philip here.
Yeah,
We
so
have
central segmental
as
mastectomy
Curie
has
has shown
become more
30 years
popular
ago that you can substitute
recent
breast
years.
surgery with
Or,
radiosurgery. That's not very popular.
Yeah. Or a Grisotti flap is quite a nice operation. Adnan, have you done Grisotti's for Paget's disease? Yeah. Okay, next question. Yes, okay. That's a good one, I think. Okay, I'll just give you a chance to vote. That should be or sentinel lymph node biopsy, not plus. Yes, at presentation, yes. Yes. Yeah, that should be at presentation. I think we've got some transcription errors here, actually.
But I think can I make another very clear comment here? I was astonished earlier today when I stepped into the session and there was still a discussion about the excision of the previous tumor bed and everything. I think what we have really firmly established is after neoadjuvant treatment, we treat the disease at hand, not the previous disease. And that's true for all modalities, for surgery, for imaging, for radiotherapy. Whatever nodes were enlarged or something, we treat the disease as it is, because that's the whole issue of the neoadjuvant approach. So there's no reason to mentally go back and say, yeah, well, last year we found something in the lung and it might be a stage 4 disease. No, Now it's one node, two nodes. That's what we do. Say again? He always agreed with me after I educated him about some data. So now no, we respect each other.
Okay, fine. Can we have the voting result? Okay. Oh, it's interesting that. Oh, so
Yeah, I'll have to admit, I said no because, um, yeah, I think over here the general feeling, and I'd like Nikhilesh you to say, if there are a number of normal nodes at the start. I know Professor Grant has just said you don't have to go back into the past, but we've burnt our fingers, and then we have residual nodal disease. I think that's too much of a risk. I would, if you have a lot of abnormal nodes at the start, I'm sorry.
well, yes. So, okay. Do you want to say?
Either no, either we agree to believe the evidence or we forget all this discussion.
Okay, just hang on a minute.
If
Hisham,
I'm
can we
saying
just-
that the we accept TAD in 3 nodes, I can see no biological reason why we don't accept it in 6 nodes. Because the response of the disease is not about just volume, it is about biology. If you got the node and you believe in TAD that it will give you the full information, then it doesn't matter the number of nodes.
No, well,
Is there evidence for this? Is there evidence?
Sorry. Can I just? Sorry, excuse me.
That's what
Can we
I'm-
just?
okay. But is there evidence for this? Because we have always been taught if it is 2 to 3 nodes, and then you give chemotherapy, and they completely respond, and you can do a sentinel node. But for multiple nodes, which are maybe even 10 in number, are you suggesting that we can still do a sentinel node if there's a complete response?
No.
But where is the evidence for that?
Okay, can I just bring in my colleague
I
guys?
Sorry, just a quick question for all of those of you that said yes. So you're heavily node positive and you can become node negative, and you're doing your TAD. What are you doing with your radiotherapy? Are you irradiating? Giving nodal radiotherapy instead, or are you just doing the TAD? You're just doing the TAD and nothing else.
So I want to.
You're
negative. Exactly.
even if you were a level 2 and 3 were positive beforehand, you don't mind.
I think the question should be.
But where is? I have to say, I really don't see where the evidence for that is at all.
Okay.
Yeah.
So
in this situation. So
Yes,
can I?
but we have to do yes.
Can-
Ash, can I just bring you in and then I'll make a final.
I think the only way we will get an evidence is if we have a follow up and say these patients do not have a higher relapse. What we have is, can you do it? You can do it.
Yeah.
But after doing this, you have a positive node or a negative
Yes.
node. What's your next decision?
Yes.
Is the final decision.
Can I go first? I'll go first. So, I mean, obviously, whilst we're introducing procedures like TAD, we're de-escalating management of the axilla after neoadjuvant chemotherapy. We have to do things safely. So, we do have a national trial called the ATLAG trial in the UK. And, so if there are more than 3 abnormal nodes on imaging at presentation, we would recommend an axillary lymph node dissection, not for a targeted axillary dissection, because the reasons that we've just said. What are you going to possibly then do in addition to the
Can I just comment on 2 things? One, if you look at as we said, that the ultrasound scan in the group of patients where they accept them for TAD, there is at least 25% of these patients are underestimated the axillary disease. And yet we accepted them because we are ignorant about the disease. The second thing, guys, it has been our practice for the last 7 years to do total axillary clearance based on the number of nodes. And we looked at the correlation of TAD to the axillary clearance. When the TAD is negative, there is no residual disease. So I'm not going to wait for the result of recurrence because I have the evidence that the nodes have been clear.
Simple question.
Yes.
That is what? You're removing all the clips nodes. 1 minute. You're 1 minute. Only one name. If you have 10 nodes positive, you'll clip 10 nodes, right?
No, you only clip 1 node.
What? No, no. I don't think there's any evidence to suggest that we don't do an axillary clearance when there are more than 3 nodes positive. But this thing we are trying to change that by, but then where is the evidence for that?
The question is that when you have 3 nodes, you don't clip the 3 nodes. So you are accepting that the localized node is enough to tell you whether the other 2 nodes have been cleared or not. So why you accept it when there are only 3 and you don't accept it when they are safe?
I think that the general issue of de-escalation puts us in a position of discomfort. Can we really do that? Remember my 13 centimeter case, where we eventually did breast conservation because we couldn't believe, can this be true? Is the tumor really gone everywhere? Are we putting additional local regional risk on the patient? The concept of de-escalation means that gap between knowledge and hope is not put as burden on the patient, because otherwise we give all the unnecessary chemotherapy, we do all the unnecessary axillary clearances, we do all the unnecessary mastectomies. So de-escalation means that we live with some of the discomfort and saying, maybe it might be too dangerous to do this, but let's still, within the corridor of believing and clinical trials, hopefully move ahead. So I agree, it could be wrong, and nobody wants to have axillary recurrence increase based on that. So I think it's perfectly fine that not everybody finds him or herself on the same position within that corridor. As long as we agree on the corridor, I think that's fine.
Okay. Okay. So I think we'll move on to the next question, if we don't mind. Next question.
No evidence to.
Okay, so I think we've alluded to this earlier in this morning's session, actually. Yeah.
Oh, yeah.
No pressure on voters. The democracy.
Okay. Fine. Shall we get the results?
Yes.
Yes.
No.
So, 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 so,
Next question.
yes. Yeah. Of course, they could have a baseline MRI, but then you use another modality to monitor the response. But if you're doing breast conserving surgery, it's certainly useful to have an end of treatment MRI, in my opinion. Hmm. Yeah, yes. But I think I might have actually, when you're at the Marsden, don't they do an ultrasound at the end of chemotherapy, not an
Do
MRI?
an MRI.
Right, right. So that's
We have the best of both worlds.
I voted.
three times an MRI. Is that part of a research protocol? Okay. No,
There
no,
is
no,
a lot
wait,
of
can I
variation in
just
the
say,
UK. There are centers that do perform MRI routinely to assess tumor response, and that's the reason we put this question.
Yes.
yes, yes.
And I think we must not mix this up with the primary MRI issue, because we are fighting against excessive primary MRI. When you assess because response to neoadjuvant systemic treatment is the most important dynamic biomarker we have. So when you start assessing this at baseline with MRI, I don't think it's a bad idea to have the MRI before surgery, just for the assessment of response, not for surgical planning. And when you start with the mammography, do the mammography. When you have high quality ultrasound, do the high quality ultrasound. The response to neoadjuvant treatment is the most important dynamic biomarker we have. And the MRI is now 200 euro in my environment. I don't know. It's not as expensive any longer. Just don't do more mastectomies because you do more MRI.
Yeah, yeah. Yeah. Okay. Next question. Thank you. Well, I don't know. I don't recall seeing this question actually. Um, yes. I don't know what it means actually. I mean, it depends on how you define oncoplastic breast surgery. Um,
All is wrong anyway, actually.
I don't know. I'm distancing myself from this question, I think. Okay, so if we could just finish off voting on that. So if you want to abstain, you're very welcome to. Yeah, absolutely. Okay, we're stuck at 15. Shall we see what result we've got for so far? No, it's just one, yeah.
We can move to the next one.
Okay. Yeah. Good. Yeah, I mean, there's some debate about whether somebody having a standard wide local excision always needs to have a level 1 oncoplastic readjustment of the surrounding breast tissue where you have to mobilize quite a bit. I mean, I don't routinely do that, but Sean?
It's about two things: eradicating the disease and giving the good shape of the breast.
Mm.
Call it plastic, call it grade 3, 5, 10, it doesn't matter. If a patient by straightforward lumpectomy is going to end up having bad cosmetic results, should be offered oncoplastic procedure.
Yes, yeah, yes. So do you always make a point of closing the surgical cavity after a lumpectomy? Okay, fine. Well, it's level 1 oncoplastic.
But that's in.
Yeah, yeah. Well, it's yeah.
Next.
You cannot actually say to the patient, sorry, we removed the lump, but I'm sorry, the shape of your breast.
No, sure.
Only those suitable
Okay, we'll move on. Yeah,
Let's go ahead.
let's move on.
Yeah. Let's move to.
So, okay, come on, let's answer all the questions standing on. Sometimes we can.
Yeah. Okay. So.
I'm going to be happy or you accept what was the because we won't get to those questions. Yeah. Quickly. So let's go to the next one. Yeah, answer.
Okay, we're up to.
We can move to the next.
Next one.
Yeah,
Yeah,
next one, please.
Okay, next question.
Fastest thing away. Come on. Resolve.
Yeah. Yes, good. Yeah, I don't know.
Yes, for yes.
Okay.
Supposed to how to make the creation that.
Okay, it's come now. Yeah.
Yeah, so we'd predict on this to see what the score was initially, and then perhaps a multi-gene assay depending on the result. No, not regardless.
Yes.
Okay, have we all voted?
Wow, very good. Yeah, correct.
Okay.
Absolutely.
Good. Okay.
Okay, next
Okay,
question.
next question. Thank you.
No, that's okay. I have on it.
Same, but instead of T and zero, we have
And it's a postmenopausal woman. Postmenopausal.
No, again, because we do go on the
Yeah.
Yeah.
Yeah, you can't really say why. I don't know why it's saying regardless of multi-gene assay, but anyway. Okay, let's just vote on it. I think I probably abstained.
No, it's HER2 negative. HER2.
Fine. Okay, so shall we 18? Is there anybody else?
Perfect.
Right. Okay, next question. Thank you.
No, no, but that's because it's unanimous.
I think I will do oncology more surgery. Chemotherapy and now
Yes. Oh, well, yes, I would say. Yes, yeah, definitely. Yeah.
Yeah. Okay. Okay, we all voted. Okay, let's see. Yeah, good. Okay, next question. Thank you.
Why no?
Yeah. Oh, yeah. Yeah. Who said no? Correct.
Well, there's only one. Well, yeah, but we've got the majority. Yes.
I think you don't say no because it says irrespective of. And the still people believe that unless you have a positive PD-L1, if you are not I know, but I'm saying some people still believe that.
But can we hear the people rather than
Okay.
anybody else?
Who's voted no? Yeah, according to Keynote 522, it was irrespective of PDL1 status. So who's voted no? Yeah. Okay, let's move on. Next question. No. Next question. Okay, so we'll assume the patients are up to 45 years of age here. Okay, 19. Okay, shall we have the result? 20, yeah, good. Let's have the result. Yeah. Yeah. Okay, next question. Okay. Okay, so this is metastatic triple negative breast cancer. Yeah, this is advanced breast cancer. No, but we took out the CPS more than 10. We thought it made it too complicated.
I just had a patient and 8 to 0. Hands down, people said no.
But it's PDL1 sort of positive, so it implies it's a CPS or positive or that.
Positive
Results.
CPS score could be one, could be more than one. So we are not going to follow that here.
No. I mean, I think from a pragmatic point of view, it's more.
But then we accept that the question is PDL 10 plus positive.
Yes. Yeah. Okay, are you voted all? So, okay, great. That's good. Fine, next question. Well, Hisham's being a bit quieter now. Results. That's an interesting. Yeah, of course. Yeah, this is another quickie. So, yeah, 100%. Yeah. Right, next one. Yeah. Okay, so this is primary surgery, but primary presentation, primary thing of the surgery.
Sentinel or
Yeah. So that result is from a sentinel or from a clear? Sentinel node. Yeah, I don't recall seeing that actually. That one. Yeah, it should just say positive sentinel nodes. Yeah. Okay, let's say yeah. Oh, let's say yeah. Next. Okay. Okay, 17 voted. 100%. Okay. Yeah.
Well, this is a big issue because, in fact, I vote, of course, also yes, because it was 100%, but we don't have the evidence. There are trials ongoing on oligometastatic directed locations and the primary tumor. Currently, they're not directly trials because it's commonly done, but it's not evidence based.
Well, the issue is that with, for example, resection of the primary tumor, we have 4 trials, including the wonderful from Memorial Tata. They all show the same. Don't do it. 2/3 of patients have it. And it's really not the crazy surgeons, it's the patients who have the response say, now there's this thing left. Can I get rid of it? And I think the trials for the other oligometastatic stuff, which is like, for example, single bone, everybody nowadays will do curative radiotherapy. So it's very difficult to recruit such a trial, and it's still a rare occurrence of that.
Yeah.
I'm not sure we're going to get a good evidence base for that.
Yes, yeah. But this is probably a slightly different question to whether you do surgery in the setting of stage 4 disease.
It's
I mean,
like
here we're talking about
yeah.
curative intent with proper margins of clearance and all that sort of thing.
High level evidence for the use of a parachute when you jump out of a plane is also difficult to
Okay,
obtain.
next question. Okay, this one I think. Abstain. Realistic. Okay, let's see. Okay, so we just yes, so 10% abstainers, 5% no, so that's 15. Yeah. Okay. Um. Yeah. Well. Okay. Next question.
Yes. No pressure, but we'll do it.
And register the patient in the oligocare study. Then you have at least registry of the data.
Yeah.
Okay. 100%. Wow, that's good. Okay, next question. Thank you.
What?
Okay, so these are previously untreated, chemotherapy naive patients with newly diagnosed brain metastases.
We follow the patient carefully. We offer radiation. When we come to the and there is a counsel specifically disagrees with that we will relate in the other things we also will look at how many where and what is the size. The where part is also like can be considered very still. Yes.
Yeah.
I don't know for that.
And I voted yes, by the way. But those patients, then they have one progressive metastasis, you give a stereotactic. Half a year later, another progressive, you give stereotactic, and you don't damage them like you do with whole brain or whole brain is really
I think we should. This is like
from
Yeah.
95%
Okay,
in
fine.
to
Okay. Okay, do you want to go to the next question?
I should answer the question actually. Yeah, I know. But it is a back now.
Yeah, is that was that the last one? Okay, fine. Good. Okay. Oh, thank you all very much.
So I think we'll just come. So shall we wind up? Yeah, come. Everything. Okay. I should. Come.
Thank you, don't Adam.
Yeah. So can I have your attention for just 3 minutes? Yeah. Yeah. Thank you everyone for coming and being here till Sunday afternoon. Still fighting. Yeah. Yeah.
Yeah, we should take a panel.
Yeah. We'll take
After
that.
he finishes thanking you.
No. No, I wanted to thank you, of course, for being here, but I wanted to invite anyone uh, from from the audience, from the panel, anyone, if they have any comments on how the meeting was. It was a kind of uh, a maiden experience, if you may call it, of organizing this sort of a meeting. But we just want to know if there were any shortcomings, if there was anything that anyone would like to say about it. Please, this is the time. We would request you to. Okay, that's good. Yeah, yeah, yeah. Anyone else? Any comments? No, they're still fighting over. Yeah. Okay. Okay. Come. Would you like to say anything to the people?
No, I'd just like to thank you all for making this our maiden event a great success. All the discussions, of course, are to be taken with a pinch of salt. There's no animosity. It's very not personal.
Yeah.
Uh, Thank you very much, everyone from India who came, from abroad who came, to all my friends who supported me. Thank you very, very much. There's nothing more I can say, and we will try and make an annual event. So hopefully, we'll see you all here again next year, and we'll have more questions coming from St. Gallen's that we can discuss. But let's see. I just wanted to show him we can do it once, and then we have to do it again. Come, we have to take a photograph. Hey, Hisham.
I just want to say, for Sir, it was maiden, but for me, it was most maiden. And honestly, it was an experience to come into a surgical meeting and to create a med-onc and a precision onc vertical. So it was a true challenge to match up because your schedule had already been created. And I had to match that by creating the med-onc and the precision onc and to do justice. And we had a great time in the parallel sessions. I'm very energized. I don't know whether the yearly thing will work out for us, but it was a lot of hard work from cleaning the floor to mopping. Everything was game. But thank you. It was all so enjoyable. So I have had a great time. And my big heartfelt thanks to two big stalwarts sitting right here through and through the meeting with me, and only gratitude for them, for my team, and for all in the room for making it here, especially to the ones who have traveled so far to make it so interesting till the last very minute. Thank you.
Just I want to add on behalf of the faculty and the delegates, and it has been fantastic experience in every level, from the scientific level to the hospitality to looking after us to meeting people. It was fantastically also friendly environment, which does make a huge difference to the outcome. But the quality, obviously, of the science was great. Thank you very much.
Thank you.
I want to thank each and every one of you for making this such a successful event and letting all our efforts fall into this being such a successful program. Thank you very much.
Yeah. I want to very heartily thank the main event. I see Rucha here. Rucha, I mean, Vama events. I mean, everything you see here, starting from the screen to everything you see here, everything you saw on the film was planning by Vama events. So, a very grateful thanks to you. A very grateful thanks to shout out for the where is Pranav? Yeah, Pranav Mahajan for the consensus questions. I think he did a great job.
Comments on his app, anonymous comments
Yeah,
for any process.
and of course, our hospital administration they've been supportive from administration, marketing, every department of the hospital has been just amazing. So it's great. All good things have to come to an end, but there's still coffee outside. So come, yeah, yeah.
A big thank you to the academic partners sitting at the back. Thank you, guys. Thank you for your support.
Thank
Yeah.
you, thank you. Yeah.
Panel for photograph.
Panel picture, come everyone.
Everyone on the first 5 rows.
I think what we'll do is we'll stand down. We'll stand down. You stand down.
Where's your time? So this like I said, a 3 level. So one. You know, yeah, it's better go fast. I'll make it happen. Excellent.
Yeah, just stand that.
So we get all these social. Well, what's in this one? We're going to take one. That will be afterwards. Right. Yes, Profit sharing in the group. Thank you. Thank you. Coffee. That's for coffee. I haven't seen you make she knows my question actually. So if I know, if some try, they don't reduce the economy. Well, they don't know it. And it was an open trial. So what happened in general? Yes. But the first study is Arabic consideration for no it's yes, it's when that to be sure, which is but that's unnecessary. Yes, that was there. And if 760s, I've seen all studies. See long term what we do now.
I adopted the principle that we shouldn't do things for just to be